Good morning. I'd like to call this joint hearing of the Committee on Health and the Committee on Hospital and Health Equity to order. I'm at-large Councilmember Christina Henderson. I chair the Health Committee. Today is Thursday, February 8th, 2024. The time is 9:31 a.m. Today, we will be discussing the performance of two agencies, the Office of the Deputy Mayor for Health and Human Services and the Department of Healthcare Finance in FY 2023 and FY 2024 to date. This is a hybrid hearing. We do have some witnesses testifying in person and virtually via the Zoom platform. Deputy Mayor Wayne Turnage, who leads both agencies, will provide his testimony in person alongside his team. The Office of the Deputy Mayor for Health and Human Services supports the mayor in coordinating a comprehensive system of benefits, goods, and services across multiple agencies to ensure that children, youth, and adults with or without disabilities can lead healthy, meaningful, and productive lives. DMHHS provides leadership for policy and planning, government relations, and communication and community relations for agencies under its jurisdiction. It also manages two special initiatives, Age Friendly DC and the Interagency Council on Homelessness. DMHHS also oversees the administration's encampment clearing and closure efforts. The Department of Healthcare Finance provides health care services to low-income children, adults, the elderly, and persons with disabilities. More than 304,000 District of Columbia residents, approximately 45% of all residents, receive healthcare services through the Department of Healthcare Finance, Medicaid, and Alliance programs. Department of Healthcare Finance strives to provide these services in the most appropriate and cost-effective settings possible through the operation of the following 9 divisions: healthcare delivery management, long-term care administration, the healthcare policy and planning, DC Access System project management administration, healthcare finance, healthcare operations, healthcare reform and innovation, agency management, and agency fiscal operations. The committee sent written pre-hearing questions to the agencies, and we will reference those materials today. If anyone watching would like to see those materials, they can be found online at the DC Council website, dccouncil.gov/hearings. I don't see any of my colleagues here, and unfortunately, Councilmember Gray could not join us for this joint hearing. But shall I see any of them, I will turn to them. Before we get started, I want to review the testimony guidelines for public witnesses. Given the large number of public witnesses we have today, all public witnesses will have 3 minutes to testify. Again, as I've said before, that's not because we don't want to hear what you have to say, but we also want to make time to hear what everyone has to say. We also will have your written testimony for the record to review your full thoughts. To make sure we get to everyone, your name will be called when it appears on the list. If you were not available when your name is called, you'll be welcome to submit your written testimony. For those testifying in person, we'll do panels of 4. For those testifying virtually, we'll probably do panels of 6 or 7 if you want to sort of time out where you might be. If you're testifying virtually, you need to proactively accept our invitation to be promoted as a panelist when your name is called. All right. So I'm going to now call the first panel of witnesses. These folks will be testifying on the performance of the Department of Healthcare, on the Deputy Mayor for Health and Human Services, and then we'll hear from those testifying on the performance of Healthcare Finance. All right. So in person, we have Sharita Whiten and Eric Walcott. And let me ask, is there anybody here who intended to testify for for the Deputy Mayor for Health and Human Services who happens to be on the virtual list, but intended to be here person? No, all good. Okay, great. All right. When you're ready.
Good morning.
Good morning.
Chairman Henderson, thank you for having me. My name is Sharita Whiting, and my testimony today is geared towards bringing awareness to what we as DC residents face when we have a family member, especially a senior citizen, in need of help and services from the district. And more importantly, the independent agencies who receive funding from the district. My grandmother is now 98. At 97, she had her leg partially amputated. After raising 6 children in her home and retiring from DCPS, she had to deplete all of her savings in order to receive Medicaid to continue to receive health care and home health care aids. Our seniors should receive much more respect than this, especially when a nursing home or a senior home is sometimes subpar at best. My grandmother was released from Washington Home for Aging for her rehab to Washington Home for Aging for her rehab. This nursing home asked my grandmother to sign over her Social Security checks to them. Luckily, she has a family and we said absolutely not. But this bothered me to wonder how many residents there don't have family members and who are asked to do such a thing. Why would a 97-year-old be asked to sign over her Social Security check without a family member present? There are far more issues with this at this nursing home: security sleeping at the desk, patients yelling for nurses to be changed. Sadly, the nursing home takes advantage of these residents who don't have family members who are often there to see them and make sure that they're being serviced correctly. Moving on from the nursing home to the home healthcare aides, we have experienced tardiness, no-shows, and even an aide who committed fraud. This was very alarming to me because they clock in from their phones, and this particular aide showed up within the vicinity of my grandmother's home and clocked in as though she was there working, which she had not actually showed up for work. DC government funds these agencies, funds these healthcare aides, and the agencies that they come from. This is very alarming to know because this is just one aide who we experience, but how many other agencies have these aides and they're doing the same thing? I'm asking for more oversight because the fraud, the tardiness, the aides that come to these homes that go to sleep. I've taken pictures of the aides sitting in the house sleep while they're on the clock. And it's just unacceptable. For me, I do want to say on record that I do commend Deputy Mayor Wayne Turnage and his staff, in particular Kathleen Rogers, because there is not one email or phone call that I have sent to them that they have not responded to, that they haven't had an answer or a resolution for, or even looked into, especially with the fraud. They stepped right in to that particular healthcare aid agency and the person was terminated. So yes, I'm asking for oversight, but I'm also saying that I want to publicly acknowledge the work of Deputy Mayor Wayne Turnage and his staff when called upon. And they have definitely stepped up. I don't have one email that they haven't answered. I don't have one phone call that has not been returned. Thank you.
Thank you. Thank you so much for your testimony. In terms of, well, first off, you and I have spoken on numerous occasions since your grandmother's surgery. And if you had one recommendation in terms of what we should be doing, we as in DC government, to help families prepare for seniors who are reaching the point in their life where they need more care, what needs to happen? Is it more information? Is it preparation? Say a little bit about what you hope for.
I think both of what you said, more information and more preparation. We had no idea. My grandmother had never been sick in her life, thankfully. So we didn't know that her being a homeowner could jeopardize her actually receiving the Medicaid care that she needed. But then also, what do you do and how do you prepare for that? Because she actually needed to do things 5 years out in order to not have to have her house become a part or attached to a payment going to Medicaid.
Mm-hmm.
But who knew 5 years ago that she was going to need her leg amputated? You know what I'm saying?
Yeah.
So I think the educational part for our seniors, and I think educational will lend you and lead you into preparation and knowing what to do and be prepared for it. I think the district is doing what they can because you all are funding these independent agencies. You all also have expectations of what these independent agencies should be providing for the seniors. The problem is some of them aren't.
All right. Well, thank you so much for your testimony and for being here today.
Thank you for holding this hearing.
All right. So we're going to go to the virtual witnesses. I'm going to call everyone who signed up for Deputy Mayor for Health and Human Services at the same time, since there's not that many. So Jasmine Brazier from the Healthy Babies Project, Baruch Tami from Advanced Dental Care, Laura Puchak from Miriam's Kitchen, Ashley Ruff, Commissioner ANC 7FO2, Joshua Drumming, excuse me, and Dergere Brady. Again, you'll need to affirmatively accept our invitation to become a panelist. Okay, so the only person we have here is Joshua. So, Mr. Drumming, when you're ready.
Good morning. My name is Joshua Drumming from the Washington Legal Clinic for the Homeless. Since 1987, the Legal Clinic has envisioned and worked towards a just and inclusive community for all DC residents, where housing is a human right and where every individual and family has equal access to the resources they need to thrive. Today, I'd like to focus on encampments. Many encampment residents are surrounded by every belonging they own, including sentimental things to legal documentation. Some leave their encampment for an hour or two, and upon their return, their home is lost forever. This, unfortunately, is the experience of too many district residents. It is the order of things as set by DMHHS. Over the last 7 months, DMHHS has used their immediate disposition protocol 37 times. Immediate dispositions differ from normal clearings, as instead of a mandatory 14-day notice, the immediate disposition protocol allows DMHHS to clear an encampment without notice if it presents an immediate risk to health and safety. There's no notice on the encampment site or on the website. The legal clinic understands the need to respond to immediate health and safety risk. However, DMHHS abuses the health and safety risk language and wields it against encampments that are neither unduly obstructive nor have dangerous objects. Often, the immediate disposition is to remove one person from their site. In addition, the ambiguous immediate disposition standards, DMHHS has at times conflated terms, encampment clearing and encampment cleaning. The website and encampment signage may say cleaning when in actuality it's being cleared. This precludes encampment residents from adequately anticipating and preparing for a mislabeled clearing. Ultimately, immediate dispositions only re-traumatize encampment residents. Furthermore, seizures of encampment belongings during immediate dispositions without notice, the requisite risk factor, due process, or post-deprivation proceedings are likely unconstitutional and may lead to unnecessary litigation. We ask that Council evaluate the immediate disposition protocol and create legislative policies that standardize requirements and definitions related to encampment evictions, establishing due process for encampment residents and minimizing opportunity for random encampment evictions. Additionally, we'd like to see all full encampment clearings replaced by trash-only cleanings. A study found that encampment clearings cost between $1,000 and $6,000. This high cost will surely increase. Data indicates that homelessness in the district has increased by 12% and unsheltered homelessness has increased by 19%. The 2023 PIT count found 821 individuals in DC, unsheltered individuals in DC due to a variety of factors. Many unsheltered individuals living with DMHHS would deem an encampment. Using conservative estimates, this will likely constitute a 7-figure investment for the district. Council should know and be concerned with how much DC is spending annually to displace and traumatize unhoused residents. When budgets are tight, clearing encampment should be the first to go. The current administration seems set on eliminating all visible signs of homelessness. Unfortunately, unhoused residents and encampments are indicators of a failing system that displaces and dispossesses mostly Black and Brown people. This council has the ability to do better by establishing actual standards to govern immediate dispositions, improving shelter systems that dissuade far too many people from accessing it, investing in housing resources, and granting encampment residents the dignity that comes with due process of law. Thank you.
Thank you, Mr. Drumming. Since you're the only witness who's here on this particular panel, I'll just ask you a couple of follow-up questions. So when you say that, I think you said in your testimony, you feel like the DMHHS has been abusing the health and safety language standard. What is the suggestion you all have for tightening that up if you feel like it needs to be more narrow?
Yeah, currently DMHHS is really able to call anything a risk to health and safety. They can say that something is slightly too far into a sidewalk, immediate disposition. It is not the peak of cleanliness, immediate disposition. So I'd suggest council actually, codify standards that say X, Y, and Z constitutes an immediate risk to health and safety, and therefore from that the protocol can be triggered. Without that language, they'll continue to be able to call anything an immediate risk to health and safety and use the protocol.
Okay. Well, thank you so much. We certainly have some questions for DMHHS about the encampment clearings and closures that happened over the last year, but appreciate your testimony. Please make sure you upload your testimony on the council website.
Absolutely. Thank you.
Thanks. Thank you for being here. Okay, so we are going to turn to witnesses in person for the Department of Healthcare Finance. Heidi Case, Claudia Schlossberg, Veronica Sharp, and Leah Kaslas. Okay, I only see Leah, so I've got more seats. So let me keep calling. Ruth Pollard. Okay. Fernanda Ruiz. Right. Lindsay Niles. Lindsay's here. Let's keep going. Jacqueline Bowens. All right, y'all not used to people starting their hearings on time, I see. Gregory's here. Yes, all right. Anna Dunn. Okay, all right. All four of my seats are full. Great. All right, Leah, when you're ready.
Good morning, Chairperson Henderson and members of the committee. My name is Leah Kaslas. I'm a policy attorney at Children's Law Center and a resident of the district. I'm testifying today on behalf of Children's Law Center. We are troubled that over the past year, perinatal health and behavioral health outcomes have remained poor or worsened. We've seen an increase in preterm births, ACEs, suicidality, and more. Children's Law Center clients and their families continue to face persistent, sometimes insurmountable barriers that keep them from critical resources and therapies. In our experience, this is due in part to the lack of available providers for Medicaid beneficiaries across the continuum of care, from promotion and prevention to treatment and long-term supports. We believe DHCF plays a critical role in breaking down barriers and building a system in the district that supports residents from pregnancy onward. My oral testimony speaks to DHCF's responsibility to hold MCOs accountable for network adequacy, while my written testimony further discusses DHCF's multiple projects to expand services and incentivize better whole person care, including the reconvened Maternal Health Advisory Group, the integration of behavioral health services into MCOs, and the current 1115 waiver opportunities to meet health-related social needs and provide continuous coverage to children. We share DHCF's underlying goal for DC to be a jurisdiction that strives to ensure healthcare enrollment and expand access and services for all. To succeed in this goal, however, all initiatives must actually result in better health for district residents. It is clear there are a significant number of outputs, but from our experiences, this is without the improved outcomes. While we want DHCF to continue to be a leader of innovation, we also must hold DHCF and their sister agencies accountable to create actual meaningful improvements to our healthcare system, not just lists of projects and activities. For DHCF to start to see outcomes improve as a direct result of their work, they must address network adequacy, ensure accountability for timely access to care, improve rates and reimbursement, and implement workforce recommendations by experts. It is critical for DHCF to not only routinely monitor, but also enforce network adequacy. Meaningful measures of access should be required for MCOs and tied to accountability mechanisms that are regularly and transparently enforced, such as monetary penalties. We, however, are not aware of any enforcement measures being levied to date, despite recent external reviews documenting inadequacies. We therefore ask this committee to address with DHCF how they are holding MCOs accountable for network adequacy in the district for all areas in healthcare. We recognize DHCF is undertaking a tremendous amount of work to ensure healthcare access, but there is no access without a provider network. We ask that this committee continue to engage through timely oversight, as well as providing support to the agency in these endeavors. Thank you for the opportunity to testify today. I welcome any questions.
Thank you. Ms. Niles.
Good morning, Chairperson Henderson and members of the committee. My name is Lindsay Niles, and I'm a managing attorney at Disability Rights DC at University Legal Services. We are the designated protection and advocacy agency for the district. We appreciate the opportunity to testify. Since 2002, DRDC, among other organizations, worked with DHCF to develop a participant-directed services program that would enable people with disabilities to hire and manage their PCA aides without the need to rely on home health agencies. However, DHCF began implementing a 16 hours per day cap on self-directed PCA services, and resulting in enrollees authorized for 17 to 24 hours a day of PCA services, not having staff for those remaining hours. Accordingly, DHCF should amend the EPD waiver to allow for coverage for up to 24 hours a day PCA services under Services My Way. A DRDC client's experience of not having his 24 hours of PCA services staff since November 13th, which is detailed in my written testimony, is illustrative of the adverse impact of the cap and the infeasibility of DHCF's proposed solutions to staff the remaining hours through understaffed home health agencies. DRDC appreciates this committee's leadership in introducing the Direct Care Worker Amendment Act to respond to the workforce crisis. In its oversight responses, DHCF states it only has anecdotal information regarding staffing-specific gaps in care. DHCF needs to monitor the extent of EPD waiver beneficiaries are not receiving their authorized PCA services to model its Medicaid system to address these gaps. DRDC also has concerns that DHCF is not taking responsibility, despite its role as a single state Medicaid agency, to ensure that United Healthcare delivers needed EPD waiver services and that United adheres to beneficiaries' due process rights. Contrary to federal and district law, DHCF has taken the position that OH appeals that it has no legal responsibility when PCA service hours are reduced, terminated, denied, or not timely provided, because United is contracted to deliver these services. Additionally, United and other MCOs are failing to send legally required notices to enrollees of its determination of the number of PCA service hours authorized, or notice of their appeal rights, including failing to inform them that they need to exhaust the MCO's internal appeal process before they can appeal to OAH. DHCF must hold United and other MCOs accountable for failing to comply with all legal requirements applicable to long-term care services. Finally, we remain concerned regarding unlawful Medicaid terminations of people with disabilities. DHCF reports that approximately 21% of EPD waiver beneficiaries due to recertify on or before September 30th remain procedurally terminated from the waiver as of January 2nd. We requested that DHCF, at a minimum, stop terminations for those whose renewal has not been completed due to case manager neglect, while also at the same time continuing to work with these agencies to remedy renewal issues. DHCF has declined to make the requested changes, despite its own data of system-wide case manager neglect, to timely submit renewals by agencies which serve 96% of this population under fee-for-service Medicaid. We urge the DC Council to hold DHCF accountable to stop these terminations to maintain their health and safety and community living. Thank you again for the opportunity to testify. I encourage you to read my written testimony, which addresses these issues in detail, and I'm happy to answer any questions.
Thank you, Ms. Niles. Dr. Argros?
Good morning, Chairperson Henderson and members of the Committees on Health and Hospital and Health Equity. My name is Dr. Gregory Ardras, and I am the DC Hospital Association Board Chair for 2024, co-chair of the association's Equity, Diversity, and Inclusion Collaborative, and president of MedStar Washington Hospital Center. MedStar Washington Hospital Center is a 912-bed major teaching and research hospital. We are the largest private, not-for-profit hospital in the nation's capital and among the 100 largest hospitals in the nation. We are a referral center for treating the most complex cases. We are also the busiest and largest hospital in Washington, D.C. and the surrounding area. Our services help our community's residents get and stay healthy and help to improve patients' quality of life by managing chronic illness. One of our major programs is our Burn Center, which provides very extensive support for the entire region. And I would like to take this opportunity to thank the council for their ongoing support of our burn center renovation. I appreciate the opportunity to present testimony at the Department of Healthcare Finance's 2024 Performance Oversight hearing. The Department of Healthcare Finance is a critical partner in caring for the residents of the nation's capital. Under the direction of Deputy Mayor Wayne Turnage and Melissa Byrd, the department is committed to assisting providers as they care for Medicaid and Alliance beneficiaries. At MedStar Washington Hospital Center, we see firsthand the challenges residents face as the system seeks to provide the services they need to be healthy and thrive. DCHA and Healthcare Finance are partners in the delivery of care. Over the last 2 years, the association and the various agencies within the health cluster have been meeting in an effort to remove barriers to caring for our patients. As an industry, we are grateful for the department's attention to our concerns regarding challenges to discharge. There are many factors affecting our ability to discharge patients. Some are related to behavioral health conditions, housing insecurity, and socioeconomic issues. As a result of our collaboration, DC Healthcare Finance piloted a program with the hospital center to reduce the discharge timeline of complex cases. This work resulted in a significant reduction of extended stay patients medically ready for discharge. Earlier this week, DC Healthcare Finance and DCHA met with the care coordination teams at all of the hospitals in the district to expand this work and relaunch the effort, making it available to all hospitals in the district. Our hope is that through the growth of this initiative, we will continue our collective work to get individuals to the right level of care when they are medically ready for discharge, as well as the most appropriate care setting. We also thank Deputy Mayor Turnage and his team for committing to expanding access and the availability of intensive care coordination of our residents with behavioral health challenges. Increasing the availability, sustainability, and quality of community programs is critical to reversing the readmission cycle many patients face. Thank you for allowing me to testify today, and I'm happy to answer any questions you might have.
Thank you. Anna Dunn?
Good morning, Chairperson Henderson and members of the committee. My name is Anna Dunn, and I'm the president of Health Services for Children with Special Needs, also known as HSCSN, a Medicaid health plan licensed in DC. Thank you for the opportunity to testify today at the DHCF FY23 Performance Oversight hearing. Now, for over 30 years, HSCSN partnered with DHCF to serve children and young adults with disabilities in DC through the CASEP contract. We currently serve more than 5,000 children with special needs in DC from birth up to age 26, including babies born to our enrollees and youth in custody of DYRS and CFSA. We are the part of HSC Healthcare System, which is a subsidiary of Children's National Health System, and hold both care management accreditation and interim health plan accreditation from NCQA. Over the last year, we continue to work collaboratively with DHCF to ensure the health care of children with disabilities are met. Our care model aligns with the patient medical home model, and the value of our program yields results such as high EPSDT participation rate, effective management and delivery of services in appropriate care settings, and reduction in emergency department and avoidable hospital admissions. We thank Deputy Mayor Turnage and Director Byrd for continuing to address concerns impacting the unique needs of our enrollees and identifying policy solutions that allow children to receive SSI. As healthcare delivery market evolves, it is clear that value-based care is the future. Advancing value-based care remains an area of focus to DHCF in driving quality improvement and managing cost. As such, we have designed specialized pediatric-focused value-based care program and strategies that enhance provider collaboration in coordinating care for children, with a specific focus on kids who are high risk and medically complex. In 2021, we implemented a value-based care program with PHN, which is a pediatric health network that includes over 500 pediatricians within the Children's National and Children's National Pediatrician Associates at the Goldberg Center. This program covers more than 2,000 enrollees that account more than 60% of our enrollee population, and more than 60% of our total medical expenditures of our health plan. We look forward to opportunities in thought partnership with DHCF in further defining pediatric measures of focus in value-based care. The early identification of complex behavioral health conditions is essential to the physical, mental, and social well-being of children. We thank DHCF for recognizing it as a priority, as reflected in the Autism Spectrum Disorder policy changes in the state plan amendment. Behavioral health conditions are prevalent among our enrollee population, with almost half of our enrollees having a diagnosis associated with developmental delays. Given this, we have launched a targeted value-based care program with our ABA network providers to meet the holistic needs in managing kids with disabilities. In closing, we're committed to being a valuable asset to the district in improving our members' health outcomes. We strive to do this efficiently and cost-effectively while serving children and their families and making certain they have access to the health care they deserve and have a right to receive. We would like to thank this committee for your leadership and thank DHCF for the leadership on the health of district residents, and looking forward to continued partnership.
Thank you. Ashley, if you put 5 minutes on. Thank you. Thank you so much to this panel for your testimony and obviously for the work and engagement that you guys do on behalf of district residents. I have a couple of follow-up questions. Ms. Niles, I wanted to start with you around PCA services being capped. It is a little troubling to me to hear that when you all inquired about this, healthcare finances, we can use home health aides to fill the gap, especially knowing a week ago we had a hearing, 2 weeks ago, we had our hearing with DC Health, and the number of individuals who are even trying to be licensed or certified as home health aides in the district dropped significantly in FY23. Can you say more about how this has been going?
Yeah, I mean, we share your concerns about the 16-hour per day cap on Services My Way. The goal of Services My Way is for folks to be able to self-direct their care and hire their own home health aides to service their needs. And effectively, the cap has restricted unnecessarily their access to getting all of their hours staffed appropriately. And so one way that DHCF could address this, and I outlined this in my testimony, is that they could amend the EPD waiver so that they allow for up to 24 hours a day of PCA services based on medical necessity. And so these are folks that have been determined that they need these services to live in their homes, to maintain their health and safety. And so far, the solutions proposed have been, as you point out, is identifying another home health agency to do it, or asking your participant-directed worker to try to get hired by one of those home health agencies. And so there are a lot of factors outside of the beneficiary's control in order for the second option, which is not feasible, because there's a lot of factors, with the willingness of that participant-directed worker to want to be hired by a home health agency.
Right.
Things like whether the home health agency is going to bring on that staff, whether they're willing to staff those remaining hours.
Did they cite the reason for the cap as finances or something else?
Yeah, they didn't cite in the waiver amendment the reason that they wanted to cap the services at 16 hours a day. I mean, it is certainly, I think, more cost effective to cap it.
Well, I mean, cost effective how? If you're going to be hiring another agency to fill in to get to 24, is it really cost effective or efficient for, a resident to have two different people from two different, it gets complicated.
It's cost effective in the sense that there are gaps in care, because for the client that we describe, they have reached out to 14 home health agencies, and they've all said that they could not take his case. He recently identified an agency, but they still are unable to service his 24 hours a day. I think they're willing to service maybe 19 hours a day of services. And so they're not currently billing, right, for those unstaffed hours.
Right.
So it does, even though that's not the intent, does save money for the district.
Thank you. Thank you for your testimony. We're certainly going to look at your full testimony that you submitted for the record. Ms. Caslas, I wanted to ask a follow-up for you as well. You spent a lot of your testimony talking about network adequacy needing to be addressed. Are there some examples from clients that you want to share?
Definitely. Yeah. So for a lot of our clients, especially our clients that are in foster care right now, they're really struggling to access therapists. And more importantly, they're struggling to access therapists that are culturally congruent or are in line with what their needs are. And so having a young man wanting to access a male therapist, for example, right? And so we know that that really reflects the current workforce needs. And we know that that is a range that we need to see from all of our health agencies, right? This isn't DHCF alone, but DHCF as the contractor with the MCOs that are employing different health providers, there's an opportunity to work more closely and hold them accountable to who they're bringing into their MCOs.
Yeah, no, I definitely understand. It's interesting. Last year we started holding oversight hearings with our boards. And I asked, the board, all of the boards that we've talked to, especially Board of Psychology, and others, right? How do I get your members to take more patients with Medicaid? And they talked about the rates being so incredibly low. And I asked, okay, well, when is the last time that your board met with the Department of Healthcare Finance to talk about the gap and what's missing, especially if we're going to address the network adequacy? I feel like using the professional boards as a conduit to try to figure out, or a better pulse of what's happening in the field, I think is super helpful and something we haven't seen happen, but I'm hoping we can see more of. But thank you for being here. Dr. Argos, thank you so much. I know you're busy. And so I appreciate you taking the time to be here, and your comments around healthcare finance working with you all on complex discharges.
Right.
I know that this had been an ongoing thing that many of the hospitals have brought up in terms of, you have a patient who doesn't need the acute level of care anymore, but there's no place for you to appropriately discharge them to as a hospital, right?
Correct. That's correct.
And so we've been having these conversations, not only with healthcare finance, but also with Department of Behavioral Health, and some other entities as well, as around what's a step down protocol and how are we making sure that hospitals are not bearing the brunt of
Right.
all of this on their own?
Yeah, I would say that it's important for people to understand that the boarding crisis that we are seeing across the district and really across all hospitals in the nation is largely a reflection of that large group of patients who are stable to be discharged but have no place to go. And what has really changed over the last 6 or 7 years has been that relationship with healthcare finance, one that we hope to continue to expand with DBH around their support, which is absolutely critically important to ensure that we can get those patients to a safe level of care. I mean, the comments around the 18 hours of home health aid, I mean, that's part of the continuum that's required in the community to keep people from being readmitted to the hospital and coming back to the ED. It's those wraparound services which are absolutely critical to keeping people in as safe a place as they can, and keep them out of the emergency departments and the hospitals unless absolutely necessary.
Right. So just to underscore it for folks, let's say at MedStar Washington Hospital Center, what's the longest stay a patient has been there without needing, they're not in the recovery unit or something to that effect?
So we had a patient that was just discharged last week who had been with us for 260 days, had ended his need for acute services by day 10.
By day 10?
10. He was unusual, not that unusual because we have a lot of international patients that literally get off a plane and come to the hospital center. He had come straight to us from Liberia. So we were able to discharge him back to Liberia, identifying a safe place for him to go back there. But that's the extreme of what we have to deal with. I would say that some of the services that are needed by our most challenging psychiatric patients are such that they burn all the bridges at the psychiatric facilities we have in the district, which are limited. And it ends up resulting in us having to resort to send those patients to Maryland, where there are far more of those facilities available. And, two of our our patients that had the longest length of stay were well over 300 days in that circumstance. And they repeatedly were rejected by all the facilities in the district because of past behavior.
Yeah. All right. Ms. Dunn, I don't want to leave you out. I just want to, I appreciate your testimony for being here. And I hope that we could set up time to talk. I've met with all of the plans and I haven't met with HSCSN yet, although I've heard a lot about the work that you all are doing. All right. But I don't have any further questions for this panel. Thank you all so much for being here. Okay. Patricia Wiseman. Are you Miss Case? Okay. Of course. Yes, ma'am. Is Patricia Wiseman here? No? Okay. Is Robert Kennedy here? All right. Mr. Kennedy, if you want to take a seat. Okay. So for the folks online, sorry, we're doing a little jostling here. We had some witnesses who arrived after the after the fact. I'm going to start with Mr. Kennedy. Do you not want to go first? Okay.
Okay. Yeah.
Yep, you're good to go.
So,
You're on.
okay.
You just come a little closer to the mic.
Okay. Ms. Harrison, my name is Robert Kennedy, and this is the first time I seen you in person. I've seen you on TV a lot, but I also welfare. I've been here before. I used to live here, but where I live there because I do a lot of stuff here. Okay, my name is Robert Kennedy. I live in Ward 5 with RCM of Washington. I'm I retired from the National Relations Board. I'm gonna recap where I'm here. Medicaid. A couple of years ago, we protested in front of the Wilson Building for Medicaid and stuff like that. I've been hearing back and forth Medicaid. I think what year? I think it was this year, next year, they put the cut it. But most of the time, just some people tell me they're not gonna cut it. I'm here today because I want to make sure my age and the children, especially my age, I'm going to the doctor. Medicaid helped me pay my bills, the bill for the doctor and all that stuff like that. And I want to make sure it would stay for me where it's supposed to be and stuff like that. And I want to make sure everything is going well. I will recap with what I'm saying, but you have my testimony in front of you. I want you to really read it and see what I'm there here and stuff like that. And thank you for my testimony.
All right. Thank you, Mr. Kennedy. Okay. Ms. Case.
Hello, Councilmember Henderson and others in the room. I came to speak on one thing for myself and larger for our community. I've done a lot. I have been a staff support for Project Action, which is the disability advocacy group. We felt like we had to start our own disability community support group at the beginning of the pandemic. Robert, people from DDS and Project Action, but ADP waivers all across. So specifically for me, we worked hard to get the last person over services Whiteway, the company, out of here. We got GTI with all this promise, all this commitment. And in my story, they did not approve my budget for this year until January 22nd. I can't get whether that's GTI or Department of Healthcare Finance, but what happened is, therefore, staff weren't paid. They haven't gotten paid for any time in January yet. Their last paycheck, their new paycheck will be tomorrow. 2 weeks ago, they got paid one day, December 31st. Now, that was right before rent was due in February. I'm fortunate. I'm blessed. It's my wife of 40 years that's my caregiver. So she's not going anywhere. But other people with the limited aid situation, any easy reason to leave because they've got a multitude of jobs, some people can't go a day or two or whatever without care. I tried to raise alarm. I tweeted everybody in the council. I called Disability Rights DC. They would only look at it as an individual case, but other people, and I think it was January 12th, my GTA support broker said nobody in Services My Way budget had been approved by then. I don't know who it is. Nobody's talking, but I hope you will hold them accountable and find a better way, because people aren't on that service. They're on it, and they have to qualify for it because they need it. I want to, in my time up, just to share, there are stories out there. Home Care Services Long-Term Care Consortium is not inclusive of people with disabilities. I've gone, I've spoken to them. A lot of those providers, some of the people with disabilities, they're young. They need different kind of health care. They need people to help them go places, not who only want to sit at home. The disability community needs really aren't met by what's going on now. And I want you to hear that. There are more stories. If you or anyone else wants to be connected with people, I'd be glad to do it. Thank you for giving me that extra time.
Thank you. Thank you, Ms. Case. Ms. Pollard.
Good morning, Chairperson Henderson and members of the Committee on Health. I'm Ruth Pollard, President and CEO of the DC Primary Care Association, and I thank you for this opportunity. We focus our comments on the DHCF's opportunities to invest in the primary care system and on their oversight of the Medicaid managed care organization's value-based contracting requirements. Primary care should serve as the cornerstone of healthcare delivery, offering preventative service, early disease detection, and management of chronic conditions. By investing in primary care, we prioritize patient-centered approaches that emphasize continuity of care, patient education, and holistic well-being. Ultimately, investing in primary care not only enhances individual health, but also strengthens the resilience and sustainability of healthcare systems, laying the foundation for healthier communities and societies as a whole. Despite its importance to overall health and well-being, primary care spending is in the single digits compared to spending on specialty and hospital care. DHCF has opportunities to increase investment in primary care, including the 1115 waiver for health-related social needs that includes resources for primary care infrastructure, several CMS primary care focused initiatives alternative payment methodologies for federally qualified health centers, and a managed care quality strategy that requires reporting on and increases in primary care investments. We look forward to further progress with DHCF and welcome the opportunity to brief this committee on defined strategies for improved primary care investment. In pursuit of these better outcomes for patients, 7 FQHCs and the DC Primary Care Association established the DC Connected Care Network, or the CCN. Combining these services, partnerships, and practice cultures of our member FQHCs, the CCN will establish a continuum of care that addresses the diverse needs of each patient. For us to achieve its goal to create capacity for care management, coordination across the sites, and capacity to address social needs, the CCN needs the support and engagement of DHCF and our MCO partners. Most importantly, we need DHCF to develop a standard MCO value-based care contract that includes guidelines for the quality measures and require a guide path for total cost of care contracts. Alignment across these payers is essential for the kind of systems transformation to improve health outcomes and advance health equity. Our member health centers, upon which so many residents impacted by inequity rely, need DHCF and its MCO payers to engage in proven strategies for value-based care and improved health equity. DCPCA and our member centers are very grateful for the partnership with Deputy Mayor and DHCF Director Wayne Carnage and his staff. And we believe that there is a collective capacity to build the system. Thank you.
Thank you. Ms. Reese?
Good morning, Chairwoman Henderson and members of the committee. Thank you for the opportunity to testify today. My name is Fernandez Reese. I am the Home Visiting Director at Mayor Center, a member of Under 3 DC, and a district resident from Ward 4. I am here today to provide testimony regarding Mary Center's new partnership with DC Healthcare Finance to implement the Nurse Family Partnership Program and the sustainability of the program. Yesterday, we received the notice of grant award from DC Healthcare Finance for the 2024 First-Time Birthing Person Home Visiting Grant for $225,000. As you are aware, NFP is a widely research-proven, evidence-based home visiting model that supports first-time mothers who are facing financial barriers. DC Council and DC Health made this possible in fiscal year 22 through seed funding with a total amount of $150,000. Mayor Center has secured an additional $2.2 million through private foundations and NFP to pilot NFP in the district for 3 years. The community has received well the NFP program, and we're happy to report that to date, we have served 96 mothers and welcomed more than 57 healthy babies. We are excited to continue to partner with the district in offering NFP to more mothers and their children in the district. However, all funding for NFP, both public and private, ends with the fiscal year. For this reason, it is important that the district invests in long-term sustainability strategies, such as leveraging Medicaid, and continues to support NFP. The Home Visiting Reimbursement Amendment Act of 2023 provides a clear pathway for long-term sustainability. We appreciate the unwavering support from DC Council that has demonstrated for the bill. However, without funding attached, the bill will not be implemented. As the mayor stated in her letter, the council needs to partner with district government agencies to develop and implement a cost-effective approach. On this note, we urge the council and DC Healthcare Finance to work with the Office of the Chief Financial Officer to review the fiscal impact statement they provided for the implementation of the bill, as we believe it is flawed. The fees estimations are based on erroneous understanding of which programs will be eligible, programs capacity, and a failure to account for the other federal funding that currently supports eligible programs. For example, only 5 out of 13 programs accounted for meet the required certification and are accredited with a national office for an evidence-based home visiting model. The FIS estimates 1,200 families will be served starting January 2025. According to the 2023 annual report of the DC Home Visiting Council, the full capacity of the 5 eligible programs is 398. The FIS projects that once Medicaid funding is available, a new program will open each year, serving 50 additional families. As an implementing agency, I can assure you that ramp up for implementation requires seed funding that will fund you from program designed all the way through at least 1 year after implementation. Funding NFP and other evidence-based home visiting programs through Medicaid is not only cost-effective, it also promotes better coordination of care and services for pregnant persons and babies who are enrolled in managed care. Mayor Center continues through our social change model to be committed to the health, education, and safety of families in the district. We hope we can build from here to continue our shared commitment to serve families in the district with the goal of improving maternal and child health outcomes. Thank you.
Thank you. And thank you to this panel of witnesses. Mr. Kennedy, Ms. Case, I appreciate you so much coming down to testify and advocate not only on behalf of yourself, but the entire community altogether. Ms. Case, we'll ask some questions to healthcare finance regarding why the funding for Services My Way has been delayed in getting approved. I think as you noted, this isn't just about, oh, it was just a glitch in the system, but it's a livelihood for folks in terms of their ability to make a living. And I think the more times where we get it wrong in terms of paying someone on time, the less likely they are to stay in that profession and field. And then we have the issue of the turnover. And then, the things that we talked about before with Ms. Niles around the number of individuals who are seeking to go into this profession going down. So we'll ask some follow-up questions on that front. Ms. Reese, thank you so much for being here. The joy of, I don't call it the joy, but we have another opportunity. Yeah, it's not joyful. We have another opportunity to engage with the CFO's office around the FIS. So if you have some additional information that could be helpful, let's do that as we head into the budget process in March. We did that last year with another bill where we felt like the CFO's numbers were off and we were able to provide them with some additional information that was able to significantly reduce the numbers. And so it seems as though you have some of that information available. Okay, great. So let's work on that. But I'm glad you got your money.
Yeah, very excited.
Okay. And that you all will be able to continue the program. How many families do you all currently serve in your home visiting program?
We currently have 76 families.
76 families. Okay.
Just with NFP program.
Just within NFP. All right.
We were able to graduate our first cohort of families back in September. So that was very exciting because this is a new program, it's a pilot program, and just seeing families graduate for the first time, it was really exciting. And we continue to ramp up the program and we'll probably be at 100 pretty soon.
Great. I look forward to hearing about the outcomes for the families, the first group that you just graduated. Yeah, I don't have any further questions, Ms. Pollard. But I thank you all so much for being here. And so we're going to go to what I believe will be the final panel of in-person folks. All right. So I see Ms. Bowens. Okay. Who else is here in person who is not on this list? All right. Come. I'm sorry. You tell me, remind me your name again? Eric. Oh, yeah. Oh, you were second. Come. All right. Okay, I have 2 seats left. Speak now or forever hold your peace. All right. Okay, great. Wonderful. All right, Mr. Walcott, why don't you go ahead and get started? The mic was on.
Greetings, Chairperson Henderson and members of the Committee on Health. My name is Eric Walcott. I serve as Executive Director of the District of Columbia Home Health Association, a business league made up of some of the most long-standing home health agencies providing personal care services to a large percentage of district residents living with chronic illnesses. It is with much honor and consideration that I bring testimony before you on behalf of my members. I do have a few members today that will be bringing remarks from a perspective of being a longstanding provider agency, and I do hope that you will give ample weight to their testimony. And forgive me if I will appear to echo of a lot of what that will be said by others who have raised the alarm about workforce pressures within the home health community-based services sector. My testimony today will be directed towards increasing difficulty, or rather the mounting transaction costs of doing business in the District of Columbia in the post-COVID environment. To be sure, COVID-19 has exposed the fitness readiness weaknesses of the home health sector as it relates to inadequate response to address labor shortages. Much like in other jurisdictions, we need a state Medicaid agency that seeks to remove barriers to onboarding needed workforce. Moreover, the District of Columbia Board of Nursing needs to be sufficiently agile and as a regulatory agency to propose regulations that would create a more streamlined process to enable long-term care providers to hire from an already shrinking workforce pool. Yet it was very helpful that the Board of Nursing to allow for Maryland CNAs to be allowed to work in the home health sector and afforded them a bridge program on a pathway of license to be an HHA in the District of Columbia after having worked in health setting for a period of time. Were it not for this flexibility, we would have had a further crisis in the district. I'm disheartened to say that we did not continue this flexibility. And for whatever reason, I believe that, to me, the state Medicaid office did not work with the home health sector, the long-term care community, to actually pressure or actually make a more persuasive argument and advocate for keeping that flexibility in place. At this time, I must tell you that the home health agency is having a tough time staffing district residents who require personal care aides. Individuals are spending a long periods of time waiting for services, as you heard earlier today. And you would know that CMS recognized this as a need in terms of we were able to have Appendix K, which the state Medicaid actually chose not to actually apply for. So DCHHA met with the state Medicaid director and senior staff to request that they do so, or request that they would they inform the home health agency that they would not. So this was shocking to us, and we would like for a council to actually look into it because this is a major issue. I'm going to jump around. Notice that I have time.
Mr. Walcott, you don't have time.
Oh my goodness. It's only two of us. Maybe you should accord me one more minute.
Okay, Mr. Walcott, what time did my hearing start?
Let me just say,
No.
Madam Chairperson.
Yeah, I have
am-
30 something other people to get to.
Let
Let me ask you some follow-up questions. I'm going to go to Ms. Bowens.
Exactly.
All right, there we go. Thank you, Ms. Bowens.
Good morning, Chair Henderson, and I'm Jacqueline Bowens, and the President and CEO of the DC Hospital Associations, and apologies for my late arrival. And good morning, and very much appreciate the opportunity to present testimony regarding the Department of Healthcare Finance's 2024 performance. The work of the Department of Healthcare Finance under the direction of Deputy Mayor Wayne Turnage and Medicaid Director Melissa Burton team has been essential to ensuring over 300,000 district residents have access to high quality health care so that they can thrive. The ongoing work to recertify beneficiaries during the PHE unwinding is critical to providing continuity of care and ensuring that everyone eligible for redetermination continues their coverage. We know the department has worked incredibly hard to create a process that maximizes the opportunities for outreach to residents and provide communication tools to stakeholders to assist in encouraging beneficiaries to participate in the redetermination process if their eligibility is not passively determined. As we look toward the delivery of care from a provider's point of view, ensuring that denials and unnecessary prior authorizations are limited is essential. Councilmember Henderson, also your work on the prior authorization legislation is a big step forward. We hope that the Medicaid MCO provisions of the legislation will be funded in the near future to drive improvements for patients and providers by eliminating and reducing paperwork. From a rate-setting perspective, it is critical that the department continues its work with frontline providers, including behavioral health, home health, and assisted living providers, to ensure that reimbursement rates reflect the higher wages needed to recruit and retain staff that allow our patients to be served in a timely manner and in a sustainable way. Additionally, we look forward to partnering with the department as they advance physician-directed payments in the future. Investing in physicians will create stability and expand access for additional resources. And finally, DCHA would like to thank DHCF for its work during the MCO transition. During the transition, the department and MCOs were quick to respond to any issue that arose to ensure a smooth transition. And as we look towards MCO accountability. We look forward to the MCO annual report to understand the metrics the DCO MCOs are meeting. We also hope there's additional information related to denials and prior authorizations to quantify any burdens on the beneficiaries as well as any positive outcomes. And in closing, I want to reiterate that DCHA looks forward to our continued collaboration with the department, and a thank you for your patience and allowing me to testify today. And I'm happy to answer any questions you may have. I did it in less than 3 minutes.
Thank you. Thank you. Okay, Mr. Walcott, let me ask some questions. We've met, we talked about this issue in terms of the waiver. Did you meet with the deputy mayor at the end of last year or even in the fall to advocate for the continuance? What feedback did you get?
Absolutely. I met with the senior staff to include the deputy mayor, the state Medicaid director, and other senior staff.
Okay, and so why, like, yes, they could do the waiver without legislation. So why do they hesitate?
Well, I must tell you, first of all, we appreciate the deputy mayor and the senior staff. We understand the difficulty of the work that they do. But at some point in time, the voice of the practitioners, the providers must be heard, and ample follow-up must be made. So in essence, when we met, we talked about, we developed a survey tool. We sent it out to our members. We informed them that they would have severe challenges in meeting the current workforce levels if they do away with overtime, and especially for those with high acuity needs. And so we had some follow-up, but I must say it has not led to any change in their position on the matter. So now we have a real challenge. And I must say the surveyors from DCHRLA is now weaponized in a way where they're actually issuing citations for not meeting actually plan of care levels of services. Well, this is a perfect storm that we have created.
Mm-hmm.
We don't have the staff. We're unable to provide the services at current levels. And when you do away with overtime, we face now with providers funding district services out of their pockets. And in the end, what we may have is agencies going out of business. It's a real crisis.
Yeah. Are we seeing a situation though where providers are having to rely on overtime because they don't have enough staff to cover without doing overtime? Is that
that is correct.
okay? All right. So it's sort of like a cascading problem, right?
Right. And also those who are actually prescribing or determining how much care is needed, how many hours of care is needed, we've seen an uptick. So whereas it would be almost an average of 8 or 10 hours, you now see it's more an average of about, it's more than 12.
Yeah.
More than 12 hours. You have high incidence of 18, 16, sorry. And you also have the 24-hour care. So we just can't sustain, it's unsustainable.
Yeah. And we've been trying to raise the alarm. I introduced legislation on the direct care, direct support. No, you know what I'm talking about.
Yeah.
Direct care worker. And we're going to have a hearing on that in March to talk about some of the challenges. But frankly, I'm more concerned right now in terms of what it means for someone who's licensed in Maryland and Virginia not to be able to serve district residents any further, and how that's going to put a strain, right? We could address some of the other things later, but that seems like a low-hanging fruit.
Absolutely. Absolutely, council member. This is something that we could do tomorrow.
Right.
We can do tomorrow. We can say, we can allow CNAs and HHS from neighboring jurisdictions to work in the district, and that would help support or put a stop to some of the challenges that we have today. So we can do that. Sometimes I know my friends, I must say, I was a former Department of Healthcare Finance employee. I've spent more than 16 years in government. So I know when we want to do something, we can do it. I know the deputy mayor is well capable. The state Medicaid director, Melissa Bird, is fantastic. The staff is there. I'm just trying to figure out why haven't we been able to operationalize some of the suggestions that we've made. Some of them are no cost. Some of them are cost neutral. We have to do it.
Yeah.
We've been crying for it. The district residents deserve it. We ought to do it.
Okay. I certainly have questions for the deputy mayor on that. Ms. Bowens, I don't have any specific follow-up questions in terms of your testimony. There are some issues that questions we have for the deputy mayor about some of the issues you raise around, implementation of prior auth. For those who are listening, so prior auth is in effect for folks who have private insurance, but there was a significant cost for those who are on Medicaid, who now we're starting to see, for MCOs, for instance, let's see. We have one MCO that, if you have an urgent matter, they average now 72 hours before they provide prior auth, which I think is then like, is that urgent really? 72 hours seems, especially it's out of line with everybody else. Everyone else is averaging 24 hours for an urgent, and we have one MCO that's 72.
Yes, and would just add to your questions that you raised with Dr. Arduous. We're certainly happy to have him as our new chair, and he spoke to some of the issues that Washington Hospital Center experienced. But I would say that multiple hospitals have a number of the complex patients that have been there. I know one hospital in a meeting just the other day talked about several who had been there, hundreds and hundreds of days for non-acute days. So again, we're working with the department, but certainly any efforts to deal with the prior auths with respect to the Medicaid populations, and thank you for your efforts on the private side, but certainly being able to address that. And when we're hearing about bottlenecks and we're hearing about borders, and those contributions to long wait times in the ER, it is that combination which we've talked about that really become issues, not just for that population, but for all access, whether it's EMS drop times. It's just this contributing effect. So thank you so much for all of your efforts in the past, and we look forward to continuing to work with the agency and your office in terms of how we can resolve it.
Great. Thank you guys so much. I don't have
Thank
any
you.
further questions.
Thank you.
Mr. Walcott, we'll have a follow-up conversation. I'm going to move on to the virtual witnesses. So I'm going to call 7 at a time. Again, for the virtual witnesses, you'll need to affirmatively accept our invitation to become a panelist. So we have 2 people who had signed up for in-person who are virtual now. Claudia Schlossberg, Veronica Sharp. I'm going to call Eric Romero, Ian Paragol, Makita Vanderpee, Andrew Patterson, and Sal Salvagaggio. We're just giving it just a minute. Okay. Claudia, when you're ready.
Thank you. You can hear me?
Yes.
Good morning, Chair Henderson, members of the Committee of Health, and members of the Committee on Hospitals and Health Equity. My name is Claudia Schlossberg, and I'm testifying this morning in my capacity as Chair of the DC Coalition on Long-Term Care's Workforce Development Subcommittee. I'm going to focus my testimony today on the direct care workforce crisis. As you have heard previously, the DC Board of Nursing recently shared data in their January meeting showing that in the last renewal cycle, which ended in October of last year, we lost 4,489 direct care workers. This represented 46% of certified nursing assistants and 20% of certified home health aides, as well as a 30% decline in trained medication aides who work with people with developmental disabilities. In addition, some data from the Board of Nursing shows that we are not training enough workers to replace those. In fact, if you look historically, at least at the data that was available, at no time have we even reached even a quarter, the capacity to train even a quarter of those who have left the workforce. So we are digging ourselves into a huge hole. These numbers are alarming, but they shouldn't be surprising. Yesterday, the coalition released its 5th long-term care workforce survey. since 2020, where we have been documenting the growing workforce shortage now for 4 years. Our survey respondents, there's a lot of data in that survey, and I've attached it to my testimony and asked that it be included in the record. But our survey respondents confirm that the primary driver is the inability to pay competitive wages, which was led to a lack of interested qualified candidates, and also results in serious access issues for seniors and people with disabilities. And I'll also note it contributes to the degradation of quality and care. I think you heard from your first witness, about aides who were not doing a good job. For the past 4 years, we've urged DC as the primary payer in long-term care to provide meaningful increases in provider compensation to allow providers to pay competitive wages. The current compensation levels, reimbursement levels have proved insufficient to keep direct care workers on the job. And I just note that childcare workers with comparable levels of education make $7 on almost 50 cents more than a direct care worker caring for the elderly. DC also cut nursing home and reimbursement by 20% last year and stopped, as you heard, compensating home care agencies for overtime and agency staffing, even though reliance on overtime pay has been a primary means for home care agencies and other providers to meet their staffing needs. Worse, DOH and DHCF are now imposing sanctions, including monitoring fines on home care agencies when they're unable to find a home health aide to fully staff a client. This tactic does nothing to address the root causes of the shortage and will only further exacerbate the workforce crisis by increasing financial pressures on agencies that are already losing money or working on very low margins. We're not alone in this crisis. You're going to see submitted testimony from Claudia Balag outlining the work that other states have been doing. They are many years into pulling together multi-agency initiatives, implementing comprehensive strategies to improve the workforce situation. We have yet to see this level of response from DC officials. I'll close. I know my time is up. We are very appreciative of the work that you've done, and we're looking forward to testifying in support of the Direct Care Workforce Amendment Act. But we are in a crisis now, and as you've heard, one way to address this would be to reinstitute the waivers that we had during the pandemic that allowed Maryland and other certified aides from other states to come and work in the district. We need to do that immediately.
Thank you.
I'm going to stop there and happy to answer any questions.
Thank you. Ms. Sharp? Ms. Sharp, you're on mute.
Good morning, Chairperson Henderson and members of the Committee on Health and Committee on Hospital and Health Equity. My name is Veronica Sharp, and I am the president of the District of Columbia Healthcare Association, which represents the district's all of the district's licensed nursing facilities and several assisted living communities. I'm pleased to go on record and state that in 2024, the relationship between DCHCA membership and the Department of Healthcare Finance continues to be a good one. The provider community and the department continue to work together to improve the quality of life for the district's nursing facility and assisted living residents. That's not to say that there are no areas of concern on the part of the provider community. Long-term care providers across all provider types are facing an unprecedented workforce crisis. Nursing homes and residential care facilities lost over 234,000 employees during the pandemic, and the Bureau of Labor Statistics show that 131,900 workers are needed in long-term care to reach pre-pandemic levels. As Ms. Schlossberg stated, the information from the Board of Nursing shows that in 2024, DC had 2,346 fewer CNAs apply for DC certification than in 2022. In the Long-Term Care Coalition Direct Care Workforce Study, nearly 80% of providers report moderate to heavy staffing shortages. Providers in workforce say that they're leaving for jobs that are less physically and emotionally challenging and for higher wages. DCHCA worked with DHCF over the summer to gather data that substantiates the need to increase provider rates to be able to pay higher wages and to also cover the increased operational costs that are still being incurred even though the PHE has ended. The department presented a combined CMS market basket index and percentage-based increase in SNF direct labor costs. The local cost to fund this initiative is approximately $8 million. We recognize that the 2025 is a difficult budget year, but the increases are necessary to allow providers to continue to provide quality care. With the elimination of the 20% add-on payment to SNFs in July of 23, the need for DHCF to function efficiently in processing eligibility claims becomes even more important. DCHCA recently met with Melissa Bird and her leadership team to discuss the extended length of time it is taking to process eligibility claims, which delays the ability to pay and get paid for care on a timely basis. The department has said they will be authorizing overtime and hiring contracted staff to help bring the backlog of cases current. Several other technical points were discussed, and we will continue to work with DHCF and other areas of concern. And lastly, I just want to state that the members of DCHCA, we thank Deputy Mayor Turnage, Melissa Bird, Angelique Martin, and their staff for their ongoing efforts on behalf of the district residents. Thank you.
Thank you. Mr. Marrero?
Good morning. Good morning, Chairperson Henderson, council member, and council staff. My name is Eric Romero, and I'm honored to stand before you today as an intake and benefits specialist at La Clínica del Pueblo. I am grateful for the opportunity to discuss concerns regarding the Department of Healthcare's finances performance related to the DC Alliance program. La Clínica del Pueblo is a federally qualified health center providing health and community services since 1983. Our mission is to build a healthy Latino community through culturally appropriate health services, focusing on those most in need. As an intake and benefits specialist, my responsibilities are to provide information about different healthcare programs, determine eligibility, and help patients complete the required application. The district has made significant progress in extending healthcare access to all district residents, including eliminating the 6-month recertification progress and in-person applications for the DC Alliance. While these positive steps signify progress towards health equity, it is crucial to shed light on persistent challenges that continue to impact our patients during the renewal process. We constantly find inconsistent information in the DHCF provider portal. When our patients go to the ESA office, they are told their insurance is active, but when we look in the portal, Medicaid portal, we see messages saying that they are not eligible. And to make it more confusing, the recertification date shows that the patient renewal is not until 2025. I would also like to highlight that many of our patients who go to the ESA office to ask for help report feeling mistreated, and many of them say they do not receive interpretation services. We recently had a patient go through this experience. He is a 56-year-old male who was confused, frustrated, and was not sure what to do to be able to see his doctor and get his medication. I contacted the DHS office for guidance, and they did not provide any solution. Such lack of clarity and support only serves to exacerbate the stress experienced by patients already grappling with health concerns. Another prevalent issue related to inconsistency and lack of clarity is when we submit group applications. We have sent family applications for renewal of their DC Alliance insurance, and some of the members of the families are approved, while others face unexplained denials. Additionally, although many patients have received recertification yearly, we see patients who only receive the renewal for 6 months without any explanation. These are just a couple of examples of what many of our patients have to go through when trying to renew their insurance. Many of our patients suffer from chronic condition, and lapses in care are detrimental to their health. The management of chronic conditions require timely medication adherence and constant communication with their primary care physician and specialists. The DC Alliance program is one of the most vital benefits that extend access to low-income immigrants who do not qualify for Medicaid. Today, I would ask the DC Council to consider healthcare access beyond just the doctor's visit, but as a responsibility to ensure that system and processes are in place so that people can obtain insurance without disruption. By doing so, we can collectively guarantee that our community members and all DC residents receive and consistent and reliable healthcare coverage they deserve. Again, my name is Eric Romero, and thank you for your attention.
Thank you, Eric. Ian?
Good morning, Chairperson Henderson. My name is Ian Perigo, and I serve as the Executive Director of the DC Coalition of Disability Service Providers. The DC Coalition currently represents over 50 provider agencies, supporting over 2,300 persons with intellectual and developmental disabilities and employing over 4,700 staff. Member organizations provide home and community-based waiver services as well as ICF services supporting residents of the district with intellectual and developmental disabilities. On behalf of the provider agencies and those whom they support, we want to recognize the leadership of the DHCF Director, Melissa Bird, Catherine Rogers, and in particularly the transparency and accountability demonstrated by Deputy Director of Finance, Angelique Martin. As our primary conduit to fiscal matters relating to service delivery, Ms. Martin's follow-through and implementation plans have enabled the district to fund direct support workers at an average of 117.6% of the living wage for the DSP Rate Payment Act of 2019 as of January 2024. We appreciate Ms. Martin's engagement with the coalition and willingness to meet and discuss matters related to the vision of supports to district residents. That being said, with the continually mounting staff turnover and vacancy rates, and in spite of the recent funding allocations, DD providers are just too far behind to reach sustainability without further action by DHCF. Vacancy rates now exceed 20% in the industry, with some providers reporting vacancy rates as high as 35%. As a result, the DC Coalition, as well as numerous other healthcare associates, including long-term care leaders, home health service providers, SEI, would suggest that a recruitment and retention needs require an even more substantial commitment to funding. But none of this is new. Over the last 8 years, we've testified, we've written communication to the mayor and to the council and DHCF. We provided data and distributed infographics. In fact, I was reviewing my testimony that was shared before this committee from 2023, and the DC Coalition voiced its concerns and projected the exact same situation that presently exists in the healthcare community, and it's now and is highlighted and detailed in my written testimony. So before I go further, I want to advocate essentially for the same measures that I voiced for this very committee last year: continued frontline staff funding for fiscal support for the rising overtime costs. In 2023, the coalition recommended that any continuing wage enhancements for frontline staff include allocations for expected continued overtime costs resulting from the unsustainable vacancy and turnover rates within the industry. Service providers need some accommodation or additional funding to account for this overtime. Number two, funding to address mid-manager, mid-level wage compression. Mid-level staff supervisors are vacating their positions because, quite frankly, they can earn more with overtime as a direct care worker. Now that's good because they're earning more, but they're of course using more hours. So we need that additional fiscal support for mid-level managers so the providers can maintain appropriate supervision ratios. This is the same request that I made in 2024. And thirdly, we asked for competitive funding rates to address the nursing shortage, as we did in 2023. Our funding for LPNs and RNs are below the market value, well below it. So we recognize there are many agencies and programs to consider, but the coalition has a proven track record anticipating issues and developing recommendations that can lessen the impact of those issues upon the industry and with the persons at whom we support. And lastly, it's troubling that year after year, the coalition, largest association of DD providers in the district, an organization whose leaders know this industry better than anyone else, continues to warn and offer guidance regarding adverse foreseeable consequences, but they're set aside. So it seems rather unwise. Thank you. My time's up. Appreciate it.
Thank you. Ms. Vanderpee?
Good morning, Chairperson Henderson and members of the Committee on Health and members of the Committee on Hospitals and Health Equity. Thank you for the opportunity to testify today. My name is Makita Vanderpoy, and I'm the Executive Director of Leading Age DC, an association representing mission-driven organizations serving older adults across the district, including nursing homes, assisted living, affordable housing, senior villages, home and community-based services. We're part of a network of over 5,000 nonprofit organizations serving older adults across the United States. I'm also a Ward 5 resident and an active member of the Coalition on Long-Term Care's Workforce Development Committee. My testimony today is to share leading HDC's concern about the deepening and alarming shortages in the professional caregiver workforce. I'd like to first acknowledge the work and efforts of the leaders and staff in the Department of Healthcare Finance and the Deputy Mayor's Office for Health and Human Services for their public service to the residents of the District of Columbia. That includes the provider members of Leading HDC, many of which who have served older adults in our community for over 100 years and remain committed to providing high quality care to some of our most vulnerable residents. The mission-driven nursing home members of Leading HDC consistently outperform for-profit counterparts in domains of health inspection, staffing, and quality, as reported by the CMS 5-star quality rating system. However, the current shortage of direct care professionals trained and certified to work in DC, including home health aides and certified nursing assistants, is an urgent and pressing crisis to our healthcare system, with dire impacts for these community institutions, older people, people with disabilities, and their families across our city. The population of older adults is rapidly growing. The Office of the Budget Director estimates that over the next 5 years, approximately 44,200 residents will turn 65 years old, and increasingly residents will require care professionals to support tasks of daily living at home or in a facility setting. Conversely, as you've heard, recent data from the DC Department of Health shows that for the past several years, there has been an ongoing decline in the number of individuals training to do this work. I included some statistics in my written testimony, and you've heard much of that there. I would also urge you to refer to the results of the 5th Annual Direct Care Workforce Survey, which was released yesterday by the DC Coalition of Long-Term Care Providers, where respondents have reported their challenges with acquiring and retaining workers because our caregivers are leaving the field for jobs that are less difficult, require less training, and pay more money. While this is a complex problem that's driven by a lot of factors, we luckily have some learnings from other states that Claudia Baylog has included in her submitted testimony. In addition to these long-term efforts, we also need to take action now, and I will encourage council to consider reenacting emergency legislation to allow district healthcare providers that are out of state to be appointed as temporary agents so that they can provide healthcare services to the district residents who need it. Thank you so much for your time, and I welcome any questions.
Thank you. Mr. Patterson?
Thank you, Chairperson Henderson. My name is Andrew Patterson. I'm a senior staff attorney with Legal Aid DC in the Public Benefits Unit. And thank you for the opportunity to testify at this Performance Oversight hearing. Today, I'll focus my testimony on the problems our clients continue to face regarding Medicaid renewals and DC Healthcare Alliance renewals, as well as the inadequate provision of approved medically necessary home health care and personal care aid hours to Medicaid beneficiaries and EPD waiver beneficiaries. First, regarding Medicaid and Alliance renewals, since the September roundtable, there's continued to be an unacceptably high number of Medicaid terminations. DHCF's November 2023 recertification outcome report continued to show an average of less than 70% of initiated renewals for the months of May through October 2023 resulted in a completed renewal. The report also showed that the vast majority of terminations that occurred were not due to ineligibility, but instead due to failure to complete the recertification process, meaning many people who are losing coverage probably continue to remain eligible. We're especially concerned about the renewal rate for the ABD and long-term care Medicaid groups. The most up-to-date figures available in September showed that only 36% of that population had successfully renewed their health coverage. The most recent figures available on DHCF's website shows that those renewals have only increased to about 43%. Additionally, as another witness mentioned, over 20% of the enrollees in the district's EPD waiver program have been disenrolled from that program since September 30th of 2023. This is especially concerning because, number one, this is a vulnerable population that is at risk of institutionalization if they do not receive their necessary home health services. And number two, it is ultimately the case manager's job to ensure that EPD waiver beneficiaries are able to successfully renew their benefits. Legal Aid has encountered many examples over the years of case managers not completing recertifications on time, which leads to unnecessary delays or cuts in services, as well as unnecessary appeals and hearing requests. We know this has been a challenging year, and we do appreciate the efforts of DHS and DHCF regarding renewals, and we have multiple recommendations in my written testimony, but I would like to just highlight two of those. We want DHCF and DHS to have adequate staff to ensure timely processing of all Medicaid and Alliance renewals. And we urge DHCF to adopt the changes proposed by the DC Coalition on Long-Term Care, in particular for EPD waiver enrollees, granting access to beneficiary designated assisters to not only help with the renewal process, but also to submit that paperwork through DC Care Connect. I also want to address our concerns, which are shared by many at this hearing regarding workforce issues with personal care aid services. As others have testified, it is clear that these challenges are caused in large part by the inability of DHCF to ensure that home health agencies maintain adequate personnel to fully staff the number of hours of approved home health hours. Data from the DC Board of Nursing, which I believe the councilperson herself referenced, shows that the number of licensed home health aides has declined by more than 1,700 over the past 6 months, which represents a decline of more than 20%. Again, in my written testimony, I have more recommendations, so I'll just highlight a couple. We, as other witnesses have, urged the council to pass the Direct Care Worker Amendment of 2023. If adopted, this legislation would help to address the shortage of home health aides by reducing or eliminating administrative barriers to the licensing process, as well as increasing wages to make the position more competitive with other industries.
Thank you, Mr. Patterson.
Thank you.
Thank you. Sal?
Good morning, Chairperson Henderson. My name is Sal Salvaggio, and I'm here to provide testimony in support of the efforts being made by the DC Coalition for Long-Term Care to alleviate our shortage of healthcare workers. First, I'd like to express our appreciation for the interest and attention you and your staff have demonstrated in addressing this problem. You will be given testimony by others in the coalition that will provide you with data on this issue. Some of this data comes from healthcare worker employers, indicating the drop-off in candidates for these positions, as well as trends showing a decrease in the absolute number of workers available to meet the needs of their clients. What I would like to do is to relate to you some recent experiences I have had interviewing the recipients of healthcare aid in their homes and the real impact that the shortage has had on their lives and the lives of their families. James is a young man who experienced a devastating spinal cord injury. He requires help 14 hours a day, 7 days a week. He cannot walk. He has limited use of his arms, which means that all of his hygienic bodily functions require assistance, as well as his needs to receive nutrition. When his aides don't show up because of scheduling problems or none are available, his 75-year-old mother must do these things. He's a large man, and his mother, who I met, is a small woman. She does these things out of love and because there is no one else who can. I interviewed a 90-year-old woman who had her leg amputated. At a rehabilitation facility, she was left unattended for hours, and because of insufficient staffing of the facility, could not receive her most basic hygiene and other needs. When she was released to her home, her daughter had to travel from Ohio, take off from work for a month, and provide care that she was not trained to do because of difficulty in finding the consistent professional help required. Councilmember Henderson, in doing these interviews, I experienced many emotions. The admiration for these individuals and their families whose love and devotion for each other left me humbled. The fear that I, my family, and my friends can, because of an illness or accident, be placed in the same difficult position at any time. And the sadness that our society, which prides itself on being enlightened, has yet to come to the realization that this situation is real, urgent, and needs attention. Thank you for the opportunity to share my experiences with you and your past efforts on behalf of our most vulnerable community members who require healthcare assistance to live. I believe our DC government, working with interested organizations and individuals, has the capacity to marshal its resources and talents to find the solutions to this complex crisis. It will require a dedicated department within an agency to coalesce these resources and implement viable solutions. It will require the financial commitment from the district to make this vital component of our healthcare system a sustainable reality. It is our hope that you and all others who have the ability to make a difference will find the tenacity to do so. Thank you.
Thank you. And thank you to this panel of witnesses. Mr. Salvaggio, I will just say I appreciate you sharing those stories and your continued work to uplift the folks in the community on that. Many of you had testified about the similar issues, which, as I said, we'll have some questions for the Department of Healthcare Finance, particularly around overtime, the waiver, and some other issues. But I do want to just ask Mr. Romero, a little bit different of everyone else, because yours was specifically about the Alliance. So, I'm concerned that you all are reporting challenges in terms of the portal that the providers see on your end. Have you all raised these issues with DHS or with healthcare finance in terms of like it's sounding like there's some sort of glitch in the system where ESA is telling folks you are approved, but the provider side is saying, no, you're not.
Yes, and it gets very frustrating because when I call, they just say it's not active. And then when I mention the restart date of it being later on, let's say 2025, as I mentioned, they don't say anything. They just say submit another application. And that can be very frustrating because the process of just completing an application, sending it, then receiving and approving it, it gets very frustrating. And
yeah,
it's hard to explain to the patient that.
So I'm confused. You're seeing that the recertification is not until 2025. Therefore, there should be no issue, or
correct. It should be
clearly
active, but
is
it's
like
not.
a typo. The default response can't be just submit another application, because that's how the system gets clogged up. Further, that's how people get flagged for fraud when you have 3 or 4 or 5 applications in the system for the same thing. So we'll certainly ask some questions about that, but I certainly appreciate you being here. I don't have any specific questions for the rest of the panel, but we have been joined by Councilmember Zachary Parker from Ward 5. I'll turn to Councilmember Parker to see if he has questions for these panels. Councilmember Parker?
Thank you. I have no questions, but want to thank you all for your testimony.
Okay. I know I will see many of you next month for our hearing on the direct care worker bill, but appreciate you all being here. All right. So for the next panel, we have Mark Lavota, Mary Catherine West, Robin Griffin, Deja Williams, Wendy Jones, Travis Bale, and David Friedman. We'll give it a minute. Just again, for those who are joining us virtually, you'll need to affirmatively accept our invitation to join as a panelist. But we're moving folks in and out of the room, so just give us a minute. All right, I see Mark. So Mark, when you're ready.
Chairperson Henderson and members of the council, thank you for the opportunity to testify today. My name is Mark Lavota. I'm the Executive Director of the District of Columbia Behavioral Health Association and a Ward 2 homeowner. The District of Columbia Behavioral Health Association works to advance high-quality whole person care for district residents with mental illness, substance use disorders, or both, including 32,000 district residents our 33-member organizations serve annually. I'm disappointed to share serious concern today that the provider network is not prepared for the transition of Department of Behavioral Health certified provider services to Medicaid managed care, and fear that DHCF, DBH, and the managed care plans are also unprepared 53 days from the scheduled transition April the 1st. Despite provider technical and financial assistance, managed care readiness reviews, and service definition and payment rate update efforts, my remarks will provide details regarding lack of preparation for contracting between provider organizations and managed care plans, credentialing and workforce recognition, authorizations and level of care assessments, and claims payment. Information provided as recently as January 25th was that only 45 of DBH's 76 certified provider organizations had a contract in place with at least one of the 3 managed care plans. Only a fraction of the approximately 2,000 licensed staff members in the DBH certified provider workforce are successfully credentialed with all 3 managed care plans. Still no process has been announced by DBH or DHCF for recognition of approximately 7,000 unlicensed staff members. DBH and DHCF need to announce more robust transitional bridge policies, such as directing managed care plans to pay DBH certified provider organizations claims with rendering provider NPI numbers as in-network claims, regardless of contract or credentialing status, for at least 180 days from April the 1st. DHCF also needs to share more information about care authorizations and level of care determinations. To the best of my knowledge, nothing prevents the managed care plans from taking a more restrictive approach than DBH has in its recent requirements for authorization reviews. DHCF also needs to clarify how managed care plans are expected to make use of assessment tools that DBH certified providers are mandated to complete. DHCF needs to ensure that managed care plans have written clinical criteria for any service that the plan requires to go through an authorization review. Even if these other issues addressed, there's uncertainty about whether people systems or electronic systems are prepared for a smooth claims payment transition on April the 1st. DHCF needs to be able to track what portion of claims submitted managed care organizations consider clean claims and what portion are sent back for rework, what portion of claims submitted are formally denied, what the major reasons are for denials, how timely payments are made for clean claims. Any step in this readiness process has compounding impacts, stopping the rest of the process from working or causing it to work ineffectively. The path to avoid severe negative consequences for the plan transition requires swift and decisive action and strategic phase-in substantially after April the 1st of some requirements. We're grateful for Melissa Bird's leadership and the efforts undertaken by DHCF staff over the course of the past year. Thank you for the opportunity to testify today.
Thank you, Mark. Mary Catherine?
Hello. Good morning, Chairperson Henderson and members of the Committee on Health. Thank you for the opportunity to address the committee as it reviews the Department of Healthcare Finance's performance. My name is Mary Catherine West, and I am the Program Manager for Early Childhood and the Chair of the DC Home Visiting Council. I'm a member of the Under 3 DC Coalition and a Ward 1 resident. We appreciate the DC Council's support for home visiting, including the recent passage of Home Visiting Services Reimbursement Amendment Act. Fiscal year 24 is DHCF's first year supporting home visiting, and I appreciate the enthusiasm of DHCF to join the Home Visiting Council and build relationships with programs and partners. My testimony today focuses on DHCF's administration of Mary Center's Nurse Family Partnership Home Visiting Program and the incoming Home Visiting Services reimbursement through Medicaid. Home visiting is a key to the district's strategy to improve maternal and child health. Over the past 6 years, severe maternal morbidity has increased across all demographics, and Black women in DC face severe maternal morbidity at almost double the rates of other races. Inadequate access to healthcare for Black families and racism in healthcare drive these disparities. NFP combats these problems by helping parents identify and mitigate maternal morbidity risk factors, including reducing pregnancy-induced hypertension and preterm births. NFP teaches parents to navigate interactions with medical professionals and advocate for themselves. Ajane, a participant who will graduate from the program next month when her daughter turns 2, shared, "I've learned to never doubt myself while working with my home visitor. I hope the next parent can accomplish everything they say they want to, like I have so far and am striving for in the future." The NFP home visitors are currently building capacity to support 100 first-time parents and their families each year. The district must continue its investment in NFP and other home visiting programs. Upon the enactment of the Home Visiting Services Reimbursement Amendment Act, DHCF should work towards a timely implementation of the legislation. Thank you again, Chairperson Henderson and the Council's for your leadership in the Council's passage of this bill. In 2022, Medicaid funded 45% of births in the district. Preventing a premature birth reduces the average medical cost by almost $40,000 per child. Evidence-based home visiting is a proven strategy to prevent preterm births and improve family outcomes and provide significant savings for the city. With strategic and transparent rating of local McV and Medicaid funding, the district can maximize its impact for families and create a pathway to achieve long-term stability for home visiting program budgets. I'm excited to continue building our partnership with DHCF to support children and families in DC. And I welcome the opportunity to meet with you, Chairperson Henderson, and partners at DHCF to share clarifying information and evidence on the fiscal impact of the implementation of the Home Visiting Services Reimbursement Act. Thank you for the opportunity to testify today, and I welcome any questions.
Thank you. Robin? Robin, you're on mute.
Thank you. Good morning, Chairperson Henderson. My name is Robin Griffin. I'm a senior attorney with Legal Counsel for the Elderly, also known as LCE. Thank you for allowing me to testify today regarding the performance of DHCF. LCE provides free legal representation and social work services to low-income residents of the district who are 60 years of age or older. The attorneys in my practice group represent senior beneficiaries who receive home health services under the EPD waiver program run by DHCF. The current DHCF Medicaid renewal process is negatively impacting EPD waiver beneficiaries who receive vital PCA services. The inter-eye algorithm used by Liberty Healthcare negatively impacts beneficiaries, as LCE noted in testimony at prior hearings. The inter-eye tool gives no weight to a beneficiary's needs as to instrumental activities of daily living. Beneficiaries are negatively impacted by persistent issues with home health agencies and available home health hours. LCE represented many clients who have been awarded upwards of 24 hours of PCA services, but they have not received those services because of insufficient home health agency staffing. Many of the clients LCE represents do not have informal family support to cover the hours home health agencies claim they cannot staff. This inadequate staffing puts their health in jeopardy and strain on families. Finally, many LCE clients have complained specifically about case management services. This includes being switched to different case managers without their knowledge. The client is not informed who their case managers are, and case managers do not respond to calls from clients or their representatives. It appears to LCE that there is a lack of cohesiveness and coordination, which negatively impacts the beneficiary's health and wellness. DHCF must address these issues. LCE continues to have concerns regarding DHCF's administration of the EPD waiver program's assessment process, particularly as related to Liberty's inter-eye algorithmic assessment tool and its failure to consider cognitive diseases in the scoring rubric, the home health care staffing shortage, and case manager inaction. Thank you for the opportunity to testify here today.
Thank you, Ms. Griffin. Deja?
Good morning, Chairperson Henderson and members of the Committee of Health. My name is Deja Williams. I use she, her pronouns. I'm Health Equity Organizer at Spaces in Action, member of the Under 3 DC Coalition, Home Visiting Council, and member of Mary Center Home Visiting Community Advisory Board. As a DC native, a proud big sister, and advocate for families in DC, I am ecstatic that the council has passed the Home Visiting Reimbursement Act. My testimony today will focus on the support of the Home Visiting Reimbursement Act and the value that it has for our families in the district. Home visiting programs in the district provide much care from maternal health to school readiness, relational health, crime reduction, and child abuse or maltreatment prevention. Through my work at Spaces in Action, I have witnessed the care that home visitors have for their participants. Numerous one-to-one meetings with these home visitors have shown that they love, I quote, love and value the work I do. It's so crucial for families' growth. Home visitors in the district are the frontline workers supporting our families. They have a vital role in the healthy development of our babies and toddlers. They are providing tangible resources such as diapers, food, access to holistic health care, and many, many more. Home visiting programs in the district must have sustainable funding sources that will come through Medicaid reimbursement. Evidence-based home visiting programs have a proven track record of improving maternal health and birth outcomes and the health and mental health of pregnant women, new mothers, and babies. Programs such as NFP, Nurse Family Partnerships, Healthy Families America, and Parents as Teachers directly address and improve DC's maternal and infant health rate. Sustainable funding for these programs is imperative to continue to address these disparities. I urge the council to, I urge the council to quickly move with the implementation of this bill so that the families that are participants of the home visiting programs in DC, evidence-based home visit program in DC, can benefit from the bill being passed. I also want to quote from the home visiting report that was given from Mary Catherine, that home visitors, I quote, home visiting programs occupy a unique role in DC's broader early childhood system because home visitors actively attend to both children and parents' need to meet family goals. It's all about the whole family, and that is the most important piece of home visiting. It's not focusing on just the child, the parent, but the whole family as a whole. And that is my testimony for today, and I yield the rest of my time, and I accept any questions. Thank you.
Thank you, Deja. Wendy? No, Wendy. Okay. Travis. I see Travis.
Thank you, Chairman Henderson, for allowing me to testify today and members of the committee. My name is Travis Bally. I'm testifying as a resident of Ward 7, a public witness today. I know this is oversight season, not budget season, but I think in order to robustly implement really great legislation like the Home Visiting Reimbursement Act, it's important that our agencies can count on the budgets that have already been allocated. So I just want to stand in solidarity with the Fair Budget Coalition and its platform for more racially equitable and economically just DC. That includes standing firmly against any mid-year budget cuts to services that DC residents, especially those in greatest need, rely on to survive. So no mid-year service cuts. My testimony today will focus on the importance of home visiting for a strong, effective, and connected early childhood system in the district. For communities like mine in Ward 7, home visitation for new parents and children is especially critical. Over 1/3 of our district's children live east of the Anacostia River, making Ward 7 and 8 having some of the largest populations of children in the district. 2/3 of maternal mortalities are concentrated with women from Ward 7 and 8, despite women of Ward 7 and 8 just making up 22% of the district's female population. No doubt a major contributor to these health disparities is the dearth of maternal health focused facilities, or let's be real, medical facilities in general, in our east of the river communities. I dedicated a previous decade of my career in the movement for reproductive freedom. So policies that improve the health of pregnant individuals and children have been a keen focus of mine. We've heard from numerous people today about the studies that have shown correlation between home visiting programs and enhanced maternal and child health, especially when other options do not exist nearby. I particularly want to highlight the Nurse Family Partnership Home Visiting Program. Those 100 families a year, they will serve with alternative access to healthcare during pregnancy and postpartum. That is going to have a disproportionate impact east of the river, where whether it be inadequate public transit and having to go to many medical centers that are in Northwest, it really will be a disproportionate benefit to east of the river, my east of the river neighbors. This intervention, it reduces preterm and low weight birth rates and pregnancy-induced hypertension. I am very grateful to this committee for moving forward for passing the Home Visiting Services Reimbursement Amendment Act. And I just want to make sure that we have the funding we need. The agencies have the funding they need to properly implement. Thank you so much for your time.
Thank you. Next, we will have David Freeman. Who doesn't appear to be here. And that concludes this panel. So I thank you all for your testimony. Ms. Griffin, I wanted to come to you. You spoke about the EPD waiver program and raised several issues from case managers to a lack of coordination and an overall concern with DHCF's implementation of the program. On case managers, can you speak more to what you're experiencing with the communication when a case manager is switched with your clients?
Definitely. Thank you for the question. And I'd like to provide 2 examples for you because we've noticed several occasions where EPD case managers' inaction led to negative consequences for our clients. One client came to LCE after several unsuccessful attempts to renew their Medicaid through their case manager. The case manager assured the client that she would file the renewal, but the client received notices in the mail that her Medicaid was terminating due to non-renewal. The client attempted to reach her case manager, and after several unsuccessful attempts, she came to LCE for assistance, where we were able to assist her online through District Direct. However, EPD waiver beneficiaries shouldn't need legal representation to reach their case managers or renew their Medicaid. And really quickly, the last example, another client was duly enrolled in Medicaid and Medicare, and they had never been contacted by their United Healthcare case manager. United Healthcare never provided the client with the name of their case manager. LCE contacted United Healthcare and obtained the name and contact information of the case manager. And we made several attempts to contact the case manager, but we were unsuccessful. After months with no response, we discovered that the case manager had left United Healthcare. We then obtained contact information for the newly assigned case manager. But again, United Healthcare failed to notify the client of the change in the case managers. And we were hopeful this time that the client would finally receive the assistance they needed. However, the case manager had one discussion with the client and provided no further services. We later discovered that the new case manager had also left United Healthcare. So beneficiaries also, they already have a lot to worry about without having to chase down their case managers. And we believe that district seniors deserve better.
I couldn't agree more. Can you share more information about those two examples with the committee as a follow-up to your testimony?
Yes. And in my written testimony, I'll share more information about those two examples.
That would be great. We recently had a hearing with the Department of Health, and this issue came up as well. And so when you talk about coordination, there is a clear need across district agencies from DC Health to DHS to DCHF. And the example that I raised was someone that was victimized in their home by a health aide, and as a result of the complaint, lost services because of some of the issues that you're flagging here. And that's certainly something I will raise with the deputy mayor. One quick question: what engagement has LCE had with DCHF, if any?
Yes, so we reach out to DHCF. We attend their, bi-monthly meetings on Medicaid renewals. We have all their contact and email information for when our clients cannot reach their case managers, and we stay in constant contact with them. We also are a part of the Long-Term Care Coalition, where we directly advocate to DHCF. So we are in direct contact with them.
But
we try to work together for the benefit of our clients.
Sorry for interrupting. What I'm getting at is, are you getting satisfactory responses when you raise these concerns on behalf of clients? And what, if any, further support could the agency be providing?
That's a great question. When we reach out, the intention is there to follow up, but I think the examples we provided highlight the response where, we're actively chasing them down, and that's taking up a lot of time on our part and also on the part of the beneficiaries. So having DHCF take a more active role in, ensuring case manager action, ensuring the staffing levels at the home health agency, and also taking a look at the Interi tool, I think those would be great actions for DHCF to take.
Thank you. And your point is well taken that someone should need representation from LCE to get those responses and engagement. Thank you all for your testimony.
Thank you.
Thank you, Councilmember Parker. Thank you so much to this panel of witnesses. I just want to have a follow-up with Mr. Lavoda. You testified at the behavioral health hearing last week about issues in terms of the carbon, and DBH, as I said, made some agreements in terms of how they would turn things around in terms of communication, but it doesn't sound like from your testimony that you have much faith in that.
Well, I don't think it's just a matter of communication. I think it's a matter of actually making policy decisions. And there are some decisions that just don't seem to have been made yet, or that if they have been made, haven't been communicated to the provider network. So there is definitely communication that we're looking for, but it's really the substantive policy decisions that we need to see put in place and quickly.
Okay. Okay. We have some questions, I have some questions for the director about that process as well. I don't have any further questions for this panel. If you didn't upload your written testimony, if you can do that for the record, so we go back and review that. So this would be super helpful. But thank you so much for everyone on this panel. All right, we're gonna go to the next panel of witnesses. Eva Gina Orgodova, Janet Phoenix, Stephanie Maltz, Jennifer Vega, Doreen Blue, Crystal Jones, and Christopher Williams. So we'll give it a minute as we transition. Okay. I see Miss. Do I see? Oh, yes, I do. I see Miss Orgodova. Excuse me. Apologies. When you're ready.
Thank you. Good morning. Thank you for the opportunity to testify today in support of fully funding Medicaid reimbursement for home visiting services. My name is Jenya. I use she, her pronouns, and I'm a nurse home visitor with the Nurse Family Partnership of DC at Mary Center. Every time that I'm here to testify, I usually start with, as I'm sure you know, the state of maternal health care is in crisis. And unfortunately, today is no different because a lot more work needs to be done. We continue to see increasing rates for preterm birth, inadequate health, prenatal care, a huge increase in disparities rooted in systemic racism and discrimination, with Black women being 65% more likely to experience preterm birth than all other racial groups. Nationally, and now in DC, NFP participants have significantly decreased rates of preterm birth, maternal and infant mortality, among many other outcomes. NFP participants are paired with a home visiting nurse for 2.5 years, starting in their pregnancy. As a nurse home visitor, I meet mothers in spaces that are most comfortable. I sit with them in their reality. It may seem, what's the big deal? 1 to 2 hours every other week with a nurse. But an hour can be the difference between understanding how to treat your child's asthma symptoms and your child being admitted to the PICU with a severe asthma exacerbation. An hour can be a detailed safety plan for a pregnant person experiencing severe intimate partner violence, a mother of a 3-month-old who is recovering from an emergency surgery and is at risk of losing current housing, being connected to appropriate housing resources despite significant language barriers. An hour is feeling listened to, heard, respected, and supported. Home visiting is building trust. It's consistent presence, showing up, and reliable support. The many hours being there with our participants may mean the difference between experiencing a tragic, preventable complication of childbirth and receiving the care needed to stay alive. The many hours may be the difference between a parent in distress and a parent who is confident in their abilities to build the life that they dream of giving their child. Pretty recently, I read a study that demonstrated that participation in NFP actually led to significantly decreased rates of hypertension and obesity, not only in their mothers, but in their daughters as they grow up. And that's just one small example of the long-term impact home visiting programs have. You're quite literally investing in the future of families and children by supporting and funding home visiting programs. NFP's return on investment is nearly $5 for every dollar spent. You're also investing in the health and safety of home visitors, people like me who have our own families that depend on us, our own dreams, and while we work in the DC community. Every parent deserves to have equitable support to create a healthy and stable life for themselves and their children. Consistent access to home visiting programs with sustainable funding is key in accomplishing this. I ask the committee to fully fund Medicaid reimbursement for home visiting without any delays. Thank you.
Thank you. Dr. Phoenix?
Good morning. Thank you very much for the opportunity to testify. Good morning to the committee, to the chairperson. I want to underscore the need for using Medicaid funds for reimbursement of home services. And that's part of the reason why I am testifying today. I did with a group of organizations, some national, some local. I submitted a request to the Department of Healthcare Finance to include asthma assessment and home visiting in the 1115 waiver that they're working on. So these organizations included the American Lung Association, Black Millennials for Flint, the Children's Environmental Health Network, Children's Law Center, the Coalition for Nonprofit Housing and Economic Development, the DC chapter of the American Academy of Pediatrics, Green and Healthy Homes Initiative, the Impact DC Asthma Clinic at Children's National, the Institute for Public Health Innovation, and Local Initiative Support Coalition of DC and others. We provided really a robust set of evidence for the Department of Healthcare Finance that incorporating asthma assessment and home visiting in the waiver would be at worst cost neutral and at best provide a cost benefit to the Medicaid program. The reason for that is the high rates of childhood asthma, in particular in DC. I won't go into the statistics that support my saying that we have a high rate of childhood asthma, but let me say that there's an equity component to this as well, because children who live in wards 7 and 8 have many, many, many times higher visits to the emergency room and to the hospital for their asthma. So they are costing the Medicaid program a lot of money. And so some of these costs could be recouped if we were able to use Medicaid funding to be able to implement a sustainable assessment and home visiting component in the Medicaid program for children with asthma. So this is not a new thing. New York incorporated asthma into its 1115 waiver and were able to show cost savings. Maryland amended their state plan to be able to use CHIP funds to fund lead and asthma remediation. Wisconsin did something similar with their CHIP program, and California incorporated this into their plan using an in lieu of services provision addition to their state plan. So let me just sum up by saying that the evidence is really very strong that this could be beneficial, especially in communities that have high rates of asthma. DC has implemented it in its Medicaid program, a pilot program several years ago that was evaluated by the Delmarva Foundation that indicated that this can work, focusing on pediatric asthma. So I strongly encourage this for DC, and thank you very much.
Thank you. All right, Stephanie Maltz.
Thank you, DC Council Committee on Health, Chair Henderson, and the council members for the opportunity to testify today. And I apologize if I get emotional because I have been dealing with DC Healthcare Finance and DC Healthcare and some issues about 10, 15 hours the past 2 days. And I'm a little bit happy that we're going through a reauthorization process that has been a disaster right now. So my name is Stephanie Maltz, and I've been DC resident since 2005, and I currently reside in Ward 3. I'm the parent of 2 children. One is neurotypical and one is neurodiverse. My neurodiverse child has a rare genetic disorder and has received Medicaid as a secondary insurance through the Katie Beckett waiver since 2017. There are several issues I'd like to bring to your attention. The first is related to the registration renewal of BC CAS. The second is about access to referrals and authorization. And the third is what's actually done with the with the requested information that parents and other providers are required to provide. The registration and renewal is complicated and confusion. I received information about my child's renewal in July 2023 to be completed by September 2023. There are 4 types of documents that needed to be entered. And for the residency portion, there were the 4 types of documents were Social Security, citizenship, residency, and level of care. For the residency portion, there's a list of 10 to 15 document options. However, none were appropriate for children under 18, as my child doesn't have a license, utility bill, lease. And so I needed lots of communication with DC Healthcare Finance in order to be able to understand the appropriate residency documentation for my child. It was very hard and very confusing for us to understand and be able to complete. In August, my child's eligibility was renewed through September 2024. Unfortunately, in early December, one of our providers my child's used let me know that when they submitted the documentation for payment for services that had already been authorized, HSASN was denying my child's coverage, saying that my coverage had been terminated. I shared the eligibility letter and email with the provider while contacting the Department of Healthcare Finance to determine the issue. There was a glitch in the system, and my child's, although they're telling me that my child's coverage had not been terminated, that provider had to resubmit the paperwork. And since that time, it has had a rippling effect. Anytime we submit paperwork on behalf of my child for any of the therapies or doctors that he sees, it has now caused an additional workload increase on my end because of this glitch to ensure that bills are paid and things are getting processed appropriately and reimbursements are required. So this is an instance where mistakes on other people's end are making it harder for me as a parent to continue to be able to do the things that need to do because I'm cleaning up messes from other folks. The enrollment system also does not provide patients with access to any information or services that have been requested or authorized. When a provider requests services for my child, whether it be an evaluation or continuing therapy services, the provider reaches out to HSCSN for authorization. HSCSN is required to respond to these requests within a time frame, within a 14-day time frame, which often doesn't happen. And to ensure that my child's providers are receiving timely responses from HSCSN, I have provided all of my child's providers email me this request that they submit to HSCSN, and while HSCSN provides the authorization to the providers via email, this information is sent to parents via snail mail and is often received 2 or more weeks after authorizations or denials are sent. Therefore, once I have to keep track of the 14-day timeline and then reach out to HSCSN, reach out to my care manager, my case manager, whoever will give me that information to be able to determine whether services were granted or denied. It'd be so much easier if I was able to have access to this information with electronic system, because getting this information depends on whether or not somebody actually gets back to you. So instead, I'm spending time managing my child's case and care manager to ensure that authorizations are provided to allow my child to get the necessary services. Just last week, I was dealing with something where I got an authorization that said the services were reauthorized for 8 weeks, and my provider got the same authorization saying it was authorized for 6 months. I've yet to date been able to figure out where the discrepancy is and how to fix that. My other issue that I think you all need to be aware of is what happens to the information that I'm required to provide for my child. One example that I think that I want you to all be aware of is an issue. There was an issue with my child's vaccination, that my child receives vaccines back in June of 2019, 5 days before his birthday. Every year after my child receives a physical, I'm required to submit and complete a healthcare form to HSCSN, which I do. My child's vaccine records are also part of documents that I submit each year in order for the Katie Beckett waiver to be renewed. Why am I telling you this? Because in February of 2023, almost 3.5 years later, I received an email on a Friday that my child is not, on a Friday at about noon, that my child is not considered fully vaccinated because certain vaccines were given 5 days before his birthday. And that if I didn't get this resolved within the next 4 hours, my child would be ineligible for Aussie bus transportation. How is it all right for HSCSN to have my child's vaccine record for over 3 years and not tell me that there's no an issue? For the record, in order to figure out where the issue was, I tried to get this resolved through DOH, Aussie, and DCPX. Each agency claimed this is not an issue. I know that I'm not the only parent to have experienced this, but I'm filling out all this paperwork and spending all this time, and then there's paperwork that they had in their system about my child for 3.5 years, and I had 4 hours to fix it. Otherwise, it was going to cause a whole host of issues for my child. This is just one of the many experiences that I have had with HSASN, and my biggest ask is that not to make things more difficult for parents of children with special needs. There are lots of things that I do and lots of ways that I manage things, but every time they make mistakes, it requires me to go back and fix them, requiring more and more of my time. And it's just hearing a lot of the experiences that other folks have had. Those are similar across the board. And it's so hard being a parent of a child with special needs, and it's so hard to find providers, and it's so hard to get services. I'm also currently fighting for the fact that there were services that my son was authorized from February of 2023 to August of 2023. And just last week, I had to have a conversation with HSCSN and DC Healthcare Finance that those services have not yet been paid for. And if they don't pay the provider, there's a potential that my son won't be, that provider will no longer provide services to my son for a failure for HSCSN to pay for those services, which are over a year old. So I am way over my time. Thank you.
Ms. Maltz, I let you go because I know you're super passionate about this, and I'll ask some questions. And just so you know, the deputy mayor and his team are here in the room, so they heard everything that you said. So I'll ask some follow-ups. The 4 other people who are supposed to be on this panel aren't here, so we promoted some additional folks just so we can fill it out a little bit. Dr. Peebles.
Thank you so much, Chairperson Henderson, the rest of your committee and your staff, and thank you for the opportunity to speak with you today. My name is Clint Peebles, no pronouns, a dermatologist and member of the Board of Directors and Advocacy Committee Chair for the Medical Society of the District of Columbia. The Medical Society of DC is the largest medical organization representing metropolitan Washington physicians in the district. We advocate on behalf of all 11,000 plus licensed physicians in the district and seek to make the district the nation's model for patient care and physician practice. We applaud Deputy Mayor Wayne Turnage, Medicaid Director Melissa Bird, and the entire leadership team and staff of the Department of Healthcare Finance. We found their offices to be responsive and communicative. MSCC is also proud to serve on the Medical Care Advisory Committee. All of you and many members of your committee supported B25-124, the Prior Authorization Reform Amendment Act, when it was introduced. The legislation has now become law, but due to a fiscal note, the law only applies to private insurance. This creates health inequity that needs to be rectified, unfortunately, through the budget process. So consider 2 patients. Patient number 1 goes to her dermatologist and is prescribed a name brand prescription for eczema. If she has private insurance and that insurer issued a prior authorization for the prescription, the insurer would 1, need to respond to any appeal of the denial in a set period of time, 2, have licensed physicians reviewing the request and appeal, and 3, be required to offer information to help with any appeal and would not be allowed to make determinations based on cost. Now consider patient number 2. She goes to her dermatologist, but is a DC Medicaid beneficiary. The same prescription may also have a prior authorization, but unlike the first patient, this individual has no support and may be left in a limbo waiting to see if her appeal is denied. The MCO may make a determination on any number of factors, and only quality metrics may determine how quickly they respond. DC area licensed physicians may be involved in the decisions, but they're not required to be. The first patient may have a resolution and her prescription in hand, while the second patient has to wait for her medical treatment, all because of their insurance type. Considering one of the DC MCOs in 2019 denied almost 20% of claims for the district and the other denied 12% of claims, this person has a good chance of not even receiving her medication. Recently, CMS released new prior authorization guidance for public plans that takes some of the same elements as the DC law and puts them into effect in 2 years. DHCF should get started now on complying with DC and federal law and adopt the requirements of B25-124. While we certainly recognize that this is a challenging budget year, this type of health equity issue cannot wait, and the gap in care will become apparent as the district's prior auth law goes into effect. Please reach out to us if our membership can be of assistance on these or any other issues. We really look forward to working with you and the committee to make DC the nation's model for patient care and physician practice. Thank you so much.
Thank you, Dr. Peebles. Andrea Pelham.
Hi, good morning, Council Member Henderson and members of the committee. My name is Andrea Telhami, and I am the Programs Director at DC Greens, a nonprofit organization that advances health equity and build just and resilient food systems in the district. I am here to voice my appreciation for DC Healthcare Finance Partnership in helping DC Greens maintain our produce prescription program. Our organization administers a produce prescription program that provides qualifying adults and children who are Medicaid and DC Health Alliance recipients with a monthly incentive of 80 to 120 based on family size to purchase fresh fruits and vegetables. Produce prescriptions benefit patients by helping prevent diet-related illnesses and reducing healthcare costs. They also benefit DC's economy by reinvesting Produce RX funds into the local economy. Just in 2023, our Produce prescription program enrolled more than 1,600 households throughout the district who collectively spent more than $930,000 on fresh fruits and vegetables, and we plan to continue this work in 2024. Access to vital food as medicine programming through Medicaid has grown substantially over the past 2 years, thanks to support and investment from DC Healthcare Finance through their Produce prescription grant programs. In 2023, with financial supports from DC Healthcare Finance, we were able to offer a program at 18 partner clinics across the district and through all the managed care organizations. We also introduced a new payment technology that allows participants to receive their Produce RX funds via debit card and can be used at Safeway, Walmart, Giant, and Harris Teeter. Recent research shows that participation in Produce prescription programs can lead to improved health and decrease our hospitalization and emergency room utilization. And data on our Produce prescription program has shown similar results. Despite the encouraging indicators and the growing interest for food as medicine initiatives nationwide, current access to Produce prescription programs remains small relative to the need in our city. To truly increase access and meet the need, the district must move beyond grant-based support and work towards integrating these programs into the healthcare delivery and financing systems. This year, the district has a unique opportunity to redesign our Medicaid system and test innovative strategies for addressing health-related social needs through the 1115 demonstration renewal waiver process. DC Green supports the work DC Healthcare Finance is leading on the 1115 demonstration waiver renewal process, and we urge the agency to include nutrition services as well as other health-related social needs and reentry services in the renewal application. DC Healthcare Finance plans to submit later this year. Thank you for your time and consideration.
Thank you. And thank you to this panel of witnesses. Appreciate your testimony and for being here. Dr. Phoenix, if you're still here, I wanted to start with you. It seemed as though you all were working with a coalition of folks to get asthma assessment added. Have you all engaged in a conversation with healthcare finance, and what has been the results of those conversations thus far?
So what we did was to participate in their stakeholder process. They set up a portal in the fall and encouraged organizations and individuals to submit comments to them about what to include in the waiver process. So we participated in that and submitted comments through the portal. I did, when I submitted the letter in January, to Mr. Turnage and his colleagues at the Healthcare Finance, I did offer to make us available for a face-to-face meeting. And so I am hopeful that they'll take us up on that offer.
Okay. We'll follow up on that. Ms. Maltz, thank you so much for your testimony and for being here. And I know this isn't the first time that you've testified. It seems as though perhaps the system glitch that you're referring to is a similar system glitch on another end that the gentleman who testified from La Clinica de Pueblo also talked about as well, where, one side is saying one side, the government is saying, no, the person is approved for care, but the providers aren't seeing it. And that isn't being managed well. Honestly, listening to sort of your experience, it is disheartening. And it's also, I can imagine, incredibly frustrating, because it's a full-time job for you to manage the work of other people who are supposed to be managing the work. Go ahead.
So what's happening now is usually our providers would do our primary and then they would hit our secondary, so we wouldn't get like a bill. So like we use HSCSN usually covers the copay. So since the glitch from one of our provider, our therapist, when my son's seeing like his doctor or his nutritionist or any specialist, what's happening is they're sending me a copay, which they never sent me. And when I call and say, hey, did you run it through HSCSN? They say we did, but it's saying it's turning us down. So then I have to have them resubmit. So correct. So that was an issue that I wasn't having until that glitch. But that is adding, while you may say it's just a call, it is just a call, but they're weekly just calls. And it's not I just call and someone answers. I call, wait on the phone, have to talk to them, have to document so that when I call again. So yes, that is an issue. And that might be anyone who experienced that glitch might be having the same issue. And this is with providers that we've been using for years. So nothing else, as far as I know, have changed. And some of it's MedStar, some of it's Georgetown or Hopkins. So it's happening consistently across the board with everybody now for us.
Right. So that's what I'm saying. I imagine it sounds like it's the system. And instead of somebody fixing the system, but you're the one who you come down to testify. I'm sure that this is happening for other families as well. But the idea that you have to request that anytime the doctor's offices are submitting paperwork, that you also get a copy so you could do a follow-up call to make sure that they get paid is not the system. It's not how it's supposed to work. It's not how it's supposed to work at all. And so we'll ask some follow-up questions on that, but also I'm going to ask for the folks who are here from Department of Healthcare Finance, if someone can reach out to HSCSN to sort of figure this out with you as well. Dr. Peebles, thank you so much for being here on behalf of the Medical Society. I agree with you in terms of the disparity in terms of prior authorization, right? If we say that we want equity across the board, or when we don't even say equity, we say parity in terms of Medicaid and private insurance, having private insurance be able to do prior auth sooner than those on Medicaid. So it's definitely something that we're going to be focusing on as well. And for all the other witnesses, I don't have any particular questions, but someone has testified on your program already before, but I do appreciate you being here, and I hope that you will upload your written testimony for the record. Okay, so we're going to go to our final panel of public witnesses. I just want to telegraph for folks what's going to happen. So we're going to do our final panel of public witnesses. Then we're going to take a 10-minute break, and then we're going to come back, and then we're going to do government witnesses so that everybody kind of knows what's going to happen. So Rajan Thomas, Catherine Crossland, Takesha Presson, Cheryl Baptiste, Kurt Gallagher, Martha Asifa, Samaria Washington, and Jabron Eubanks. Okay, we can just give it a minute while we transition. Again, if you're in the waiting room, in order for you to become a panelist, you have to affirmatively accept our invitation to be promoted. Okay, I see Mr. Thomas. So when you're ready.
Okay. Good morning, Chairperson Henderson, Councilmember Parker, and others on this committee. It is my honor to be able to present my witness this morning, or this, it's still almost morning, it's afternoon. I represent a group of healthcare providers whose mission is to provide care to vulnerable and aging folks within the comfort and security of their places of residence. In addition to skilled services they might need, the majority of care is assisting with activities of daily living, ADLs, and instrumental activities of daily living, IADLs. These so that they can have a quality of life that they would not find necessarily in a facility setting. Testimony has been given with statistics and analysis in this and other council hearings about the mounting staffing challenges that home care agencies are now facing, and we experience that too in our own healthcare agency. Certain DHCF did roll out some efforts to alleviate these, including the retention bonus grants, which was for past services during the PHE. The enhanced living wage supplemental payment also. Here again, it's well accepted, however, not enough to say when opportunities for higher pay and benefits are available outside the industry. So aides continue to leave our industry. We believe that recommendations of the Mayor's Healthcare Workforce Task Force are wisely put forth and should be considered in depth and urgently if there's going to be a timely reduction of the workforce needed to maintain the health of DC residents. We also believe that there are other non-financial issues that home care providers face that could be addressed in a cooperative manner with DHCF and service providers. These include provider licensing and credentialing. Currently, home health aides are licensed by the Department of Health, as well as they are required to enroll as Medicaid providers, 2 sets of licensing. It would be good if this could be integrated. Agency compliance surveys also. We do realize that oversight in a healthcare setting is very important. However, we do need standardized procedures. Some agencies have had a surveyor in their home for weeks, if not even months. I know my time is up. Appreciate this opportunity, and I have a little more to say in my written testimony. Thank you very much.
Thank you. Catherine Crossland. Takesha Preston. Cheryl Batiste. Okay. Kirk Gallagher.
Yes, good afternoon. I believe Dr. Preston and Dr. Baptiste will be with us in just a moment. But good afternoon, Chairperson Henderson and members of the committee. Thank you for the opportunity to testify before you today. I understand that this isn't budget season, but I did want to share with you some challenges that dentists are facing related to Medicaid reimbursement fees and fees that are paid out to them for the care that they provide. I'm Executive Director of the DC Dental Society, and here representing the more than 400 member dentists of the DC Dental Society. Sorry, I've lost my place in my testimony. And again, I'd like to bring to your attention just a looming crisis that is underway that affects those dentists who accept patients who are enrolled in the Medicare program. We want to be and are your partner of the DC government for ensuring and advancing the health and well-being of the populace. But the fact that Medicaid fees have not been increased in 17 years is creating a crisis for those dentists who participate in the program, especially those who have a significant portion of their patient base that rely on Medicare for their dental care and other care needs. You know, for example, the rate that a practice would normally pay on average for an oral exam is $99. The rate that is paid under the Medicaid program, straight Medicaid, is $69 for an adult. And then when you take a look at the rates that are paid by AmeriGroup and MedStar, that rate actually falls to $55.20. There are other cases where the rates that are paid are actually below the cost to provide or produce a device. For example, those who might need an abutment to repair or to help them out with a dental condition is actually, the cost to produce it is more expensive than the rate. One of our member dentists recently paid $385 to produce this implant. And the fee that is reimbursed by AmeriGroup and MedStar Family Group is $240. I'll submit my testimony with additional details related to the fees that are paid, comparisons to average rates charged by dentists for fee-for-service in this region, not just DC, but throughout the southern region. And I hope that this information is helpful. The testimony also addresses 2 other points that I'll speak to briefly. Number one, there are a number of Medicaid dental procedures that are not currently included in the DC Medicaid schedule. So we'd encourage DC Healthcare Finance to take a look at those procedures that are not included and add them in order to keep the standard of care that's provided to Medicaid recipients current with what those who are not enrolled in Medicaid receive. And another practice is actually the bundling of Medicaid fees. Some procedures are much more complex and others just based upon the realities of the situation for the patient. And the fees that dentists are charged and actually need to engage in to provide appropriate care for the patient may be more complex than the standard code. So we would encourage healthcare finance to unbundle a number of codes. We'll provide additional details on those recommendations and provide examples. Thank you again for the opportunity to testify today, and I'd be happy to answer any questions you may have.
Thank you. Martha?
Good morning. My name is Martha, and I'm so excited to be with you, Councilmember Henderson, and it was wonderful to see Councilmember Parker. I work with DC Hunger Solutions, and I'm also a proud Ward 7 resident. And I'm so excited to be here today because for 2 years, I've been a very persistent advocate to ensure that District Direct is as effective as possible. And the Deputy Mayor and Healthcare Finance hold the decision-making power to decide what aspects of District Direct are prioritized and which aspects are put on the back burner. And major system updates can only be done by Healthcare Finance and cannot be fixed by the Economic Security team. From the launch of this combined benefits portal, this has been a big area of tension. And with your help today, I'm very excited to have some oversight. And we've consistently seen that they have not prioritized the SNAP application tech fixes that are so vital for the success of the program. This has created a perfect storm that has led to DC being one of the worst in the country for SNAP application processing times. This means that our residents are waiting endlessly for their essential right to food. Oversight of healthcare finance is critical to ensuring that everything possible is done to ensure that the application process is unhindered and functioning. I am so grateful to you, Councilmember Henderson, for your colleagues White and Parker, for that hearing that you held in December. It provided such clarity and it was really illuminating for advocates like myself. For 2 years, I had unanswered questions and your hearing really helped me gain some clarity. One of the largest takeaways that I had was when the deputy mayor raised the fact that Give SNAP a Raise would take 1 month of implementation just from his department to ensure that the technology infrastructure in District Direct would be ready to go. So in my opinion, continuing to improve and invest in District Direct is critical to make sure that SNAP residents receive their benefits in a timely manner. Healthcare Finance has an obligation to provide adequate staffing, funding, training, and tech support to fix urgent systemic issues with District Direct. One area I strongly recommend is more resources allocated to the tech teams, both at ESA and Healthcare Finance. We believe that a fully functioning District Direct should be a top priority, and we're so grateful because we know with your leadership and oversight, this is going to be realized. I have more depth in my testimony, but lastly, we're here as partners. If there are ways that we can advocate and play a role in fixing these issues, we're ready to step up. I want to really thank you for your time and your leadership. Already, it's made a huge difference.
Thank you so much. Samaria? Okay. Mr. Eubanks?
Yes, good afternoon, Chairperson Christina Henderson and members of the committee. Thank you for the opportunity to testify at this hearing today. My name is Jabron Eubanks. I'm the political organizer with 1199 SEIU. We represent 400,000 workers across the healthcare continuum in hospitals, clinics, and skilled nursing facilities in the District of Columbia. And I'm here today testifying on behalf of our members and all the district's healthcare workers who are struggling to make ends meet on low wages and are unable to provide the critical care for their patients due to severe staffing shortages. The direct care workforce is in a crisis, but I'm hesitant to use the word crisis because I feel like its impact has been diminished. We have exhausted that language since nursing homes became the epicenter of COVID-19 pandemic 4 years ago. That pandemic has highlighted the brokenness of our long-term care system, and these workers who we once called essential are feeling more burnt out and underappreciated than ever. In DC, as we know, the aging population continues to drastically increase, and so will the demand for direct care workers. We've reviewed the recent data from DC Board of Nursing, so I'll spare you the numbers. But DC ranks dead last in nation for wage competitiveness for direct care workers. You can earn more as a dog walker in DC than as a nurse, and it wouldn't require hours of training or rigorous testing. While DHCF has taken some steps to increase the wages for home health aides, they do not go far enough towards making those wages a true livable wage. And in cutting nursing home reimbursement, DHCF has created even more roadblocks to raising wages for district CNAs and the other entry-level positions in nursing homes, such as dietary workers and housekeepers. An aspect of my job that drives me the most is fighting for better wages for our workers, solely because of the stories that I hear. When I speak to our members, their number one concern is always the patients. When asked what their toughest challenge is, it's knowing that they can't provide high quality care to residents due to being short-staffed and overburdened. When asked about wages, they just want to be able to pay for their mouthpieces and cleats for their grandson's Pee Wee football league. These are genuine good people with huge hearts for fighting for basic necessities, yet every day they get up. Some take 2 buses, a train, and an Uber to show up for their patient, because a lot of times the worker is the worker is all the patient has. This work is mentally draining and physically demanding, but they do it because they care. They care for our elders when we are not able to do so ourselves. As someone who has had a family member who battled Alzheimer's for 12 years, I fully understand the importance of this work. My aunt, who was bedridden and could not do anything for herself, needed a home health aide and a personal caretaker. Our HHA, Miss Sylvia, became more than just a worker. She quickly became family. My uncle was a politician and was away from home a lot at community events, fundraisers, and other work-related activities that required much of his time and attention. While he was away, Miss Sylvia would feed, bathe, and physically move my aunt so she wouldn't get bed sores. Miss Sylvia did a lot more than just what was on her job description. She would read to my aunt, even though my aunt was far past speaking. We like to think that she could still comprehend us. She would cook spaghetti for my uncle so that he would have a home cooked meal to come home to. And then she would text my mom to let her know that there was plenty of leftovers for me. Oftentimes I would come in and she would just be laying with my aunt, brushing her hair, as if to reassure her that she was still pretty and there was someone always there for her. What our HHA Miss Sylvia did for our family is way more than we could ever show the appreciation for financially. So when I think about what a hero is to me, I like to think about the dedicated people in this workforce. And families like mine really depend on us to center the needs of elderly and disabled residents. I know I'm past my time, but thank you.
Thank you. David Freeman.
Council Chair Henderson, first of all, I want to make a special apology for not making it in my normal time slot today. And I really appreciate your staff's responsiveness and willing to fit me in here. My name is David Freeman. I'm a senior director at Community Connections, where I have worked for the past 33 years. The business of mental health has dominated discussion of the MCO carve-in on April 1st. With increasing intensity, we've been talking with DBH and healthcare finance about credentialing, authorization, service definition, revenue cycles, CAQH, CARF, NPI numbers, and billing rules. Despite these urgent discussions, a lot of decisions still need to be made over the next few months. I spoke in some detail, for example, about the importance of community support services in my testimony for DBH oversight. As we frame these future discussions with healthcare finance, it's essential that we keep the consumer perspective and experience in mind. In my experience, consumers care about community, competence, collaboration, clarity, and compassion. First, community. Clients and staff are excited about working together to build a stronger community with stronger people in it. Second, competence. Clients want to know that they're being helped by a competent person, a person who is well-trained and held to a high standard. They want staff to facilitate efficient access to resources while employing mental health savvy about helping people overcome obstacles when they have a mental illness. Third, collaboration. Clients want to know that the helping person is interested in being collaborative, in sharing power, and in amplifying the client's voice. Fourth, clarity. Clients want to know what the rules are, and they want those rules to be clear and transparent. And finally, compassion. Clients want to know that they're being helped by a compassionate person, somebody who understands what they're going through, somebody who accepts the ironies and ambivalences, the tragedies and joys of life. Clients want someone they can trust with their complex feelings, with their personal struggles, with their hopes and fears. Our discussion about carve-in and policies and procedures, profit margins and efficiencies will be grossly incomplete if we do not intentionally focus on the human side of our business. My ask today is that the Health Committee remember and advocate fiercely for the human side of the healthcare equation. Without that human side in the forefront of our minds, I fear we will be really lost. Thank you for your time.
Thank you. And thank you to this panel of witnesses for your testimony and for being here today. Mr. Eubanks, I want to specifically say thank you to you for sharing your personal story in terms of the care that your family received from a home health aide. As we've heard from the testimony from others, we'll have some questions for healthcare finance about some of those pieces today, but we're certainly going to try to move forward in looking at this issue in the coming months with a more comprehensive bill. Ms. Asifa, please, thank you so much for your advocacy and the work of the DC Hunger Solutions. You know, I'm glad that you saw that last year's hearing on the public employment benefits provided some clarity. I still have questions, so it's not necessarily clear to me. And nor have we seen the changes that we wanted to see in terms of the backlog. We still have a backlog of SNAP applications, TANF applications, and Medicaid renewal applications all still pending. And so we want to make sure that we're getting through that, and we have some questions, some further questions on that front. Mr. Gallagher, I look forward to receiving the additional information that you provide about the fees. You know, we often talk, when I talk to our various professional boards around, you know, asking questions why their members aren't accepting Medicaid, the fees or the reimbursements are the number one thing that they talk about. The reimbursements are too low. The reimbursements don't make it worth it, especially when the private insurance companies are doing something different. Or if they could just, you know, fill up their whole patient population with folks who don't need insurance at all. Mr. Thomas, you and I have met, and we talked about the home health aid situation. And like I said, we'll ask some questions and certainly work to address that. I don't have any specific questions. Mr. Gallagher, I see you have your hand raised.
Yeah, I believe Dr. Cheryl Baptiste is in the waiting room. She had trouble finding your link. I don't know if it's too late to let her in.
I could let her in for the 3 minutes. We are like, she would be literally the last public witness to testify because we are going to wrap up. But we do not see her in our waiting room.
Oh no.
So I'm holding a hearing for a.
Yeah. I don't know what happened. She might be, she disconnected. I don't know. She was in there, so I apologize. So.
No problem. Okay. So, you know, she could certainly submit written testimony for the record that we'll take a look at. That concludes our public witnesses for right now. As I alluded to at the beginning, at the top of this panel, we are going to take a 10-minute break. And then when we come back, we'll hear from Deputy Mayor Wayne Turnage, who leads both the Department of Healthcare Finance, as well as he serves as the Deputy Mayor. We are, I might even call it recessing, but we're going to take a break for 10 minutes. And so, well, yeah, 10 minutes. We'll be back. Okay, we are back. Now call up Deputy Mayor Wayne Turnage and his team to provide testimony to the committee. It looks like the DMHHS team is up first, and then we'll do the healthcare finance questions thereafter. But before you begin, you just swear you all in. So I'll ask that you or any members of your team who might testify today, if they could raise their right hand. That's all, y'all. All of you. There we go. Great. Do you swear or affirm under penalty of law that the testimony you're about to provide to the Council of the District of Columbia and this committee is the truth, the whole truth, and nothing but the truth? Great. All right, Deputy Mayor, when you're ready, please begin.
Good morning, Madam Chair, and members of the Committee on Health. My name is Wayne Turnage, and I serve as both the Deputy Mayor of Health and Human Services, as well as the Director of the Department of Healthcare Finance. To discuss the performance of the Office of the Deputy Mayor, I am joined by, both at the table, by key members of my staff. They are quite exceptional. The Chief of Staff, Kiana Creighton, our Deputy Chief of Staff and Director of Encampments, Jamal Weldon, our Policy Director, Brian Harris. We have to our right, we have Jane O, who is one of our policy representatives, and we have a very newly minted Communications Director, Rebecca Dooley, and we have our brilliant Gail Cohn, who is runs our programs that deal with making this city more livable as we age. We have a full organizational chart on slide 4. And I should note that while the chart indicates that the Director of ICH, I believe she's here, Teresa, reports is within our office hierarchy, that is probably not the best way to report it, because I think statutorily she reports to the city administrator. If you would turn to slides 6 and 7, they provide a brief highlight of some of the major activities across the cluster. And while we do provide oversight and technical assistance to these 7 agencies, my testimony will focus on the performance of my office, thereby leaving the specifics of the policy and operations of the 7 cluster agencies to each of the relevant directors, which they will cover during their performance hearings. So in my presentation today, I will cover our work on encampments in 2023, discuss the follow-up results to the care palette, and highlight the status of our work on age-friendly DC. I would begin by talking a little bit about our encampment response team. This is our encampment management efforts are expertly led by the Deputy Chief of Staff and Director of Encampments, Jamal, who is responsible for managing and executing the district's encampment protocol, which is emblazoned in the CA's document that was probably put together, I think, before I came on board, or maybe shortly after. Certainly before I came on board as the Deputy Mayor. And he is aided by our legal advisor, Sakina Thompson, so that she makes certain that we don't go off like cowboys and not being respectful of statute and regulations and protocol with respect to how we manage the encampment. She provides invaluable legal insight and tremendous guidance on the issues surrounding the management of encampments. I will say, before getting into the data, that encampment management is perhaps one of the most difficult responsibilities which I have been entrusted, not just in this job, but over the span of my 40-year career. I don't think I've ever worked on an issue that was so difficult for so many reasons. The countervailing forces that surround and define and impinge on the issue make almost any decision that we execute controversial. We make every effort despite what our critics say, to operate in the best interests of those who live unsheltered, while being cognizant of district laws, regulations, and policies that govern the work that we do. But it is a very challenging set of problems that attach to the problem of the moral scourge of homelessness. If you turn to slide 9, you will see that in 2023, we counted over right at 100 encampment sites. Now, there were probably more tents than sites because some residents use, one tent to sleep in and another one to place their belongings. So you had 194 tents or structures at those 100 sites. And you had, by the latest count, 210 people as of January of this year counted in the census of people who were homeless. Outreach staff says about 7 of those 194 sites are really new sites, and 13 sites either disappeared or have gone inactive. By far, the heaviest concentration of structures and people who are living unsheltered is in Ward 2. And a lot of those tents and structures are on federal land. And so we don't have the authority to do anything on federal land without the permission of the National Park Service, which we regularly work with when there are issues on a given encampment that sits on federal land. So when is the encampment response team activated? And it is simply when there is a site that poses a health, security, or safety risk, or, and this is probably one that is not that clearly understood by the public, but it is in both policy and statute. It's when that encampment interferes with the community use of a public space. So given those criteria and that legal underpinning, the encampment activity could be probably far more aggressive than it is. And I don't think we are that aggressive, to be honest, because we always, except under extreme circumstances, give deference to weather. And we certainly have not acted to clear, as they say, every site that we have encountered in public space. But in some cases, and our team is pretty good at distinguishing when they should and must act, and they do. The protocol governing the management of these sites is outlined, sort of reflected graphically on slide 11. We have, as you look at the number of engagements, you will see that the immediate dispositions represent half of the 82 engagements that we executed in 2023. Immediate dispositions are when we deploy an engagement because there's a public health, safety, or security hazard that doesn't allow for a standard notice. We will work in those cases to provide 24 hours notice if possible. And we also typically have DHS, DBH, DPW, and the outreach contractors on site. I know there was some testimony from a gentleman that I have great respect for. He's a very smart guy. And I think he got his law degree from Georgetown. I think he spoke this morning. What's his name? I got his name. But I met him at the community meeting where we had the Afton. He is urging you to put in guidelines to tighten the parameters around when we can do an immediate disposition. He believes we to haphazardly use in his words, the excuse of public safety, health, and public hazards to clear a site. And while I have great respect for him. He's a very smart man. I disagree with him on that point, only because I know my staff and I know, how they work and how careful they are about when a site can be justifiably closed. 43 of the engagements were full cleanups. These do come with a 2-week notice, and it is the goal is to remove all bulk trash and hazardous materials that can impact the health and safety of the area if they're not, if those issues are not addressed. And those health and safety issues will impact not only the community, but also the residents of the encampment. And then a much smaller number of the engagements were trash-only cleanups, and that is as we describe it. Get a lot of comments about site closures. You would think we were closing sites every day. In 2013, there were 16 site closures in the city. 13 of those sites were closed by my office, and 3 were closed by the National Park Service. The most recognized, if I'm not getting my years mixed up, I forget what year I'm in most days, was McPherson. And one of the things that we have to be really careful about when dealing with encampments, if there's an encampment that starts and you see it growing daily or weekly, you can be almost certain that it's going to reach a point where it can no longer be allowed to exist on that particular site, because with encampments come a host of problems. And if those encampments if they grow, those problems will magnify. If you turn to slide 14, I know there have been a lot of questions about the care palette. The report is on our website. I knew you were going to ask about it, so I asked my staff to put it up. So we did put it up. And it's an excellent report. As one of its authors, I say so myself. But it's excellent not because, I helped write it. It's excellent because of the work that it reflects and the success of that work. If you recall, it was the summer of 21 when the mayor authorized the development and implementation of CARE, and it was done in response to the proliferations of tenant encampments across the city. And while we had successfully reduced the rate of family homelessness in years leading up to the pandemic, for unhoused single adults, and ICH always likes to remind us of this, the lack of an available supply of affordable housing generated an imbalance in the number of people who were seeking housing assistance from the district as individuals, and those compared to those who were exiting the system with a housing placement solidified. And of course, the pandemic exacerbated this problem tremendously. Because, when the pandemic hit in March of 2020, there were no vaccines. And the guidance from the CDC was that we should de-intensify shelters. Take away some beds because they didn't want people in such crowded spaces. They also, there was sort of a layer of mitigation, which at first it seemed odd to me, not really understanding how this vaccine, how the virus worked. Because then the result was as we expected. It caused people to go outside and live. So we saw a 40% increase in the number of tenant encampments across the city. There was that rate was 8 times higher than the actual increase in the overall rate of homelessness. So people clearly gravitated from inside shelters and moved to the streets. And that those moves were facilitated in large number by the fact that the streets were vacant. Nobody was working, businesses were shuttered. And so, folks who needed somewhere to shelter could basically live anywhere they wanted to. So you saw an increase. But as the size of those encampments increased, we saw a substantial uptick in the number of factors that result in a closure. There were biohazards significant biohazard problems because you had so many people living in small areas. There were tremendous rodent infestations, fire hazards. You know, a couple of people lost their lives because of fire. There was they clearly intruded into public space. One park was completely taken over by tenant encampments. And there was sporadic but deadly violence. You know, people got killed, and there's no two ways to say that. You know, people were killed in some of these encampments. And so what that did is increase the tensions between the community and the encampments, and of course the administration. I get lots of emails from lots of communities, people just blasting us for not doing more to close encampments. And I said, well, why don't you come to the public meeting to speak on some of this? And they said, no, we're not gonna do that. But then I get 3 times the number of emails from people who are offended by the work that we do and who believe that encampments should not be, encampments should be allowed to exist unfettered. But we undertook the pilot under Jamal's leadership, working with the outreach providers. We selected 4 sites, and those 4 sites had, as this chart showed, 139 residents. At that time, that was 55% of all persons who were living in tenant encampments. First thing we did was the first thing we tested was how many would engage, how many would, you know, agree to work with us, and we were offering housing, and the engagement rate was 80%, very high. And of those who engaged, we were able to put in a leased apartment. In one case, it was bridge housing, 91% of those who engaged. And those numbers were phenomenal. And I think even, you know, and probably not getting the report out a little bit sooner served to, you know, create the suspicion that the care pilot was a failure. It was anything but. It was very, very successful. And I think we spent about $4 million, which is peanuts, given the nature of the problem. So the question we have been often asked since the encampments, since the care pilot ended, and we still track the people who were in the pilot, is how are those folks doing now? Because one of the criticisms, and this came from one of the council members, as I remember, you know, you're using local funds because you're trying to rush people into housing, and you don't have time to get ready. You don't even check to see if they're eligible for PSH. I said, well, we do check, but we are rushing because people need housing. And one of the goals of the care pilot was to see what would happen if we bypass some of the district's rules about what you had to do before you got housing. And so we did it, I think, 2 or 3 times faster than you would normally see. So there was a concern, and there's a legitimate concern that, you know, where the federal government could have been subsidizing these leases, we would end up paying for all of them with local money. So that's one of the things we wanted to see. So to gauge the longer-term success of the pilot program, we tracked the status of these participants through December of 2023, which is 18 months from the end of the pilot program. There's a graph on slide 15 that shows you the follow-up outcomes. They are equally, if not more impressive than the care pilot program outcomes. The engagement rate that was so impressive at 80%, it went up to 83%. The lease rate went from 90% to 100%. So everybody who engaged with us by now had a leased apartment. Now, that pie chart at the top on the right of the graph addresses the issue that was raised. Are you doing all this with local money, or are you still using PSH vouchers? Because of the tremendous tenacity of the outreach workers and Jamal and his team, the application process can be difficult, particularly when you're dealing with folks who are unsheltered and whose documents are not easily found. But 58% of those people who were placed were on PSH vouchers. 38% on local funding, so that ticker is running as we speak. And there were 4% of those who were placed abandoned their units. So we always want to know why people are still on local subsidy. You know, the biggest reason is most of them are in transition to PSH. Some have stopped the process of trying to get on PSH because they want a new unit. And unfortunately, 23% are still waiting for a voucher, which is, a problem. But it does not mar the success that we witnessed with the care pilot and the follow-up. So I don't have any hesitation or equivocation in saying that on balance, despite all the critics, the mayor was certainly wrongly criticized in this whole effort. I was castigated and called everything but a child of God. Jamal was almost assaulted on sometimes, and he's a big man, but those folks get pretty aggressive. Despite all of that, these numbers validate the success of what he did and what the outreach workers did and what the mayor did by improving this. This was a great project. Now, the goal was to obviously replicate it citywide and remove everyone from a tenant encampment. And then we had issues with all kinds of budget problems associated with, I wouldn't call them budget problems, I call them caseworker problems. DHCF just doesn't have enough of them. And so while we have the vouchers, we don't have the workers to execute the process more expeditiously to clear people. But if you look at the care pilot and the model that it set, there's no question but for the fact that it was a great success. The last issue that I will talk about, and I will talk.
Deputy Mayor, you've
Yeah.
been going for 20 minutes now.
Okay, I'm done then. If you want, we can take your questions.
Great, let's do that.
I do want to say, and certainly recognizing Gail and all the great work she's done with Age Friendly DC, that a process for the strategic plan moves forward, and we're still doing great things there. So we are ready for your questions.
All right, awesome. Thank you. Thank you for you and your team. I'll start with my questions on homelessness encampments. There's another hearing that's going on upstairs, but I know that there will be some colleagues who will be coming in and out. So when they get here, we'll turn on the clock and go from there. But let's start with some follow-up questions about care, the care pilot, and I appreciate you guys posting the report. I went to the city administrator's hearing yesterday and asked him about it, so I appreciate that. So the decision not to continue the care pilot in FY23 and the pre-hearing responses, you all said all decisions regarding potential future expansion of the care pilot program is currently in abeyance while DHS works to decrease the current backlog of residents who are waiting to be matched to eligible housing resources. I think you talked a little bit about this in terms of the need for caseworkers.
Yeah.
I'm curious to what extent you all in the DMHHS, your DMHHS hat on, how you're helping to facilitate with with DHS, the reduction of the backlog.
That's a tightly held agency operational issue. We will respond to requests that they make for resources to eradicate the backlog, but the operational decisions on how it's done and monitoring the effectiveness of it, we trust DHS. The challenge has been they have requested lots of positions, but then we look at the vacancy rate for the existing positions, and we come to the conclusion that sending down a bunch more FTEs will not resolve the problem. We have to find a way to find caseworkers who want to do this work in the numbers that we need. Mm-hmm. So I don't think the backlog is a function of not having resources for caseworkers. I think it's a function of not having caseworkers.
Okay, so is it, in terms of the analysis of the issue, is it a salary issue? Is it why don't people want to become caseworkers at DHS? The easy answer, and I would say the lazy answer, is salary. I don't think that's necessarily true. Okay. Certainly, if you put an advertisement, you're going to pay social workers $300,000, you won't have a problem with caseworkers. But that's not realistic. Right. It would be above what the market would dictate, and it would be unaffordable. So at the margins, salaries might matter a little bit, but I think it's also it could be the difficulty of the job. It's a
particularly if you know you're going to be doing what we need you to do, and that is work with folks who have been, some of who have been experiencing homelessness for a long time, to make sure they can work through the maze of bureaucracy to get properly documented and into a lease unit. That's heavy duty work, and some people, particularly after the pandemic, may have lost their appetite for it.
Okay. That's something I want to keep talking about. So we have a bill that's pending in the committee, which it's controversial. So the idea is that if we get rid of the exam requirement to become a licensed social worker, then all of a sudden we're going to have this increased number of people who become social workers and therefore want to be case managers. I'm not entirely sure that is the progression. And such a move is being opposed by DC Health as well as the Board of Social Work. So we're trying to work through that. Of course, I have lots of folks in the social work community who are saying, you know, the exam is racist. Well, any exam could be considered as racist, whether it be the nursing exam, a doctor exam, a psych exam, et cetera. So I don't see those professions who are actively asking us to get rid of their exam to address some of the health challenges. But it's something that I feel like we have to figure out. It is very frustrating to be in a situation where we have a voucher. I have a person who is homeless. I have a voucher for you, but the only impediment is that I don't have a case manager for you. Like that's a weird problem for us to have in the district.
I don't disagree.
Okay. So even though the CARE pilot didn't continue in FY23, you all reported spending about 1.1 million on encampment specific outreach and equipment. I'm assuming that this is funding specifically for Jamal's team.
Yeah, probably Jamal can address that.
Okay. I'm curious, Jamal, in sort of your response, how these funds were spent in comparison to what you all spent it on in FY22 when the pilot was going on.
Thank you, Madam Chair. Well, a good portion of that was also going towards the funding for the residents who are still currently housed under the local funding of the CARE pilot program. So again, that is ongoing until they're able to be transitioned to a PSH and or rapid rehousing voucher or subsidy per their eligibility. And of course, the variety of different supplies and efforts through our outreach with the DMHHS and Encampment response team that we render on a weekly basis, whether or not it's during the hypo or hyperthermia seasons of the year. Everything from cooling towels, hand sanitizer, blankets, water, whatever the case may be, we've been very diverse in the array of services that we can offer.
Okay. So in the documents that you all said you spent 1.8 million for quote client related costs associated with encampment clearings. Is that the funding for the housing or is that something different?
Yes, that is the funding for the housing. Yes.
Okay, so that's funding for the housing. So, all right, are these on two different line items? No, just kidding. Okay, you've spent 1.1 million on outreach staff and equipment. That's one line item. 1.8 on client related costs. That's another line item. Yes?
Yes.
Okay, so about 2.9 million altogether.
Yes.
Okay. All right. Deputy Mayor, you talked about one of the public witnesses earlier. I think it was from Legal Society, Mr. Drumming. And he expressed, and I've heard also from some residents, that they have a misunderstanding of the term clearing versus cleaning, which I think is important in that the notification requirements are different for each of the two. And so they've also said that several times where the district has posted notices of a cleaning, but residents have had their belongings removed. Do you want to speak to that?
Yes, so as previously stated, anytime a full cleanup or a trash only cleanup engagement has been scheduled, there is no less than a 2-week notice posted. During that time frame, ongoing outreach is rendered to be able to make sure that all residents who are present or identified at that site have been duly informed. Any additional resources that can be offered to them prior to are conducted. And on the day of, as was previously stated, there are a number of outreach teams and interagency partners that come together to render final efforts in assisting them before the actual cleanup engagement. And I will be clear, cleanup, not clearing. When it comes to the immediate dispositions, as previously stated, if there is a health and safety concern that does not offer the ability for us to render a 2-week notice, it is something that is detrimental to the community at large and or the resident themselves, whether or not it's the physical placement of the encampment or the variety of items that may reside at an encampment, such as bulk hoarding, such as a large variety of propane tanks, which would be a fire hazard, things of that nature. We normally, in most cases, when I say most, I'll say 95% or more, will render a 24-hour notice. Now, this is only after outreach engagement has been rendered to that site, requesting that the resident work with us to downgrade or remove these hazardous items or relocate their encampment to a manner that does not put them in harm's way. For example, someone encamping on a median in a traffic intersection, something of that nature. Those cases will require an immediate disposition. Again, normally with a 24-hour notice, and the same process of the multi-agency approach is rendered as well.
Yeah, okay. I was thinking about that in terms of like, if someone were in a median, to provide a 2-week notice if you all feel strongly that, right, one wrong action could end that person in terms of a car popping up a curb or something to that effect. Understood. So what's the difference between a full cleanup and a trash only cleanup?
A full cleanup requires the resident and any items that they wish to keep, whether or not it's their tent or any other items, they would have to temporarily transition from that space, normally within, outside of a 200-foot radius of that encampment cleanup zone, allowing for all other abandoned trash or hazardous materials to be removed either by our biohazard contractor or our DPW partners.
Okay. I appreciate that clarification. Now, in the chart that you guys had up in terms of the number of people who had been housed via care, and you had 4% of the individuals had abandoned their unit. Have we done any outreach to kind of figure out what happened there?
Yes, that outreach is still ongoing. Now, unfortunately, some of those residents have completely severed their engagement with case management and service connection. However, they are still known to the care system and to our service providers, so that outreach is still ongoing.
Okay. When you talk about, well, never mind. I know the answer to that question. Okay, never mind. Okay. In the pre-hearing responses, you state that the encampment team posts the number of scheduled cleanups or dispositions on the agency website annually for public consumption. Where is that list posted?
That list is actually currently posted at the bottom of our encampment page of the DMHHS website.
Thank you. Sticking to homelessness, but moving to ICH, of the 8 required seats, excuse me, on the ICH for continuum of care providers, only 3 are currently filled. You're working with MODA to nominate new members, but have you sent nominations and they just haven't been processed? What's happened here?
Teresa did send some over, but she's probably the best source of where they are in the process. She handles that.
Okay.
I can certainly check with her. I thought she was here, but I guess she stepped out.
Oh, okay. So she's not here. Okay.
Excuse me, Councilmember, she's gonna come back down, but I believe she submitted some. She's just waiting on MODA to actually get back to her.
Okay. All right. And I had another question for ICH, so I'll just hold until she gets back in. All right. Let's talk about opioids and your role as the deputy mayor in sort of coordinating some of this. So we're currently in the middle. Well, what's today? It's the 8th. Okay. So we're still currently in the middle of a mayor's emergency on opioids. At the DC Health Oversight hearing, Dr. Bennett discussed the need for overarching goals on opioids and substance use that cross health cluster agencies. Specifically, we discussed how DC Health has a framework for improving community health model that sets specific goals and then annually reports on our progress towards those goals. Could DMHHS be a coordinating body to develop these types of goals and metrics and hold the agencies in the cluster responsible for making progress?
Yes, we could do that.
Okay. I was going to say, if not you, where else should this be housed? But I think that when I think about substance abuse issues, it's so cross-cutting.
Yes.
It's not just within the health cluster, obviously FEMS and OCME, and even DFS plays a role, because I say DFS because they have the public health lab that does a bunch of the syringe testing. But I know that we have Live Long DC, but it feels to me like we just need some very clear, here are our 10 goals of what we want to do. And then this is what we're going to do to make it happen. And then every year we're just tracking our numbers, because right now it kind of feels like we're like throwing spaghetti at the wall and seeing what sticks.
We can do that.
Okay. In your pre-hearing responses, DMHHS describes being an active participant in the interagency DC opioid working group. How often does that meet?
I have delegated all of the opioid abatement commission meetings and opioid stuff.
No, this is
Kiana.
different. This is not the commission.
I know, I'm just saying, opioids falls under Kiana.
Okay. You just introduce yourself for the record, Kiana.
Sure. Kiana Creighton, Chief of Staff to Deputy Mayor Turnage. And Jane O'Brien, please correct me if I'm wrong, because Jane actually is a representative on that one. But I believe that particular group is on a monthly basis.
Okay.
We can also send you the schedule because there's a couple overlapping groups at DBH, and a couple of them were sunsetted briefly and now they're back in the rotation. But that one I believe is on a monthly basis.
Okay. And so what goals and benchmarks has this group put in place? So I guess I'm trying to, we have 50 million and 11 working groups and task force on many of them having overlapping same thing. So I'm curious, like, what's the goals of this particular group? I know what the commission does. I sit on that, right? That's about recommendations for money for abatement funds. Let's put them to the side. What does this working group do?
So, and it might be helpful for us to send a chart about this, but a lot of the other work that we participate in with DBH has to do with the Live Long DC. And so we're currently waiting for the third iteration of the report.
I know, we've been waiting since October.
I actually can also include that as a follow-up. But I think that's actually, Councilman, you're speaking to one of the challenges that I think exists, is that sometimes there hasn't been a clear delineation of how the groups are different. And so what happens is you have the same people who are serving, in some cases, in 3 capacities between Live Long DC, the opioid working group, and the opioid abatement commission.
Right.
And yet we're not having a synergy throughout. So I think you're highlighting some of the challenges that we're also experiencing.
Okay. Along with not just having synergy, but literally just having goals. Well, we've been in the commission meetings. Melissa's been in the commission meeting with us. Deputy Mayor, I wish you could join us for a meeting so you can understand.
I fully understand what you all are going through.
There's conversations happening, but I feel like some of it is directionless. And so I think we just need to given that our numbers are still going up, I think the latest OCME numbers have us still on a trajectory to be higher than where we were in 2022, that we have to sort of pull this together and get a plan. I was going to ask about Live Long DC, but you took that note, so I'm going to move on from there. I think, is ICH back? Great.
Yes.
All right. Can someone make space?
Yes.
Hello, how are you? If you could just introduce yourself for the record. Oh,
Sorry about that.
thank you.
Is it on?
Yes.
Okay. I'm Teresa Silla, Executive Director of the Interagency Council on Homelessness.
Great. Thanks for joining us. So the first question that I had asked earlier, but Ms. Creighton kind of answered. So there are 8 required seats on the ICH for continuum of care service providers, but only 3 are currently filled. Have you sent names over to MODA for the other 5 seats?
Yes, absolutely, we have.
Okay. When did you send them?
Oh, the actual transmittal date?
Or I'm trying to determine how long it's been since you sent it and then there's been action.
I can get back to you on that.
Okay.
But I don't know off the top of my head.
Okay.
No.
Additional context for you. So
Yes.
we have 19 boards and commissions that are under our committee's purview. There are lots of times where I ask the agency, hey, we got these vacancies. We've had such vacancies for X. They've said, oh, we sent names to MODA 6 months ago.
Okay.
I just need to know if I need to have a different conversation in terms of not coming to you guys, but going to EOM to say, hey, what's happening here? Because the names were already sent.
Would you like a follow-up in writing post-hearing?
Yeah, we'll add it to our list of follow-ups.
Absolutely,
Okay.
not a problem.
In the pre-hearing responses, you all stated that the Interagency Council on Homelessness is currently working on a better way to track progress towards its goals than the present action items under Homeward DC. And that this, well, I'm curious, why was this KPI no longer useful way to track the ICH process?
Oh, so the system level KPIs that are immediately available to us, they don't speak to the specific strategies, activities, and objectives that are listed in the strategic plan. They speak to how many people are experiencing homelessness overall at a point in time and annually, how many people are we able to house, you know, and other like larger system metrics like that. They don't track with the 160 activities that are listed under the plan.
Got it. So you want the KPIs to better align to the strategic plan?
I'm not actually sure that it is reasonable to expect for a performance management infrastructure or framework that tracks on 160 activities. We need to be doing something different.
Okay. All right. So that work is ongoing to sort of figure out what is the new metric or tool to
Framework.
framework.
Yes, what is the appropriate framework for tracking, performance. So if I may elaborate.
Go ahead.
There's likely a set of different levels at which we need to be tracking performance. There's the level of the system and the outcomes that we want to see from the system. There's the funder level, right? Because funding entities like DHS is funding multiple programs. And then there's probably like a program specific or a provider specific level that we should be tracking. And then last but not least, I think everybody's looking to understand how do we evaluate the performance of the ICH itself, the committees and work groups? Do we really have a robust framework for advancing strategic planning, right?
Okay. So what's your timeline on, I guess, what you hope to come back to the ICH with in terms of the new framework?
So we're planning on proposing a framework to the strategic planning committee, the next strategic planning committee meeting.
Okay.
They just met in January. It's a bi-monthly
Okay. So March.
meeting. So about March is when we would be proposing a framework. And then we are also hoping to leverage the performance plans that are managed by the city administrator because there are so many contributing agencies. So in terms of tracking effort appropriately so that that's not the responsibility of my small team, we are trying to leverage their performance management infrastructure and make sure we're aligned with that. So that might take some time to realize.
Okay, great. All right, awesome. Deputy Mayor, I want to check in on Cedar Hill.
We have whole,
Oh, it's not a DMHHS.
well,
You're mixing. Ben's behind you.
yes, Ben Stutz now works as the Chief Operating Officer for DHCF, and in his spare time, he continues to manage and provide oversight of the Cedar Hill project. So all of the status updates were put in that briefing that we would offer next.
Okay. All right. Well, those are the ending questions that I have for the deputy mayor work. So thank you to that team.
Sure.
Congratulations, Ben, on your promotion.
Yes,
Great.
promotion.
Uh,
Credit for that.
All right. So I'll give you all time to transition.
Okay. Thank you. All right. Explain to him, yeah.
Councilmember Henderson, just wanted to flag for you regarding age friendly, because we didn't get to discuss it, that the next version of the establishment order and the associated report are in the IQ process, but just recognizing that the first was 2018 to 2023.
Good man. Appreciate it. Yep. Yes, sir. Where's Ben? When we get the seat here, you can rotate in where Angelique is. Hope I get to this one. Oh, you waiting on me? Oh, I'm sorry. I thought it was, good afternoon again, Madam Chair. And now I want to thank you for the opportunity to discuss the performance oversight for the Department of Healthcare Finance. In my capacity, as shown on slide 3, as DHCF Director, I work with an executive management team that is absolutely steeped in considerable knowledge of the Medicaid program, and they have and can boast of years of healthcare experience. We have an agency that is staffed with outstanding policy and operational managers. My slides are not numbered the same way those are, but that's all right. And we have great line staff. I see, okay. We have outstanding policy and operational managers and great line staff, and we have an absolute dynamite team of data analysts led by April Grady. We do significant data work in the agency to try to understand a $4 billion program and make wise decisions. When we can't be absolutely right, our goal is to be less wrong. So, and we work very hard at that. If you turn to slide 4, you will see that we looked at the latest distribution of Medicaid beneficiaries and Alliance beneficiaries across the city, especially given the historic increases in the number of people who are receiving these benefits based coming out of the pandemic. And while the numbers of overall beneficiaries have clearly grown, the distribution of where they live is largely unchanged. You know, the Ward 7 and Ward 5 and 8 constitute the areas that where you found the most Alliance and Medicaid beneficiaries. If you jump to slide 6, and I'm gonna move fairly quickly because I know you want to get to questions, and you've seen a lot of this before. We've updated the redetermination report. You know, if you count everything that has happened since we started this process, there are essentially almost 220,000 renewals that have been initiated. And of those initiated renewals, for over 156,000 beneficiaries have been renewed. That's a 71% renewal rate. Based on a slightly earlier set of data, we rank 7th in the country in terms of our renewal rate, which is great in my mind. If you go to slide 7, and I focus on December, which shows, I think, pretty impressive numbers, 83% renewal, very low pending cases and disenrolled cases and potentially disenrolled. Now, April tells me this is all anomalous, that I shouldn't make too much of a big deal out of it because the numbers will flip. Well, until she shows me that the numbers have flipped, I'm going to make a big deal out of it. So we still have some problems as shown on slide 8. The number of cases that are still pending by number of days of pending, there's 56% of the population of the cases are now more than 90 days. That is problematic. Now, if you look at the new applications piece, and that was the concern that you raised when we had our roundtables, we got pending cases on recertification high. We have new applications coming in the door, and they have a CMS standard for how soon they should be processed. And we have recertifications, the annual recertification coming up. And that is a perfect storm, and you're right to to be concerned about it as we are. So we still have about 30% of the new MAGI applications that take at least 45 days, but that's down from the previous month. Now, April will tell me that's probably anomalous too, but we will see. I've asked my team to think long and hard about, you know, obviously, aside from throwing bodies at the problem, which we don't have the luxury to do, how can we fix these issues? Slide 10 goes through a list of things that we're trying to do. There's a plan to automate the eligibility for SSI and newborns. I think that goes into, does it go into production by, yeah, it goes into production by March. We are bringing in temporary staff just to do some of the administrative stuff, like take calls and process data entry. We believe that will lessen demand on the caseworkers, and this will allow them to process more, to focus more on processing cases. We are also authorizing more overtime than we have for DHCF caseworkers that handle non-MAGI renewals, which are the most laborious and difficult to execute compared to MAGI because of the documentation requirements and the eligibility rules. We have, you know, by authorizing more overtime, that expands the number of case processing hours in the system, again, for the most difficult and complex applications. We are targeting, according to my folks, about 145 cases every other week. And we believe if we do that successfully, the backload will be completely gone in 4 months. As always, we will look for other opportunities to impact this process, work with ESA when we can. And one of the things that I've asked Melissa to do is, as we get close to hitting the first tranche of annual recertifications, to make a determination as to whether we should request from CMS the permission to extend the period for the unwinding period for those in-process cases that are about to bump up against a new annual certification requirement. So we will certainly let you know if we request that extension. We will try to avoid it, but we will use it if necessary. CMS is, under this administration, is just completely interested in keeping people eligible. So they have been they will be very friendly to requests that aren't designed to throw people off of the rolls. If you go to slide 12, want to change horses a little bit and talk a little bit about our $4 billion program. Often we get in these meetings and there's a focus on a spa that probably costs $1 million, and people forget we're talking about a $4 billion jet that we have to pilot every day. Almost 90% of the people who are in Medicaid now are in managed care. Melissa had promised 95%, but I talked to her the other day and she seems to be backing away from that promise. In recognition that we wanted managed care to be the linchpin of the program, we've made some significant changes, learning from some gaps in our program over the years that created some critical problems. So if you go to slide 13, you will see that we have added risk adjustment, which for both Medicaid and Alliance, which simply allows the MCOs with the sickest patients to receive budget neutral payment bumps in their monthly rates. So if you have the sickest patients, you get more, and your colleagues get a little bit less. We are also going to risk sharing. We had to go to risk sharing because we were moving, as we move more people into managed care from fee-for-service, their population tends to be sicker. Health plans get very nervous when you ask them to take on people who are really sick and hit them with a cap rate that doesn't change, because they know they could get in trouble quickly. It's hard to predict where those expenses are going. You think you know, and then all of a sudden you realize that you're way over budget because you're making sure people have good care. We have increased the number of contracts that health plans have to execute with providers that are value-based. The goal is to get better healthcare outcomes per dollar spent. We also have a pay for performance that has, we've had to delay several times because of, different changes in the program. But when we use it, we tie a portion of the MCO payment rate to actual patient outcomes. And so if they don't meet those patient outcomes, they lose that money. Now, even if we don't put a dollar figure on it, we can monitor their performance, and it's very visible. It's a very visible thing. You know, how many people in your panel are using the emergency room without having a severe emergency? How many people on your panel who are discharged from hospitals are right back in the hospital in 30 days? How many people on your panel are low acuity hospital admission? Somebody who had asthma for months and months and months, and you didn't help them, and all of a sudden they were in the hospital because the asthma is uncontrolled. So those things we can collect data on, and we can shine a spotlight on poor performance, even if we don't tie payment to it. And we typically will tie payment to it, except if we have to do some creative stuff because of budget problems. And, you know, budget problems may be looming. Due to these policies, it's important to note that we have definitely observed a better alliance or alignment of MCO costs with payment. We don't have plans going out of business anymore because of insufficient payment around risk. We have seen greater care coordination effort. I think they should be doing more. I think we give them $25 per member per month in their cap payment to do care coordination. I think that's what it was. This was last time I checked. And not insignificantly, we have prevented MCOs from becoming unjustifiably profligate, but also protected them from insolvency. The table on the next slide, the graphic on the next slide is pretty important because it disabuses the community of a lot of false notions about managed care spend. Yeah, we spend, what is that, 12, you know, almost 1.7, $1.8 billion in managed care. But every health plan that you see on that slide is spending more than 90% of that revenue on medical expenses. They're not pocketing the money. They don't have 40% admin rates. Their money goes to patient expenses. Now, they only require from a federal level to meet an 85% threshold, but they're all beyond that. AmeriHealth, to the point where they lost 2%, but I wouldn't feel sorry for them because AmeriHealth puts a lot of, they have a very conservative reserve. And so they often are making money when they're showing a loss. And then when it's time to true up on those reserve claims, those claims turn to, you know, there were no claims to tap that reserve, and that money goes back to their bottom line. So my guess is that 2% is a function of that. But across the board, they're either making a little bit of money. MedStar made about 4%, which isn't bad. Care First, this was the last year of the Care First involvement in the program. They made 1%. And HSCSN, which has some really sick kids, they're down 2%. But there are no red flags blinking. I will talk a little bit about behavioral health, and then I'm going to turn it over to you for questions. And I'll talk about the hospital, and then turn it over to you for questions. The key issue with behavioral health is if you look at what we're spending on behavioral health services, there is tremendous growth. If you look at what we were spending in 2019, for example, compared to what we're spending now, that's been 140% growth over that time period. If you look at the average caseload, the average number of users per month from 2019 to 2023, that's grown at about 170%. So the behavioral health dollars are getting out of the door at DBH with a significant assist from a 70% federal match. One thing to watch in the future is telehealth. We put it in place more widespread during the pandemic because people didn't want to come out of their homes, understandably. DC's use right now is 4 times the national average. Yes, 4 times the national average. When you compare us to commercial insurance, we're 25% above the national average. And then there are some concerns we're seeing from a program integrity standpoint. I won't talk about those publicly because they're still doing their work. But there are reasons to be both pleased that people are using telehealth And there are also reasons to be concerned because we may have some bad actors that we have to take a harder look at. You heard a lot about the rate study that Angelique has been shepherding. That study was conducted and has concluded, and it was done to address some really long-standing complaints about payment adequacy. If you turn to the next slide, skip that one. My crackjack chief of staff didn't get that blank slide out of there. She told me last night she was.
Your chief of staff is great.
She is outstanding. I'm so glad she came back because I was going to quit if she had. The rate study was conducted to deal with some really challenging issues of payment adequacy. And they focused on 3 major categories, and Angelique can talk about this in a lot more detail if you want. I'll just blow through it. They were looking at adjustments to existing services, those where there was a change in payment methodology, and those where there were new services. And I'm not going to spend a whole lot of time going over the details. In case you have questions, Angelique can certainly tell you what more detail about that effort. Lastly, I want to speak to the new hospital. It is the 2 important words for me are, well, 4, on time and on budget. That's 5, isn't it? On time and on budget. That's where we are now, thanks to a lot of hard work by UHS, GW, and by Ben, who rides herd on the process and is very, keeps me very informed when there are bubbles developing in the pipeline that could slow the project and cost us more money. If you go to slide 22, we are doing outstanding with respect to our CV goals, and Ben can talk about those in more detail if you like. And we're also doing very well with employing DC residents, 300 on the project. Most of those, 174 were newly hired. The others were already working. 69 of those DC residents reside in Ward 8, and 57 reside in 7. We have substantially blown past the the apprentice hours on the project. We estimated there would be 15,000. We're well over, almost at 50,000. I know you've asked about the volunteer training program that is very much underway. The early reports are that it's doing well. The district is primarily responsible for making sure it gets executed, working in partnership with the Hospital Career Development at GW and HR. If you look at the numbers of people who are involved so far, we've had 98 participants from 23 different departments. There are 1,000 courses have been assigned to date, and most of the participants are from Maryland, as we are not surprised because I think 60, 70, 80% of UMC's employees are from Maryland. So at the bottom of the slide, which I found very interesting, their top course categories, I was surprised there was no revenue cycle management on there, because that's a huge issue, but GW has their own. I mean, they pride themselves on that. So those are the things that I wanted to bring to your attention. I'm sure you have things that you want to bring to our attention that I did not include, and that's why I have the people here with me who are more educated in the details of those things.
Thank you, Director, Deputy Mayor, both hats. And we'll dig into more. I have some questions about some of the things that came up on the slides. Let me start with Cedar Hill, since that was the last thing that we talked about, and that was the last thing that I wanted to talk about from before.
Okay.
So on time and on budget are music to my ears.
Yes.
And I think that's music to everyone's ears. So you guys said early 2025 opening. What's the definition of early?
I hope it's January, but Ben said that's not possible. So
I don't think that's possible.
no later than March, right, Ben?
We're shooting for early. And
Early spring.
that's our goal.
Okay.
We want to stay within the first quarter, I assume.
Okay. All right. So I'm asking some questions that, and I know, Ben, you've been managing sort of the construction aspects of things, but in sort of hopefully talking to UHS around the actual functionalities as they're planning for the transition. So some of these questions are follow-up things that I had conversation with UMC about at their performance oversight hearing. So UMC reported in their pre-hearing responses that they currently serve over 500 patients through the involuntary psychiatric commitment process in FY23, which was a marked increase over what they had in FY22. I see in the pre-hearing responses that Cedar Hill will have 16 psychiatric beds. Is that enough to match the volume that UMC is already seeing from the FD12 process?
So the number of beds that are in the new Cedar Hill were what was approved through the CON process.
Okay.
8 of those beds will be voluntary and 8 are involuntary.
Okay.
But it was acknowledged that it was not going to be a 1-for-1 replacement for what UMC currently has and delivers.
Okay. Will Cedar Hill accept FD12 admissions?
Well, Cedar Hill?
Yeah.
This is part of their involuntary.
Okay. All right. I think that's something that we should continue to have conversations with. I'm pretty sure the Hospital Association will want to talk about that as well, because even though we went into this project sort of recognizing that it wasn't a one-to-one comparison, if Cedar Hill doesn't have the capacity to even meet half of what UMC is currently taking on, then that means PIW and MedStar Washington Hospital Center are now going to see an increase as well, and that they probably need to plan for that transition too. So we just need to continue to have conversations about that. At the UMC oversight hearing, Director Dr. Payne Borden testified that they're currently procuring a consultant to help them with the closure plan for UMC.
Yes.
How, I guess, in your role as DMHHS, this is why I had it in the DMHHS section, are you all supporting UMC to develop that closure plan? I'm hopeful that you're working with the CFO's office on this.
Yeah, well, actually the board.
Oh, that's right. You're on the board.
I'm on the board, yeah.
There we go.
So we, at first and I talked regularly to Angel Jacobs, who was the chair. And I was a little concerned that I thought, well, if we have to go through a procurement, by the time we get that done, hospital will be closed. But then I was reminded that the procurement at UMC is a little bit different. They don't have as many hoops to jump through as we do on the executive side over here. So the RFP is scheduled to go, I looked at it last week, it's scheduled to hit the street. They should have a vendor selected within 2 or 3 weeks, and that vendor should be on board and ready to go.
Great. All right. So I'll check in with them at their budget hearing in a couple of months. So Cedar Hill Urgent Care Center in Ward 8 is seeing higher patient volumes than projected. I think they saw almost 12,000 patients in FY23, which is way more than the 9,000 that we projected. How confident are you all that the center has the staff capacity and space to continue on without having such exorbitant wait times?
Yeah.
Or are you imagining that once Cedar Hill opens, it will all even itself out?
I think there are a couple of things going on, but I do know this, that Kim Russo is probably one of the better hospital CEOs in the country, and she just hired an excellent CEO for the hospital. The management team in that GW system is outstanding, so I don't have any doubt that they will adjust as necessary if the numbers continue to exceed what they hope, what they had hoped when they opened the facility.
Okay.
And they will be opening another, it's taking a little bit longer because it's a little bit more involved. I think that's scheduled for the end of
25.
25.
So let's talk about the Ward 7 situation.
Yeah.
My fear is that the Ward 7 Urgent Care Center project is going to become the Ward 7 Walmart project that never happened.
Yeah, I don't know if you had to worry about that though.
I understand that there's challenges in finding a site.
Yeah.
I mean, land is not scarce in Ward 7, so what's the challenge here?
So land is not necessarily the challenge, council member. The challenge has just been finding a site that both is located in the right location of the ward, given where UHS wants to provide services, but also a lot of the space that was available didn't meet how they operate an ambulatory facility traditionally. So we are very close to having a location in place. I would just say as it relates to the commitment by UHS, they are required under the district's agreement with them to open a center in both Ward 7 and 8.
Okay. Walmart was also required to open a location in Ward 7. And it's not there either. But I'll, let's keep talking about that. Because I think obviously I would much rather a person go to an urgent care center than come to the emergency room. And so the more that we can build the health infrastructure in community, I think the more that people will use it and those kinds of things. And so now we're talking late 2025.
Yes.
Okay. All right. We will stay on that. All right. I have some general healthcare finance questions. So according to the documents that you all sent to us, you all only completed performance evaluations for 82% of the staff in FY23. What happened that almost 20% of the staff didn't get a evaluation last year?
So, Councilmember, as in my COO role, have HR under me. So you are correct. That number was lower than the prior year. A lot of the missing 18% there were new hires. So if you get hired in the middle of the year, you don't have a full review. But we are looking to get our numbers back up in the future to where we've traditionally been, which is closer to 85%.
Correct. Okay. In the pre-hearing responses, you all reported that the agency does not collect race information on agency staff and therefore can't report on how retention, promotion, and compensation might differ amongst employees. I'm curious, how then are you able to track that promotions are equitable, or that there's not some disproportionate gap in terms of who's getting promoted and who's making what? Oh, you turn your mic's not on.
I was not aware that we didn't collect race on our employees. But I will say the agency is disproportionately minority by a big number. And if there were evidence, if it were true that people who were not minority were getting promoted, while those who were minority were not, it would rear its head rather quickly. But I have, if you look across the agency, there are minorities at every level of the organization that are responsible for making recommendations and promotions. So now that I know we don't collect race, I'm a little concerned about that, but I am comforted by the fact that I know the managers, both minority and non-minority, and they are some of the finest that I've worked with. So I don't have any reservations that people are being adversely impacted on promotions because they are minorities. I just don't think that exists.
Okay. And for the public, we asked a lot of pre-hearing questions. So many of my questions are follow-up questions to some of the things that were submitted there. I wasn't suggesting that there was a problem. It was just a question that I had there. Let's talk a little bit about budget. So when we got the FY23 supplemental budget, I was a little surprised and taken back to see that 9.9 million was reprogrammed from the Department of Healthcare Finance into the general fund, about half of which was from the DSH payments under Medicaid fee-for-service. You all described in the pre-hearing questions that the overestimate was partially due to the FY23 budget being based on the assumption that the public health emergency would end in July of 22. But that doesn't really make sense timing wise. And so, how is it that you all didn't know by March of 2023 that the public health emergency was going to end in July of 2022?
Well, when the public health emergency ends, affects the federal reimbursement rate for Medicaid payments. So when the FY23 budget was formulated, the assumption and formulation was that the public health emergency would end in July of 2022, which meant the enhanced FMAP would have ended September 30, 2022. meaning the FY '23 budget was budgeted assuming no enhanced FMAP payments. As we all know now, the public health emergency did not end until May of 2023, meaning we had enhanced FMAP throughout FY '23. So we had more federal money than we budgeted when we formulated. And having that additional federal reimbursement meant less local funding was needed to achieve the same outcome. So, you know, you spend the same amount of total dollars, but you have more local savings. Additionally, relative to DISH, when we formulated the FY '23 budget, you know, given the timing of formulation, it was really based on earlier years DISH payments. But when we actually make the DISH payments, we make them based on the current year survey that the DISH qualifying hospitals complete and return to us. And their uncompensated care costs had gone down.
Okay.
So those two factors together led to the surplus.
One thing I would add as well is that with the end of the public health emergency, it was always, for a long time, it was assumed when it ended, it would be the complete end of the federal match. And it wasn't until December 2022 when the Consolidated Appropriations Act passed. And then they did a phase out of the enhanced match as well, which was, you know, unanticipated until December. And then the public health emergency ended in May.
Okay. I don't like to give money back. Especially when we asked for a little bit and you guys told us, oh no, healthcare finance, we're so broke. And then you weren't. So that's.
Well, we thought we were broke at the time.
Healthcare finance reprogrammed 1.9 million of contract surplus, which you all described or ascribed to delays caused by appeals to the contract appeals board. What were the most common complaints?
At the contract appeals board?
Yeah.
Oh man, it run the gamut. It depends on the contract. I know we had a huge, like we have a continuing complaint coming from the MMIS contract where the loser, who is our current fiscal manager, has filed grievance after protest after protest, and that involves some delays. I think there may have been some others. Angelica, are you aware of any others?
I think I'll ask this, in terms of the complaints that have come up, are there anything sort of systemic where you're like, this particular issue within our contracts process keeps coming up as a thing, or are they fairly unique to whatever the particular contract was?
It's even different from that. These are all folks who have lost and they don't want to lose the contract. So they, in some cases, they manufacture reasons for an appeal and hope that they can complete a Hail Mary pass and get the contract appeals board to overturn the award. Most of the times they're very unsuccessful.
Okay. So we asked in pre-hearing responses for you all to tell us a little bit about your grants. One grant the healthcare finance provides is $8 million to Howard University Hospital in FY '23 to provide care to medically indigent district residents through inpatient and outpatient services. So what specifically is the purpose of this grant? Because in the pre-hearing responses, you all provided no description of grant outcomes. So is this our way of just saying we give a subsidy to the hospital?
No, so Howard University received DISH funding. And with the DISH rule changes, their funding for uncompensated care was greatly impacted. And it impacted their ability to provide services to people that continuously go to Howard. And we wanted to make sure that they weren't negatively impacted. So the $8 million that was provided was to support Howard University to continue providing care to the participants that they usually funded through uncompensated care.
Okay. So is this now going to be an annual thing that we provide to Howard University Hospital?
No.
So that was only for FY '23?
Yes.
So we're not doing this grant in FY '24?
No.
All right.
Mayor has made that very clear.
To
not do it.
The hospital, they know that it's not, should not expect it.
Yeah.
Oh, just bridge
It was a
funding,
bridge
transition.
funding.
Exactly.
That's correct.
All right. So one time. Okay. All right. Let's talk a little bit about DCAS.
No.
That's my favorite football stadium online portal. So in the agency's follow-up information after the November oversight roundtable, the agency report that there has been a significant increase in the number of public benefits related hearings before the Office of Administrative Hearings in FY '23. So, in FY '22, you had about 1,850 hearings, and then in FY '23, it was over 3,000. So more than 80% of those cases, or sorry, excuse me, more than 80% of those hearings were for SNAP and TANF cases. What do you believe caused the increase in fair hearings? Is this mainly about timing of us not processing things on time? Oh, hey, Eugene. Just introduce yourself for the record.
Eugene Sims, Policy Director, Healthcare Finance.
Yes, Eugene can answer that question.
Okay.
I was just gonna say, when it comes to the appeals hearings, those, if they're for SNAP and TANF, they're gonna go through the Department of Human Services, and they are handled at that point. I don't know to the degree at which they are handled through DHCF unless they are medical assistants.
Okay.
And they're not specifically eligibility. We usually get the non-eligibility appeals, and DHS handles the eligibility appeals.
Okay.
Because they're delegated that function.
Okay, so I guess I was trying to get at whether or not some of this was about the software or if it was something else, but I guess this is, I can add this to my DHS pile for when they, okay. All right, for the DCAS update to the enhanced user service, I think you have a planned update for the user experience. Is that? Yeah.
Well, I know for
summer of 2024.
A few things specific to District Direct, which is the portal for our residents. We are in the process of making some changes and some upgrades to make the user experience better. There are a couple different things. One, I think it's 4 phases total. We just implemented the second phase last month, with the third phase development starting this month or next month, and to go live in May or June. This next phase will focus on some translations to cover more of the languages seen in the district. And then the other component that's longer term, but is our collaboration with Code for America. They've been on the ground for a few months now, really getting an understanding of what's happening in the district and starting now to speak to stakeholders, both internal and external to government, with a long-term goal of really focus on how we better streamline the application. As you know, we heard a lot of concerns about feeling like there's similar questions multiple times throughout the application.
Right.
And so they've come on board to really help us work through those variances between the different programs and make them more user-friendly in that respect.
Great. So in the partnership with Code for America, and even for, as you all plan for the upgrades to roll out later this summer, you know, one of the things that we talked about in December was the need to have user testing. Is that going to be incorporated?
Part of the Code for America work, yes, it is.
Okay, great. Good to hear that. Okay, so the mayor committed to the SNAP funding increase. We've seen the updates from DHS in terms of the particular timelines there. Are we still on track for the disbursements to begin on the regular clip in March?
Yes.
Great.
Retro back to January.
Yes.
Yeah.
Yes. Okay. Okay, so according to the pre-hearing responses, Healthcare Finance will add a streamlined process for the newborn enrollment for DCAS. This was something that came up at the hearing where folks were waiting months and months in order to get a kid in. When specifically will this upgrade occur?
Sure. Deputy Mayor Turner referenced this earlier, but that is one of the fixes, along with the issues we've had with children with eligibility grouped in SSI, that will go into production at the end of this month by beginning of March.
Okay. Deputy Mayor, there were a number of things that you talked about in your slides around changes that you all were making to try to process applications quicker. Interestingly enough, all of the changes that you mentioned, I kind of noted, none of them really had to do with DHS. It seems as though you guys are trying to fix the problem on your end internally, even though it might not be y'all?
Well, sure. One thing that I think extends beyond just DHCF is when you consider the changes happening with DCAS. And one of the other efforts underway and upgrades is, I don't think this is a technical term, but caseworker clicks. So how do we how do we minimize the number of times that a caseworker is clicking through various screens and so forth, which just makes processing and moving through that process not as efficient as we would like to. So within this will be closer to the end of spring, beginning of summertime period that is happening now, and that's one of those things that will help caseworkers across both agencies.
Okay. I noted that you all are planning to bring on temporary staff. Will they be healthcare finance staff or will they be DHS temp?
Yeah, just a reminder, we took on the Medicaid branch, which formerly was at Department of Human Services.
Yeah, question. Why?
Well, to better bring them closer to the policy apparatus and the DCAS team for more support so that, you know, as they're executing these complex policy intensive determinations, that the support is closer to them. So they're now under HCPRA, the policy apparatus of the team.
HCPRA, I'm sorry.
Healthcare Policy Research Administration. I'm the director of HCPRA, sorry.
I've never heard y'all refer to that
I
team.
try to spare you one, I say
And
policy.
the-
Apologies.
And the English for that word salary is, their outcomes were horrible and we had to get them fixed.
Okay. How many people are on that team that you all moved over?
So when fully staffed, it's 22,
22.
5 managers, 17 CS staff.
And they've done a wonderful job under Eugene's leadership.
And so you physically moved, or that team physically moved?
They physically moved and, you know, operationally moved. They're now at LaFont Plaza on the 2nd floor, same building where DCAS is.
Oh, okay. Oh, they're sitting right next to. Interesting.
They've done very well.
Okay. Now, the responses indicate that this branch primarily works with long-term care applications and renewals. Is this accurate, or do they do more?
It's long-term care, so EPD waiver, IDD waiver, nursing facility, ICFs, also a few special programs, children in care. Those are our CFSA kids. Emergency Medicaid, also Katie Beckett, the specialized pathway for when a child is disabled or their parents' income wouldn't make them eligible for traditional Medicaid. They can apply through the Katie Beckett pathway.
Okay, great. Can you all follow up with the parent who testified about the issues in the system?
And we already have, our staff has already been working with, sorry, I think it's
Ms. Maltz.
Maltz, thank you. And I reached out to Ms. Dunn during her testimony, and she is following up as well, but we'll continue to track that. Some of those issues clearly were inside DHCF in terms of what we can control, the system glitch that she experienced for sure. As when those arise, not what we want, but we do try to make them fix them as soon as possible. And then the series of issues that she raised about having to track prior authorizations and so forth, that goes through HSCSN. And that didn't quite make a lot of sense to me why she was having to do that as well. So we will be talking about that.
Okay, great. Okay, so it's related on the HSCSN sort of. So in January, Department of Healthcare Finance decided to pause redeterminations and terminations for children with SSI codes because of about 130 recent instances where children lost eligibility even though they were likely eligible. Have the issues that led to the disenrollment been resolved?
So that's, Melissa spoke about that end of March timeframe.
Okay.
That's end of February timeframe. We are working to resolve those issues by end of February.
Okay, so that was a DCAS software issue, or was it a caseworker issue?
It was how DCAS was reading some of the codes sent over to us from Social Security Administration.
Okay, so it was a software issue.
Well, it was more of a functionality issue. I'm not sure the program was accurately programmed to reflect our policy. So.
Okay, I'm not dogging the software. I'm saying it wasn't a people, like a human.
Correct.
Did not process something that they were supposed to error.
And until it's fixed with 100% certain, people will not lose eligibility.
Okay. The healthcare finance website only includes the monthly Medicaid redetermination reports up until November of 2023. So when are we going to see the more recent months published?
It will be published today or tomorrow. It's not already up there, and it will cover both months, December and
January.
it's up, and it is December and January, right? Yes, and both months, December and January, so we're back on track.
See,
Hmm.
look at that. Although now I can't dig into the numbers and ask you guys more questions because I don't actually know what it says, but that's okay. So a significant portion of the new Medicaid applications are taking longer than 45 days for MAGI applications and 90 days for non-MAGI to be processed. While okay. Well, okay. Let me rephrase the question. We're seeing a significant portion of new Medicaid applications that are taking way longer than the 45 days to process. You know, obviously we have renewals that's currently going on. How does it get, in terms of the queue, when a new application comes in, do they get prioritized over a renewal that's currently pending, or what happens?
So I'll speak to, I think what DHS is doing, and Anthea is the best answer, but they're trying to prioritize. So we have longstanding pendings. So they work from a pending report that we give to them monthly. And they also work from, they have timeliness standards for SNAP, TANF. So they also can't just ignore a new application that's coming in because they do have shorter, they have more rigid timeliness standards for SNAP. So I think they're trying to do both. First, work back to reduce the backlog of pendings while also addressing the new cases that are coming in so that they're not contributing to the backlog.
Okay. And I think we learned from Director Zeilinger, they don't split the team as in somebody's just there's like a set of 5 people who are just working on new. Everybody's working on everything.
Right. I believe it's called the core processing unit. The bulk of the applications renewals, they go to the core processing unit. The unit as a whole, which is I think the bulk of ESA, processes the applications and renewals.
Deputy Mayor, has the ESA team returned in person?
Not completely, I think, but I think, because I think Laura gave them
we have an update on that. I believe as of last week, they are back to 4 days in the office.
I know they requested an extension, but
okay.
I didn't realize they were back that soon.
They're back.
4 days. All right. Let's hope we can see some progress on here. Because when do we start annual renewals again? In April? All right.
Unless we get an extension.
But wouldn't that just set us back even further?
Well, it will, I don't know if set us back, but it prevents us from having to crunch, annual renewals with pending recertifications and creating more of a problem.
Well, let me ask you this, Eugene. When the team is doing the processing, are they at least starting with longest pending?
Yeah, so specifically, we have a processing team internally and at DHS. We're working with DHS to prioritize those that are about to be reinitiated so that, they can properly reinitiate and they go from, pending to fully processed so that, the case will be reinitiated.
Is the system set up such that I can submit a renewal when my current renewal is still pending?
So if that's the case, you will not reinitiate. So district will have a couple of options. We will either need to fully process your case so that the system can properly reinitiate you, or to the point Deputy Mayor spoke about earlier, redistribute you into the future, buying us more time to fully process your case.
Okay, so the system, let's say I was in that first group in April. That's a bad example, but let's just say I'm in that first group in April and I'm still pending, even though I don't think we have very many people who are in that situation at all, but hypothetical. I'm assuming that the district direct system has something in the system that would send an automatic push out prior to, hey, it's about to come time for you to renew. Yes?
Yes.
Okay, so if I'm still pending, will I receive that push out?
No.
Okay.
So that's why it's priority for us to process those cases or redistribute them to buy us more time to process them.
Got it. Okay.
And when Eugene is referencing the redistribution, that ties into what the deputy mayor has said about asking for that extension. So if you recall, when we stepped into the renewal time period, we looked at all cases, like states looked at their annual, and then we did redistribute some people's recertification dates. Like we put those who we call that PHE group that we had evidence that they would likely no longer be eligible. And so they were put in like months, I think 4 or 5, like July, August, October. The potential opportunity is then to take, if we have folks who are still pending, and redistribute their recertification over a period of time as well.
Okay. All right, you all reported that you're switching to a new operations and maintenance vendor for DCAS. What's the timeline for that transition?
I will have to get back to you on that one. I don't have it off of my head, but we can get it to you this week.
Okay. Okay. How about this? When we come back for the budget in April,
Mhm.
I'm going to ask some questions about DCAS in terms of where we are in processing.
Okay.
Hopefully, we'll see a decrease in the number of pending. Yes?
In April?
Yes.
Well, not according to April, if it's all anomalous. I don't know if is April still here? Hopefully we will.
Okay.
You
don't seem real confident in, in
because it's a very difficult project. And it's difficult for lots of reasons, some of which, I don't care to expound on because it's my theory.
Yeah.
And so it's not as easy for us to sit over at DHCF and say, okay, we're going to fix this way, and it has to be done by X. There's so many intervening variables between, who we send that direction to and how they can effectuate what we're asking them to do, that it's difficult to predict with any degree of accuracy how much we're going to knock off of the backlog. But we will certainly have a concerted effort to do so.
Okay. Let me ask this from a historical standpoint. Has there ever been a situation where the Medicaid applications and renewals were processed by healthcare finance, or has it always been this bifurcated system where DHS was processing?
As long as I've been here, it's been that way. And it's probably that way in almost every other state.
In a lot of states actually delegate to their county level.
Yes.
It's a county level function. So we don't have that opportunity here, but it is a formally delegated function through our state Medicaid plan. And to follow up on your last question about O&M, it was actually, the solicitation was issued at the end of January, beginning of this month. It should be open for 60 days, and the goal is to award before the, I think, into this calendar year, I believe.
Okay. All right. Let's talk a little bit about Medicaid network provider quality, or just otherwise what's happening sort of in our network. So you all had about 139 Medicaid fraud investigations that were initiated in FY23. More than half of them were related to participant-directed workers or personal care aid for beneficiaries under the EPD waiver. Is this normal that the majority of the fraud cases would be for these types of providers?
I'm sure historically, where we see the most activity through our Division of Program Integrity is on home health aides or home health agencies, dentistry, and behavioral health.
Dentistry. How do you fraud? It's what, dentures?
Well, you don't.
Maybe say you pulled teeth that you haven't pulled. Maybe you pull the same tooth multiple times. There are
Right.
a few different things you can report.
Yep.
Yep, it happens.
Interesting. Okay. Speaking of dentistry, you heard the testimony from Kurt Gallagher from the Dental Society. When is the last time that we updated rates for dental?
It looks like over 80% of the billing codes received an update in 2022, and then the remaining 20%, I think we'll have to respond to, or if I got that wrong, she'll correct me.
So we have a process where we have a dentist internally, and he works with our dentist as well as our coverage determination team, and they review codes that are heavily utilized and make sure that we're updating those. We've gotten better at it in the last 2 years. There are certain codes that have not been updated for years. The utilization is low. And so as Dr. Lacy reviews the utilization of our codes, he works with my team and then we update the rates. And so in 23 and the beginning of 24, it's about 28% of the rates that we've updated of the whole.
Just for dental.
Just for dental.
Okay.
Yes.
All right.
And so we try to get those high utilized rates updated. But our fee schedule is huge.
Okay. But is it possible that for the underutilized ones, they could be utilized more if the rates were improved?
That I cannot answer because it's more clinical, because these are HCPCS codes or clinical codes.
Right.
And so I don't know the difference between the ones that aren't utilized. We would have to follow up with that.
Okay. So when's the last time we updated the rates for behavioral health? I think we just did that.
Yes. We're
Okay.
in the process of doing that now. Deputy Mayor spoke about the behavioral health rate study.
Yes.
That was going on. And so through that rate study, we've been able to update 26 rates. We've been able to update 26 rates.
Okay.
Through the July of 23 up to this month that were effective February 1st.
Okay. Is it possible that you can send us the new ones
Yes,
of the
schedule of the rates that have been,
schedule of the rates
updated.
that have been updated?
yes, and in addition to.
And if also, sorry,
Yes.
impossible, can you send us what it was before? So send us the
Yes.
old one and the new, so we could just
We have
see.
a schedule that has a comparison.
That'd
So
be great.
yes, that's easy.
Great.
And also, I'm sorry, also one of our ARPA initiatives, the HCBS ARPA initiatives, we were able to inflate the rates. So during the public health emergency, some of our behavioral health providers, like MHRS providers, were able to get an enhanced rate during that period. We also utilize HCBS ARPA funding to inflate the rates. Since they had not been updated for 6 years, they need, we wanted to make sure that providers had increases. So we inflated the rates up to 22 while we went ahead and continued the behavioral health rate study. So they received that inflationary factor in 22 and in 23. And this year we're making the rates effective,
Okay.
the new methodologies and rates.
Okay. So, Deputy Mayor, I'm looking at a comment you made that DC's use of telehealth is 4 times higher than the national average. Is that because of the inflated rates? No.
We're
Like-
we're talking utilization. We're talking not just spending, but if you look at the data, and compare it to what you see nationally in terms of utilization, the number of units, and the number of calls, we're very high.
Okay. Is this high unusual, like, ooh, we might think that something nefarious is happening, or high in that, whoa, there seems to be a greater need in our community, more people seeking behavioral health services than before?
I think it's a combination of two things. One is we expected it to spike because it was initiated during the pandemic and nobody was going into our office. And to some degree, then the people are back, you will see that in-office visits and the telehealth have sort of, the trend lines sort of meeting one another.
Okay.
But just on telehealth alone, even with those trend lines meeting one another, you still see, when you compare us nationally, a much higher rate of usage in DC. And we have, some concerns because of the speed with which it accelerated and some of the early things that our program integrity shop has identified.
Okay. You mentioned in your presentation that you all are going to be reintroducing pay for performance for MCOs and back into their evaluation. Has that started?
We hope, we're in budget deliberation now. Only times we don't do it is when, the budget is problematic and we have to basically take things from the MCOs. If we do that, then we have to be careful about withholding additional monies for pay for performance. Right now, DHCF has a $40 million pressure. And we have to, this is a 24 pressure. And so we're doing things to try to minimize how much money we have to ask the CA for at the end of the fiscal year. One of those things that we're going to do is recommend that we withhold, which is contractually allowed under the federal regulations, 1.5% from the current rate. Now, whether we do that in 25 budget formulation will be dictated by, what the actual budget problem looks like, if there is a problem, and, whether or not the mayor would support it.
Okay, so let's go back for a second. You have a $40 million budget pressure in
Yeah.
FY24,
Yes, we do.
primarily caused by what?
One, we have and the money folks can tell you a lot better than I can, but I think the biggest one was we have a high cost group that exists in numbers in one of the health plans that we couldn't have projected because we had no history, we didn't have no historical data. So we thought the number of high cost members was here, they ended up being up here, and that was a big number. Now they can tell you the rest.
The numbers people?
So from our first quarter FRP, we're projecting a $46 million local spending pressure for FY24.
Okay.
34.1 million of that is related to managed care, but there are a number of items in there, including more beneficiaries in managed care than we had budgeted for. Also, as the director just noted, the mix of beneficiaries is different. There are more high-cost folks as compared to lower-cost folks than we had budgeted for. And in some areas, particularly the special needs plan, the rates are higher than we had projected. And then the second biggest area is in the buy-in programs where we pay the premiums for folks to be the Medicare Part A, Part B, and Part D premiums. Those premiums are higher than we were expecting.
And we don't set those premiums.
Right.
Right.
Medicare sets those premiums. We just have to pay them. And then $5 million related to the continuous coverage requirement that CMS instituted effective January 1st, which we didn't know about when we did the budget, so we were not prepared for that. And then there's some small offsetting amounts.
The continuous coverage requirement, remind me for January,
So
which population?
it's, I was gonna say.
Children.
can fix
Oh,
it.
that was the,
Mm-hmm.
they saw too many kids that were getting kicked off.
No.
Or no,
Yeah,
this is
it's
different.
Just federal, new federal law regulation that requires that we keep children enrolled for 12 continuous months. So if you had a change in circumstance, so that if family's income rises above eligibility limits, is probably the best example, we would expect that would be reported, and then we would disenroll you. But in this case, if you now with continuous enrollment, if you come in January, but something happens that would make you no longer eligible, it doesn't matter. You have your coverage until the following January.
Okay. Let's follow up on that, because now I have a question about a bill that was pending in terms of how that goes, but we've been joined by Councilmember Pinto, who I don't know if this means that her hearing is done or not, but I'll turn to her for a 10-minute round. Councilmember Pinto?
Great. Thank you so much, Chair Henderson. Appreciate that. So I know that we don't have DHS here, but I'm hoping, Deputy Mayor, that you can answer some of the questions I have around encampments and homeless services. So we've heard a number of reports from homeless service providers that DHS has asked its partners to identify mid-year cuts to their existing contracts and grants. And I've already started hearing reports from Ward 2 organizations that they're laying off staff engaged in essential work to do outreach and to engage our unhoused residents. What was the specific request that was made to homeless services providers about mid-year cuts? And as you look across your cluster agencies and your work across the government, how can we work together to ensure that we don't cut budgets at the expense of our most vulnerable residents?
Well, two things. The DHS's request was probably initiated as a sort of a heads up that this could be coming initially, because all agencies were asked to look at mid-year reductions because of the budget problem in '24. So as we got more information, it was very clear that the mid-year reductions that we were asked to propose, some of those would likely be accepted, so you wouldn't have a budget that ended the year out of balance. So yes, I think it is accurate to say that DHS asked some of their outreach providers to take a cut, and they did it because they really had no other choice. You either find funds that you can cut, or you tell the CA that I don't have the money, and therefore I need you to make sure I don't finish the year with more spending than I have revenue, which would create all kinds of problems.
Okay, and so when you said it was expected, is that expectation different now?
Oh, I think it's probably intensified. I think as you get more information on what other agencies are proposing cuts, whether those cuts are palatable to the CA and the mayor, and compare that to what you actually need, then yeah, I think the request for the dollars probably has intensified. See, the challenge that the budget director and the CA have is that Health and Human Services probably is close to a third of the local budget now. So there's no way when you have a big number that you have to solve. There's no way you can work around HHR, which is where a lot of programs for people who are vulnerable live. There's no way you can work around that and not have them cut programs, because that's where the money is. And so Laura is, talented enough that she can do it smartly, but even when somebody as gifted as she is, pretty soon you can run out of options. If you know your budget pressure is X, and you look at what you have available to some things you can't cut because they're mandated. So you know what you have left to cut, then you have to go to those places, irrespective if those programs are serving people who are most vulnerable.
So what programs are you expecting to be cut?
I mean, from DHS? I don't have the list in front of me. I have seen some of her proposals, but I'd have to get back to you with that. But I can tell you, I mean, we at DHCF, we've been scrambling into the night trying to figure out how we have a $40 million problem. And we have been scrambling into the night trying to figure out how we are going to minimize what we asked for at the end of this year.
So, I mean, one of the causes for concern is the lack of mobilization of residents into vouchers that they may qualify for.
Mm-hmm.
How many of the 210 residents living in encampments are eligible for a voucher but are not yet matched?
We have that data. I don't have it at my fingertip, but I'll get it for you. But it's not that simple. One of the issues where we find the advocates don't really agree with what we're doing in the encampment side is they get very upset, at least those who are represented at ICH, when we automatically start moving people in encampments into housing over and above people who are in shelter and have been waiting for housing for months and years. So let's say we had vouchers to match to everybody who was living in a tenant encampment. Is not as simple as saying, okay, we're going to match them to a unit, because there are other people who meet the qualifications for PSH at a deeper level than maybe some people who are living on the street. They may have been homeless longer, any number of factors. I don't have the data in front of me, but so even if we if we count vouchers, we can count vouchers for everybody, almost everybody who's homeless. But you know, you got to find units and you got to find case managers, and then you got to look at, you know, sort of the pecking order of who gets a unit before someone else. It's difficult to do. I don't recall DHS's list of cuts yet, but I don't remember seeing them turning back vouchers. I don't remember seeing that, but I will get the list from Laura or ask Laura to communicate with you directly on that.
Okay, thank you. I appreciate that. I guess in thinking then about performance oversight and the work over the past year, how have you all worked to improve the timeline and efficiency of the voucher leasing process? I know last year we talked about some of the challenges with outreach workers and getting people matched, that it wasn't necessarily a matter of the vouchers not existing, but it was the mobilization. So how have you all been focused on the mobilization component?
Well, you know, they work every day to get people into housing. I mean, you can't really look at the number of people who are living unsheltered in the city as a measure of the efficacy of their efforts to get people housed. And the reason I say that is, you're not going to be able to, with the city's budget, you're not going to be able to eliminate unsheltered housing or residents who are living unsheltered on the street, because what will happen is, if we were able to put all 210 people who we identified in 23 into a unit tomorrow, that word would matriculate across Virginia and Maryland, and you would see residents who are homeless showing up on the streets of DC. I went over to the largest encampment that exists now in your ward, and I was talking to, you know, some of the residents, and, you know, several of them middle-aged. Well, I'm from Florida. And they have not been in DC very long. We asked them. I said, well, why are you living in an encampment in DC? Well, I hear there are more housing opportunities, and you can't blame anybody for that, but that's a reality. And until there is a national policy that mitigates the inequities across jurisdictions in housing resources, cities like DC, which is probably spends more per capita on housing than any other jurisdiction per capita, maybe New York, maybe a little bit higher, they're going to be at risk for folks hearing the good news and then coming to get housing. So I would, you know, I'll go back to DHS and ask how their the speed with which they are putting people into housing has changed since maybe the CARE report. But that's probably the best way to look at it, and not look at the fact that there are 210 people living in encampments.
Okay, but what is DMHHS doing to help DHS in that voucher lease up process?
Well, we give them any help that we can when they ask. We're always cognizant of the problem, but you got to realize what we focus on at DMHHS is managing the encampments that are on the street. That's not a DHS responsibility. So we have our hands full looking at what needs to be done to effectively manage the encampments and deal with those that have reached a level of where there's a public safety risk or health hazard, or a violation of the incommoding statute. We have to deal with those. That's where we focus most of our efforts. Now, if DHS tells us, hey, look, we need this, then my team will work to see if we can get it for them. But our focus internally is on street encampments, and that's something that DHS does not have in their portfolio.
Okay. Well, I am over time. I just will leave you with this, that I continue to be very concerned about, which is that 30% of homeless individuals in the city are women, but only 4% of our shelter beds are dedicated to women. This is particularly important as we know many women who are experiencing homelessness are victims of domestic violence. And hope we can make sure that that need is prioritized in the budget as we move forward through that process, to ensure that there are sufficient beds for our women who are experiencing homelessness as well.
Yeah, I have not looked at the count for shelter beds for women lately. I do know, I do check the vacancy report for shelter beds, you know, practically every day. And I noticed that the fluctuation between beds that are available for women and men changes regularly, but men tend to have a bit larger number of available beds than women. But I have not compared that to the total number of women who are reporting that they're homeless. So, I mean, that's something I will certainly bring to DHS's attention.
Okay, thank you. Thank you very much, Deputy Mayor. Thank you, Chair Henderson.
Thank you. Councilmember Pinto, did you have any other questions? They've been here for about 2 hours, so I'm going to take a break. But I didn't know if you needed to go back to a hearing.
Oh, thank you so much. I do have more questions, but not enough that would fit into just a minute or two. So do your break and that's fine.
Okay, great. Thank you. So you guys have been answering questions for about 2 hours now. So why don't we take about a 7-minute break and, you know, stretch, et cetera, and then we'll come back and finish up. Thanks.
Oh, we're not finished? I thought you said.
Break.
Oh, okay. All right.
And we're back. And we're back. Okay, MCOs. When will the annual report on MCOs for 2023 be made available? Oh, your mic's not on. I was like, why can't I?
We report on a calendar year for the MCOs. So there's a claims runout period.
Okay.
And so at the end of end of the calendar year, there's like a 3-month claims runout, 2 or 3 months, at least if she can tell us. So then the report can't really start until that period passes. So I think we just loaded 2022 and 2023 is what 2023 probably won't be finished until no earlier than the end of the first quarter of 24, right, Lisa? Yes. Lisa's our managed care administrator. She's our administrator for healthcare delivery, and which is the administration in which managed care rests.
Okay. Just introduce yourself for the record, Lisa.
Good afternoon, Councilmember Henderson. I'm Lisa Truitt, Director of our Healthcare Delivery Management
Okay,
Administration.
can you just move the mic just a little bit closer to you? There we go.
Is that better?
Yep.
Okay. The report, I'm sorry. The calendar year 2022 will be posted either later today or first thing tomorrow.
Okay.
And then calendar year 23, we're planning for a June date. But we have to validate, like Director Turner said, or Deputy Mayor Turner said, some of the data. So we're shooting for June, but it may be closer to September.
Okay. So we took a look at some of the information in terms of performance, and the report indicates an even performance among the MCOs on several measures. So one being diabetes care, with certain measures even worsening for one MCO. How do you hold the MCOs accountable when we're not seeing improvements in outcomes like this?
Well, let me make a correction. I'm sorry. You're talking about the annual technical report, the
Yeah.
ATR, and I think what Wayne just introduced was I'm sorry, Deputy Mayor Turner just introduced is the managed care report that we do on an annual basis. So, and you want to know how do we hold health plans accountable?
Correct.
So we have a staff, a team of folks within our Division of Quality and Health Outcomes. There are regular meetings that occur with the managed care plans, discussing these outcomes, what the data shows, talking with them about their interventions, and then working with them through what's called a compliance continuum. So there starts from recognition of opportunities for improvement, and then following through to for the health plan to identify some interventions to try to improve, set some goals for improvement. And then through those recurring meetings that happen with the health plans, we're monitoring information, we're looking at data, health plans are providing data to us, and they're letting us know the outcomes of the strategies and interventions that they put in place to reconcile some of those outstanding issues.
Okay, so I appreciate the plans and the conversations, but I mean, even on prenatal and postpartum care rates for 2021, like they declined past the 2017 baseline. So we're like hustling backwards. So what's the corrective action?
So a part of it is just being aware of information immediately. Health plans don't always have immediate access to information. A lot of it is done through some of the billing. So, and when you look at the timeframes that we're looking for, if the information is provided at a later point, those outcomes are going to be displayed as dismal. That's not the total reason for some of the, I guess, poor outcomes. Obviously, we have to look at the population that we're serving, right? So some of the metrics are around the number of prenatal care visits that are completed.
Right.
And you have to have the participation by the beneficiary, right? So there are a lot of incentives offered for beneficiaries to complete services, those preventive care services. Incentives are given to them, but when they're simply not participating, health plans just don't have any other options but to rely on the data. They're doing the outreach, they're doing what they need to do, but there has to be those willing participants to support those efforts as well.
If a pregnant woman has a delayed visit to her physician, the managed care plan might not even know that she's pregnant.
Yeah.
And so then the onus, it's not entirely on the beneficiary, but we need them to sort of cooperate and go to seek prenatal care. Once that claim hits, the MCOs can dive into action. But the claim never hits, You know, they don't know the person is pregnant.
I recognize that as that, right? I think we, in lots of phases across the government, having conversations around what is the level of personal responsibility in terms of the resident or the individual, right? We could pay for your healthcare coverage, we can make access available, but we can't actually make you go. Like, what do they say? You could like lead a horse to water, but you can't make it drink in that similar way. But at the same time, we pay these MCOs money to do the care coordination, outreach pieces. And in the instances where we're not seeing any of the needles moving, I'm just curious, like, how are we making sure we're getting our money's worth?
I would say that the health plans are doing all that they can, meaning they're not slacking and saying, we've done this, but there's no results. We're not moving the needle, as you mentioned. They're not targeting a single option. They're putting in various initiatives. And I
Okay.
would add to what Deputy Mayor Turner just said around the billings of the health plans, understanding or becoming aware of some of the services after they receive a claim. Providers have a full year to bill. So it depends on how quickly those claims come in. Most often, they're not waiting for the entire year to submit a claim because they want the payment, right?
Yeah.
But in some instances, if those claims are coming in a little bit later, and it's past the timeframes for some of these, the specifications assigned with some of these metrics, you're gonna have those lower outcomes because it's just simply not falling within the appropriate timeframes.
Yeah, I totally understand. I just, and I don't think it's healthcare finance or the MCOs to do alone, right? We had a long conversation with DC Health around their role as the public health agency to put out more communications about marketing any number of things around healthy habits, right? I think something like 40% of the people who go into UMC have diabetes, like who visit. That is their patient population. When we look at the number one cause of death in the District of Columbia, it's heart disease, right? So it's health related things. And so to the extent that we are doing all we can to inform folks, and in some cases, I know it's hard because we're asking a 50-year-old to change behavior, to stop eating the way that they ate when they were 20, but
Yeah.
these are the things that we kind of have to put in place. Okay, let me ask about some of the SPA and waiver things that you guys are planning. And it was very, very interesting to see that you all are planning, anticipating, however you want to put it, a SPA waiver to cover certain weight management drugs. Is this
Well,
Wegovy, Ozempic situations?
let me say two things before our policy director, very good policy director, chimes in. Anything that we are planning that creates a new cost, those plans can be derailed if the budget doesn't look right.
Yeah.
So we constantly plan because we want to make sure we have a modern and effective Medicaid program. Sometimes what you see as plans have not reached the stage where we've sought approval from EOM. And so a big part of, whether or not we go forward with anything will be, well, when this guy tells us what the fiscal impact is going to be, and then if we look at that and say, geez, how can we ask for money if the budget is X? And then we may decide not to go forward with it, but Eugene can give you some details on it.
Okay.
Particular spot.
Chairperson, I want to clarify one thing I said earlier. I said that DHS was back as of last week, 4 days a week. That's 3 days a week. The 4 days a week, of course, will come later for all.
That's what I thought it was coming later.
March 10th.
Yeah.
It's my daughter's birthday.
Yeah.
So I'm waiting.
But yes, so, as the deputy mayor said, it's all budget reliant. But we were looking at coverage of weight management drugs, like I think I'm not a clinician, Ozempic, Rybelsus, those types of drugs. I think obesity has some negative externalities as it relates to health. So if you could, if through coverage of weight management drug, you could reduce those negative health outcomes.
Oh, you don't have to convince me. The thing that is, we have gotten several inquiries for us to do this on the private insurance side. that we've kind of pushed off because for a variety of reasons, we're researching into the various pieces. But if you guys move forward on the Medicaid side, then that puts pressure on us to, so I'm just trying to stay aligned again, as sort of this piece about parity. Because if you do this, then my emails most certainly will be popping for us to do it on the private insurance side too.
Well, go ahead.
An added complexity is that Medicare does not cover these drugs as of yet, so potentially shifting more costs to us, which might not make it as economically feasible.
Okay, so CMS hasn't said these are okay for coverage
On
yet.
the Medicare side yet, no, they have not made that
On
determination.
the Medicare side?
Medicare, the 65 plus.
Yes.
Yeah.
Okay,
But Medicaid does allow for this in there.
Yeah, we have, at the state option, Medicaid programs could cover these. However, if, someone's dual eligible,
Right.
they'd have to seek these.
got
drugs
it.
through Medicaid
Okay,
only.
okay. So CMS has approved it for the Medicaid population, not for Medicare yet, but it's possible.
Right.
It's possible they added to the Medicare formulary, yes.
And they're not added as a mandatory benefit.
Yeah,
So-
they're not going to add it as a mandatory benefit that states will have to cover. States at their option could seek an amendment to their state plans or
Okay,
their formularies to cover these types of drugs.
And if you tell us to do it, you should say, the mayor may
May.
seek an amendment.
we'll get there. We'll get there. Okay. It's just an interesting thing to know. Let's just keep in contact in terms of if you guys decide to move forward. I prefer it not to be a surprise on our end. Okay. You all anticipate implementing a community violence prevention benefit in Medicaid, beginning October 1 of 2024, which would cover Cure the Streets, violence interruption, and hospital-based violence interruption. How will billing work for these programs?
Yeah, you can go ahead.
Great question. It's being developed at this time, and I can't go into details, but what I will say on this front, for the hospital based, it will be much more straightforward in terms of hospitals or current Medicaid providers are
Right.
very accustomed to billing, claiming, et cetera. I think for those community-based organizations that don't have a relationship with Medicaid to date, they may through other services. If they are stepping into the claiming billing space for the first time in my own history, that's usually a big lift, and we will have to work closely with those providers to be able to assume that responsibility.
Okay. All right. We noticed that the list of anticipated / possible / maybe waivers and spas for FY 24-25 does not include medically tailored meals for patients with chronic conditions. This was a proposal that was included in the No Senior Hungry Omnibus Amendment Act. I think this was a bill from Councilmember Bonds. Che. Councilmember Che, former Councilmember Che. Why is this not included? And is this something that healthcare finance is considering?
Meals and nutrition is something that we are considering in the context of the 1115 waiver renewal.
Okay.
And we are our focus has been on existing programs where we could maximize federal funding to support those.
Okay. So speaking of the 1115 waiver, the produce prescription pilot program is part of that. And we've been operating it for the last several years, although it was intended to be a pilot. What's our thoughts in terms of making this permanent?
That is one of the things under consideration as well.
Okay. Do we have outcomes that we can demonstrate its
On
effectiveness?
Produce RX, we do. We have the reporting, I think 2 or 3 years of reporting, and we've had generally positive outcomes that I think, depending on how the waiver renewal, the pathway we go on that, I think will be supportive of the work to date.
Okay. All right. So last year, the council passed the prior authorization reform bill, which establishes guidelines around prior auth for health insurers must follow. The healthcare finance estimate total cost was 9.7 million for MCOs to implement the new guidelines. But I think you all mentioned hang on, that there was some change in prior auth that CMS put in place? Or did
The
I get
federal government, at least at the time of the hearing or discussion on the bill, had, I think, a pending rule. And I just can't recall if it's been published as final or not yet. But they had changes that, I think in some cases aligned with the district legislation, and in some cases, the federal was still more liberal than the district. Like I think the federal allows like 7 days for PA, and I think the district is 3 days, maybe. Could be remembering that wrong.
I don't remember off
So
the top
some
of my head.
differences. And I think the implementation timeline on the federal side is 2026.
Okay.
So we can follow up on specificity if that's helpful.
Okay, it might be helpful just if we could sort of figure out the alignment issues. I don't mind us being more progressive, if you will, than the federal side. But I also feel like this impacts our FIS a little bit in terms of us being able to implement it and move forward. And I want to try to resolve that because for the private side, it's already law. So, you know, if you have private insurance, you're already, well, will soon be getting the benefit of the earlier timeline schedule. And I just want to make sure that we're not letting it linger out too much, especially on the Medicaid side. And certainly when we look at the MCO rates of prior authorization and how in some cases they're aligned and pretty much the same. And then in some cases, I've got some outlier MCOs. Like I mentioned, you know, for urgent determinations, you know, AmeriHealth Caritas is taking 72 hours for something that's deemed urgent, whereas everyone else, minus HSCSN, is only taking 24 hours. So if nothing else, can we get our folks to align in their prior auth? I think would be helpful. Okay. Speaking of that, so when we were considering that legislation, you all asked the committee to include a 14-day window for long-term care prior authorizations under Medicaid. But according to the pre-hearing responses, the current range for long-term care prior authorization timelines is between 1 and 11 days. So why did you guys request way more time than what is necessary?
That was Catherine Rogers to come up and respond to it.
Okay. Like right now, so AmeriHealth Caritas is taking 1 day, AmeriGroup is 3 days, MedStar Family Choice 3 days. HSCSN is the one that's taking 11. So why did you all need 14?
Good afternoon. I'm Catherine Rogers. I'm the Director of the Long-Term Care Administration. Prior authorization for long-term services and supports is what I would describe as a multi-step process, and often involves things like a full face-to-face clinical assessment rather than receiving, you know, a form and approving a service. And so generally we wanted to reflect that there might be time required to receive all necessary documentation to ensure that authorization for long-term services and supports, which are often by their nature and by definition required on an ongoing basis, and we might be approving them for a long period of time, like up to a year at a time.
Okay. All right. Let's talk about Comagine. So at the Department of Healthcare, nope, that's y'all. The Department of Behavioral Health hearing, this came up quite a bit in terms of utilization approvals specifically for residential treatment. And so I'm curious, what was the impetus for us to use a third-party utilization manager?
So we have, as the Medicaid agency, we're required to have a quality improvement organization. And for us, that is Comagine. And so for some of our fee-for-service services, they do our prior authorization review and approvals for services. We added the responsibility for the SUD residential services to the Comagine contract just to have it uniform, because For SUD residential, because of the 1115 waiver, we can cover those services. The first 15 days go through the managed care organization. Anything longer than that is going to come to us. So we wanted to align those processes as best we could, and then also have the same process on the fee-for-service side. So that's why we brought in Comagine. The criteria that we use for that, the ASAM criteria, which is like I can't give you the full acronym, but it's really the Society for Substance Abuse Management. It's there, that criteria was in place prior, but then we went to Comagine to have them implement it for us. Working with
Okay.
DBH.
Are there regular meetings and communications channels between you guys and Coimagine to facilitate and address ongoing concerns?
Oh, yes.
Okay.
We have a contract administrator that sits within Lisa Truitt's shop. And then I will say that when we first implemented or attempted to implement the change, we moved swiftly into a soft launch because of provider capacity to meet the documentation, improved medical necessity so that we could actually approve the services. So I think that soft launch period was about 18 months. There was a lot of one-on-one and group technical assistance between our staff, DBH staff, Comagine staff with the providers. And then we finally went to effectuating the change permanently, which means they could be denied the authorization in November of last year.
Okay. Does Coimagine compensation as part of their contract, is it tied in any way to saving residuals from denials?
No, it's just for per prior authorization. And, you know, the one thing I have to say, and we've had this discussion with the providers, they say Comagine, but it's the criteria. The criteria is not determined by Comagine. The criteria is determined between, I believe, the ASAM and then the clinical or directions that we give between DHCF and DBH. Comagine implements what we've asked them to implement.
Okay. I just, you know, I hear from a provider, right? And I'm thinking about just a rational human being who's going through a residential treatment. The idea that somebody can get it together in 14 days, if the first 5 days are you getting stabilized, it just feels like we're cycling people in and out.
So I will do my best, but I have limitations on what I can speak to. It doesn't mean it can only be 14 days, and it doesn't mean that's the only level of service. It is that we are asking providers to show that someone meets the level of care needed for that service. And if they don't, there's, you know, this is usually specific to ASAM 3.7, then they can go into 3.5 or 3. There's different levels. I think what providers were accustomed to is that prior to bringing over into the Comagine or through our agency utilizing Comagine, they were accustomed to 30-day authorizations. You know, and that is different than having a 14-day biweekly progress report, making sure folks are meeting that medical necessity so we can ensure payment.
Yeah. I think this is, I want to dig into this more, not necessarily here, but also with Department of Behavioral Health, because I feel like there's a larger issue here too, right? In terms of discharge appropriateness out of these types of programs. Discharging someone from a residential treatment facility into a shelter, in my opinion, is not an appropriate placement, because that means like 9 times out of 10, they're going to be back again, given that environment and what's happening there. And it feels like we don't have a comprehensive step down ecosystem. So maybe you don't need to be at the residential treatment facility, but maybe you need to be in sober living, or maybe you need to be in some other type of.
I think the supports, I do think, and this has come up through the opioid abatement commission meeting, certainly in the treatment and recovery subcommittee that I sit on, is that housing component. And even though we have sober living available, maybe there's a living opportunity that someone's not ready to be sober yet, but they're moving into recovery, right? So I think, to your point, those conversations in the commission, I think that would be a good one to keep discussing with that group and what supports are needed for the city on that.
Okay. In terms of the utilization prior auth stuff for Comagine, I imagine it's not just for residential treatment. So what other types of things do we use them for?
So correct me if I'm wrong, but it's like hospital prior authorization when needed. We just shifted out of the nursing facility, correct? And go ahead.
Well, I don't think I have anything more to
Okay.
add to what you're saying, but I want to finish this, but sorry about that. I do want to follow up on what you were asking about the health plans and the prior authorization timelines, but if you want to finish with the Comagine, I don't want to interrupt.
Oh, okay. So just so residential treatment, hospitalization,
Mhm.
and there was a third one?
No, we just shifted from the one that she was going to reference.
We used to have CoMagine do something called continuing reviews for nursing facility placements, and that's shifting over to a different contractor.
Okay, so they don't do long-term care. Oh.
Okay. And then also, just so you know, the QIO is a contract that we procure on the same schedule as everyone else. And I believe we have to have CMS certified QIOs as well. Go ahead.
CoMagine does authorize long-term services and supports. All of our home and community-based services and supports under the fee-for-service program are authorized by CoMagine, and they also perform quality reviews of the service planning for the EPD waiver.
Okay. And this is all on the same contract for all 3 areas? Yes. Okay, great. All right. Okay. Making some progress. I told you guys, we only had 3 more. All right, let's talk about behavioral health and those pieces. We started a little bit. Okay, so one of the things, and Mark Lavoda in his testimony kind of brought this up, was that a lot of the providers feel like there are a number of policy decisions that have not yet been made, and therefore they're uneasy about the transition because certain things haven't been decided, like who's gonna manage appeals, for instance, and those kinds of things. Are you all putting pen to paper to try to answer some of these questions for providers? I know, Dr. Bazaran says she's in constant contact with you guys about the transition, but they're, at least from the providers, they feel like there are still some big existential questions that have yet to be answered.
That may be true, and I can assure you that those questions will certainly be answered if necessary.
If necessary.
Yeah.
Okay. We're supposed to do this on April 1st.
Mhm.
It's February 8th. I think a question about who does appeals is if necessary response, yes?
Go ahead.
Okay.
If a managed care benefit, if a beneficiary is enrolled in a managed care plan and they want to appeal the denial of a service or the length of the authorization, or the provider has a disagreement about a decision, the managed care plan is responsible for those appeals.
Okay. Are you guys, who manages the website that basically has the FAQ for providers who have questions about the transition?
We have a joint DHCF website, bhintegration.dc.gov. And that's where we have some of, I think our informational bulletins are on there. They link to our transmittals that speak to rate issues, which are be separate from the carbon and so forth. And also links to our public forum meeting minutes and information as well.
Okay.
And then each of the plans will have each plan has their own provider. Well, they have their own website, and they always have a provider component of it as well that speaks to the specific policies and contacts for their own managed care plan.
Okay. You guys have been like super confident throughout this whole process, but then I have the providers who are like freaking out. That from payment questions to appeal questions to all the pieces. And I know change is difficult and nobody really likes change. And so I'm trying to manage here of you guys sitting before me feeling very confident that this is still the right move, where the providers are like, and advocates feeling like, oh my gosh, my client is going to get dropped through the cracks here. What do we say to those folks?
I know April, what's the date? April, the official date?
April 1st.
April 1st seems to be right around the corner. The perception is there's a lot to be done that can't fit within that window. We probably share some of their perception, but the reality of it is, any situation that we're faced now that creates significant costs will have to be a part of a budget deliberation that is yet to come.
Okay. This is the joy of performance oversight hearings. We have opportunity for questions, more questions, and frankly, another hearing if we need it. I hope we don't have to have another hearing
All right.
on that. Okay. Still sort of in the SUD world. Well, no, a little bit different. So providers have expressed concerns about the assertive community treatment model, the ACT model, and the recent changes requiring specific staff members to have to make a total of 8 contacts, with 5 being in person. How does healthcare finance intend to monitor the implementation of this new model and assess whether the shift is the right approach for delivering services to this particular vulnerable population?
Sure. So from the clinical perspective, I'd have to rely on my colleagues or within DHCF or DBH. But what we've been doing since we launched the revision of the ACT payment methodology and service expectations, again, has been a transition period since I think September, with every 1 to 2 months expecting providers to get to a closer level of meeting those expectations. So off the top of my head, if we said, you have to have 8 QP, qualified provider touches or contacts, then the first month we would, or first couple months, I think you only had 1. You'd have 8 contacts total, but only 1 with a qualified provider. So we tried to kind of stair step it to March 1st for a few weeks, where we are expecting them to meet kind of what is called fidelity at that point in time. So the Behavioral Health Association has been working with providers to collect that information. We had a joint meeting with the ACT providers and Department of Behavioral Health, the association, and DHCF in December. Went over the first data from that. And then I was speaking with the association yesterday, and they will have like their next round of reporting to us. I think Mark said in the next week or 2. So that's how we're monitoring it at this point in time.
Okay. So is it going to be a situation though, if I had 7 contacts now, I just don't get paid? Because I
Right
feel like
now?
that's setting up a
No.
reverse incentive.
Well, and this is when it gets to the clinical piece, the expectation and the design of assertive community treatment. I know the way Dr. Bazran speaks to it, it's a hospital without walls. So it's a high level intensive treatment for an individual that's supposed to support them. So interacting, I think, with a provider 8 times, from a layman's perspective, I don't think that's asking a tremendous amount, particularly given the level of care and the folks with the kind of serious mental illness that we're talking about here.
Okay.
But I would ultimately defer to DBH and the clinicians within DHCF to speak to that.
All right. Starting April 1st, Alliance beneficiaries are supposed to have access to behavioral health services for the first time.
Well, they have access now. It's locally through the Department of Behavioral Health. The difference is bringing those services into their benefit under the Alliance program. So if they don't have an Alliance, they still have access to it because the Department of Behavioral Health provides those services to district residents.
Okay. So as we bring it in, would someone expect would their provider change?
What we have agreed to and announced at least well over a year ago with providers is what we're calling bridge policies.
Okay.
And so that's to help the transition, because we understand this is a significant transition. And one of the bridge policies is that the managed care plans are required to contract with all the certified Department of Behavioral Health providers for the first 18 months of the carve-in. And so that, and the certified providers are those that exist today. So that is ensuring you have that same provider network going forward for at least the first 18 months.
Okay. Speaking of Alliance, we had a public witness who testified today about glitches in their system. It was very different than the HSCSN, but they are a clinic provider. They look in their system, they say somebody doesn't have it. They call ESA and ESA is saying, no, their person is good. Or they need to resubmit an application, even though in the system it says their renewal is not for 2025. Is this something that you all can look into?
On the first piece, what I can say is that We have, I think, mostly resolved the issue. So our eligibility system, so if I'm the beneficiary looking at, yes, I see eligibility. Our DCAS has to share that with our provider system, MMIS. And we found that that was not always transmitting the way. So if I'm a provider looking into the MMIS or the provider portal, then like they're not seeing the correct information. We have addressed that. What we are not sure is happening right now is as people are still raising that issue, is it just an issue of the timing? Like, so maybe we do this on Monday, but the MMIS system's not showing up for Wednesday. So we're continuing to look into it. But
Okay.
that's the norm, been the discrepancy to date.
All right. Before I turn to questions on maternal health, I'm going to just run through some of the things that people brought up in public witness testimony. Dr. Janet Phoenix brought up including asthma assessment in the 1115 waiver. Have you been a part of those conversations?
It wasn't a conversation. I know Dr. Phoenix said she responded to our request for information. I received an email from her, I think it was last week. I've just forwarded it to the team that's focused on the renewal, and then we'll follow up as based on her testimony today to have that discussion.
Great. Okay. A delay in approving funding through the Services My Way. I think Ms. Case talked about, providers not getting paid for months on end.
Sure. So Catherine Rogers from our Long-Term Care Administration is going to come up and talk about Services My Way, which is the participant directed worker program, and can speak to some of the issues that were raised earlier.
Okay. You're on.
Thank you. I think I didn't turn it off when I left the last time.
I knew you were coming back.
So yes, Services My Way is the participant directed services program under the EPD waiver. We also now just recently, and I learned today, we have our first enrollee in participant direction under the IFS waiver, which is great. That's the first time we've covered participant direction under the IDD and IFS waivers. Our program is, I think you probably understand the basic outlines of the Services My Way program, but in participant directed services, the individual has more autonomy or authority to sort of hire and fire people of their choosing. How much they pay, the hourly wage rate. They work with support staff essentially to create and approve a budget, approve time. They approve time through our electronic visit verification, just like our home health aides.
So the person who is receiving the care is basically directing all of the pieces that they otherwise would have gone to a home health agency to do.
That's exactly right. And
Okay.
they are serving as the employer. And so because there are a lot of, resulting obligations on the participant who's otherwise, is an enrollee in one of our waiver programs, but they're called on to serve as the employer and do all of these things that otherwise we would have a Medicaid provider serving in that role. We have a contracted entity who performs a lot of the administrative functions. So processing payroll, processing taxes, facilitating a background check on their enrolled staff, making sure they have training in first aid and CPR. Individuals who provide care under participant direction are not required to be certified home health aides like DC Health and DHCF regulations require that services delivered by a home health agency are. So they could hire a family member or they could hire a neighbor or whomever. And so they have to meet these other requirements, but they do not have to be a certified home health aide.
Okay, so in terms of if there's a delay in payment, what would be the
Yes.
cause of that?
So that process, so all of those administrative functions, we have a vendor who performs them. The current vendor is GT Independence, and they are performing myriad functions. One of those functions is there's a support broker assigned to every Services My Way participant, and they help them or their legal representative complete the budget and all of the paperwork that's required in an annual certification period to ensure that they know how much they're going to pay each person, they know who's working for them, they have an emergency backup plan, et cetera, all of these things that we do on an annual basis. The budget effectively is what triggers a prior authorization. So to tie this back to a prior question. So typically when there's a delay in the authorization of a budget, there are a number of steps. The budget is, you have to develop the budget and the participant has to sign the budget. Sometimes there's back and forth on so-and-so is getting paid this much, but this other person is only getting paid this much. There are discussions that are part of that, that happen every year because there's an annual budget. Any delay in completing a renewal, as we were talking about renewals earlier, could also push this process into the upcoming year. Sometimes we have the budget signed and approved and the beneficiaries signed off and everything. And then on our quality review of the budget, we determine something is miscategorized or entered incorrectly. And so we're doing additional QA layers on that might cause it to be kicked back as well.
How many people participate through the Services My Way program?
I just entered this in a web form a few days ago, so I should know right off the top of my head, but I believe it's between 16 and 1,700. And that is across 2 delivery systems because individuals in dual choice, our integrated DSNP, can also participate in Services My Way.
Okay. Similarly related to the conversation of Services My Way, but we heard lots of testimony about healthcare finance restricting home health aides to 17 hours, 16 hours, 17 hours, and then also no longer doing overtime.
So on the first issue, what it is, we offer home health agency or PCA services through state plan authority up to 8 hours. If you are in the EPD waiver and you go through your level of care, you need additional hours, you can get up to an additional 16 hours, right? So that's 24 total. If you are in the EPD waiver and you are participating in the Services My Way program, you can also get up to 16 hours because that's what the waiver allows. The waiver does not allow 24 hours. You can get 24 hours if you need it, but your 8 hours, 8 of your 24 has to come through the state plan authority, which is not participant directed. So if someone is in Services My Way and they need 20 hours, then 16 can come through their participant directed worker and 4 will have to come through a home health agency. And this was required to us by CMS because they said you could not offer one group under the waiver up to 24 hours, I believe, while you're only offering another group 16 hours. And so our state plan, so it's an authority issue in what's allowable and making sure folks are treated the same, state plan and waiver.
Okay. Even though administratively, if you can imagine, let's say you are a person who's doing Services My Way, you need 20 hours. You have to now deal with a home health agency for that additional.
Yes, but you do have a case manager through your EPD waiver program, and part of their job is to help you coordinate that care and get an agency that you agree, help you select an agency and bring someone into your home.
Okay, but let's talk about that. I look at the numbers from DC Health, the number of people who are going through the certification process to become a home health aide or a CNA in the district has gone way down in FY23. So we have less people to provide the care, even for the required number of hours. And when you have that, that's when the overtime came in. But then we limited overtime or got rid of overtime.
So the overtime was in response to the public health emergency and was put in place so that if a beneficiary was diagnosed with COVID and they needed an aide to essentially quarantine with them or work overtime hours for their care, that allowed it. It was not meant to be a permanent allowance of overtime that would be paid for. When it was referenced earlier, we chose not to take the Appendix K waiver to continue the overtime. That waiver option was only allowed to states that were going to make the overtime function permanent, which was not something that we selected to do. So that waiver really wasn't applicable to us. Angelique can speak to how our rate is and where, there's nothing that precludes the provider from paying an individual aide overtime if they so want.
Through the process where we've been working with and giving providers ample time to work out how they were utilizing overtime, and we've had multiple meetings with them. And the reason they're using overtime isn't necessarily just because the workforce shortage. It is also because it's harder for them to find personal care aides that will travel to a certain place because of transportation needs, because of parking issues, and there are other reasons why as well. And so we continue to try to work with them to resolve alternative ways to deal with those issues so that they're able to get aids to provide the care across anybody who needs the services. So we work with them on transportation. We set aside money in our ARPA plan to do a transportation initiative. We've also worked with them and DDOT to try to make sure that the PCAs are aware of the current process where they are able to get placards and parking passes. It's been in existence. They may complain that it's inconvenient because they have to have a driver's license, but they're driving, so they have a driver's license. Sometimes it also includes the beneficiary to be a part of it because it's the beneficiary's residence.
Yeah.
And so they also have to have a state ID. And so there is a process, but Catherine and her team have been working closely with DDOT and including them in meetings. So when we think of the use of overtime, we're trying to figure out how to help that.
Okay. Complaining about having to have a driver's license, but you're driving. Yeah, that was, okay. Understood. All right. So one of the things though that I've heard is that when we had the waiver that allowed for CNAs and home health aides from Virginia and Maryland to work in DC without having to go through the separate licensure process, that was helping. Why did we not choose to continue that? Oh, your mic's not on, Deputy Mayor.
Decision to not continue that has not been made, actually. I spoke to the.
It expired in November.
No, I mean, she said not to permanently. I mean, DC Health is looking at, under the new director, they're looking at all of the issues that were around waivers that no longer exist. And she has explicitly told me as late as today that she is not opposed to flexibility in that area. She has spoken to the stakeholders and she fully expects to reach out to them with a proposal in the very near future.
Okay. Well, that's good to hear because
Yeah.
that was definitely something that folks came to us about. They've been raising it well, frankly, they were raising it starting in September, anticipating that the waiver would be over in November. And so I would hope that we had taken a little bit, addressed it in a quicker clip, but it's good to hear that we are getting there. Overall though, so, the district has experienced, got like a 30% less number of people who have certified. Are these numbers troubling for you all or surprising for you? And we think about the number of seniors and the number of people who are trying to age in place in the district. It doesn't seem as though we have the workforce here to continue to manage it, especially if we continue to see these types of declines.
Yeah, I mean, the numbers are what they are. I mean, the capacity of an agency like DHCF to impact the size of the workforce is very limited. So those are issues, again, that stem from a number of factors, one of which I think DC Health will address by allowing workers who are certified in the surrounding jurisdictions to work in DC. But there are other issues that impact why someone who may be given to providing home care does not want to work in the district that we can't control. We simply can't.
Yeah. Okay. Skilled nursing facilities are reporting some severe spending pressures. And healthcare finance has previously estimated that it would need an additional $26.5 million in FY24, $8 million of which is local, for skilled nursing facility staffing in order to avoid negative repercussions. Is healthcare finance proposing this increase in the supplemental budget, or what conversations are you having with the skilled nursing facilities to address their pressure?
We have a strategy and we have proposed it to the executive office of the mayor. And, we will see how that goes. But yes, we have, their complaints have not fallen on deaf ears. We've tried to do what we can within the constraints that we are faced with. And we have communicated very clearly to the budget director and the city administrator that this is an area where folks are underwater.
Okay.
And they they fully understand that.
All right, so for the folks who keep asking us, you hear the director say they're acknowledging the pressure
Mhm.
and are working on a solution here. In your pre-hearing responses, Healthcare Finance estimated publishing the direct support professional payment rate study in April. And you attributed the lack of, the delay to the lack of data provided by providers. What percentage of providers haven't responded to your inquiries here?
So those are two different things. The rate study, we actually have 3 rate studies that are going on for the home and community-based. DDS has one.
Okay.
And then we have the home health one and the assisted living. Assisted living, I'm sorry, the home health rate study was signed, the contract was signed in October.
Okay.
And we've already started the process of implementing that. It's a 3-year contract with 3 phases that will help address some of those things. The enhanced payments are what I think you are referring to, where it is a requirement. We started in FY '23 with the enhanced payments to pay the 10%. We have paid over $70 million in enhanced wages across all of our providers and ICFs. In order for them to do that, in order for them to get the next set of payments in FY '24 or calendar year '24, they are required to submit a report. I will follow up with the percentage of providers that that have not submitted their reports, but we've constantly met with them, and we're spending an additional $62 million on enhanced wages in calendar year '24. So that they're able to pay the average of 17%.
Okay. Okay. All right. Let's talk a little bit about maternal health and how some of the things are going there. Healthcare Finance reports that we have 101 nurse midwives and 4 doulas who are currently accepting Medicaid in the district. The nurse midwife number, is that pretty solid? I think hard to tell. 101, I don't know.
Solid and meaning like capacity?
Solid in that this is the type of growth that you were hoping to see in this area?
So usually when there is not enough growth or enough available providers, we usually hear about it.
Okay.
And I haven't heard anyone raise an issue about, I can't get access to midwife.
Okay.
So that's the best response I got.
But I have heard the issues about the doulas.
Yes.
All right. But you guys had a group that was working on this.
And then the last time we met at the round table in December, one of the follow-ups that some of the testimony that we heard from Ms. Jackson about, the provider application. We've done our first run through of trying to get specific and just really call out, this is what you fill out. So we'll be finalizing that. And then we'll be having the next maternal health advisory group meeting March 4th or 5th, I believe it is. And then that's when we're going to dive into that work a little bit more. And then we've had some internal conversations too, just kind of high level. It's like, okay, so we have doula services available. It really is digging into more of we know some of the reasons why maybe we're not getting enough doulas in. Is it other things? And it's I think the more challenging part of the implementation, but working through those.
Okay. What about the licensed certified professional midwives? Where are we on getting them in the Medicaid queue?
So DHCF continued its collaboration with DC Health. My understanding is that DC Health is planning regulations and licensure requirements for certified professional midwives. The responsible board is the Maternal Care Professional Advisory Committee. They've met
Under the Board of Nursing.
They've met a few times this year. I know their work is ongoing. They report progress. So when we have as they work toward finalizing those regulations, we of course would work in unison to develop our provider requirements, our service definition, et cetera, to bring it on under the state plan.
Okay. Okay. So under the Expanding Access to Fertility Treatment Amendment Act, For Medicaid beneficiaries, we were supposed to be expanding to allow for certain drugs to be approved. Has this happened?
That state plan is submitted to CMS, I believe, late December. It's pending their review. So we'll probably have word on its approval by late March.
Okay. Have you all had any conversations yet with CMS around standard facility preservation services for specific population of individuals? So for example, if you have a Medicaid beneficiary who has been diagnosed with cancer, and in order for them to undergo treatment for cancer, being able to preserve their eggs, but that's not something that CMS currently grants approval for, but I was wondering if we've had some conversations about the possibility of us being able to do it.
I think that piece is the piece that I think we actually cover. I'd have to check back with Dr.
We covered the cryo piece, but not the storage.
Okay. So much for your work on that front. Essentially asked us to rethink the home visiting proposal. Are you all not in favor of home visiting reimbursement?
I don't think the mayor's objections, although were based on a philosophical bent against home services. I think she was thinking more about the mechanism through which it would be funded.
Okay.
And then she also has some concerns about the encroachment into her authority by directing her to submit a state plan.
Sure, but the content of the letter for home visiting was different than childhood continuous coverage.
So I think for home visiting, it was more about the funding piece.
Correct. That's what I'm asking.
Right. And so we're not philosophically opposed to a home visit. I think there was a concern about, okay, do we want to continue to try to do, important policy by saying, well, if the money becomes available, it's probably kind of unwieldy. And it gets us in situations that we could end up like we were with gift snap arrays. That money comes available in the year before this thing is supposed to be triggered. Then when you get to the triggering date, situation has completely changed around the district's budget, and then you got to figure out, can we really go forward with a $40 million pressure in an agency, with a $40 million in expenditure in an agency that's $100 million on the water? That kind of stuff I think she's trying to avoid. And again, on the continuous eligibility was purely about her executive authority.
Yes. Which, yes. But on that, so let's say hypothetically though, I think that bill only cost child $3 million. Childhood continuous coverage was less than that. Childhood continuous coverage was like a few $100,000.
Yeah.
So let's say we found that money.
Or childhood continuous coverage?
Yeah. Are you
And
guys not gonna submit the SPA?
I think if the language is directive from the council, DHCF would have no legal obligation to submit that SPA.
Okay.
Yeah, but it's an easy fix.
Mm-hmm.
You just, stuff where you say shall, you said, where you said shall, you said may. And if there's something that the mayor supports, then she would submit it, or she would direct us to submit it. It's pretty easy. I can't believe this is drawn the kind of pushback it has, to be honest.
Believe it either, considering we seem to be aligned on the goal.
But now you will appreciate it when you become mayor, when you come. That
Be a state one day and everyone
will actually
gets
then
to
change-
participate in the Medicaid.
Then
So that should. Prediction